initiate a rapid and vigilant response to mitigate the outbreak, relying on all the strengths of her healthcare system.
Over 2,000 people were quarantined in the Malappuram and Kozhikode districts of Kerala, drastically softening the blow of a potentially much larger outbreak. After the 2018 outbreak, it had become clear that we needed to further bolster our proficiency in the fields of surveillance, epidemiology, and data analysis so that the public health sector can be better prepared in managing and responding to acute public health crises in the future. The second case in Kerala was picked up in Kochi in June of 2019. Not only were we able to save the 23-year-old student, but also prevent a second outbreak. In September of last year, a 12-year-old boy from Kozhikode succumbed to Nipah encephalitis, prompting an investigation and the possibility of a new outbreak.
As the philosopher John Dewey once said, we do not learn from experience, we learn from reflecting on experience. On that note, today, we've invited eminent scholars from various disciplines in the medical, veterinary, and scientific community to share their collective knowledge and perspectives on this ominous disease, so that we, as a healthcare community, can learn from reflecting on our experience, hence allowing us to be better equipped in tackling future outbreaks. Without further ado, I'd like to invite Dr. Vidya Kayar, Deputy DHS, onto the stage to introduce the program.
Good morning to all. It's with great pleasure and it's an honor for me to attend this, to stand before the August audience and to attend the first ever state workshop on Nipah. Actually, Nipah is a disease very close to our heart. It's in a good sense, but not in a wrong sense. Because Nipah is our first public health, not first, it's a public health success story. Actually, when the Nipah happened in 2018, with 18 cases and 16 deaths, with only 2 survivors, Kerala was shocked and Kozhikode had gone into a standstill. But with the concerted efforts of state government, then district administration and various central nodal agencies, we were able to control the Nipah. And in 2019, when the second outbreak happened in Ernakulam with 1 case and 1 survivor, things had improved a lot. From the experience and the learnings we had from Kozhikode outbreak, we did much better. And Ernakulam being the economic hub of Kerala, life had not come to a standstill, and with the increased awareness to the public and because of meticulous surveillance, we were able to control it. Then again, the third outbreak happened in 2021 in the midst of COVID pandemic. So, but with much improvement in our knowledge on infection control practices, personal protection measures, we were able to control that outbreak too. So in effect, over the years, Kerala had learned from the 3 outbreaks of Nipah, and we were able to do much better in controlling the outbreak. So the aim of this workshop is to equip our district health team from the experiences shared in this platform. So in future, if any Nipah outbreak happens in any of the other districts, they should be able to manage it on their own. We have an array of speakers today. both national speakers and state speakers, and also eminent moderators who have done their exemplary work in controlling Nipah in Kerala, and also our national team who had done in other states which had Nipah outbreak. So it's a hybrid meeting actually, with both offline programs, and also there will be a live web telecast of the whole program through our YouTube link, and some of our speakers also will be joining us online, and some of our persons who are participating in inauguration session also will be joining online. And I had the chance to call all our speakers and our moderators. Some of them are retired, and some of them are still working, and we acknowledge their services towards control of Nipah in the past 3 outbreaks. We also acknowledge the services offered by those who are not present here, who had done an exemplary work, both in the state government and also in the state health department, medical colleges, and also in the district administration, who had retired and who are also not able to be with us today during the first ever state workshop on Nipah. Now, when I called our speakers and our coordinators, moderators, they were very cordial to me, and all of them were very keen to attend our workshop. And many of them had traveled all the way from Trivandrum, Alappuzha, then Wayanad, and also from other districts. And we have with us as audience our DMO, DPMs, DSOs, epidemiologists from our health department side, and from the medical colleges we have public health specialists, microbiologists, and physicians, and we have our faculties from my friends from our animal husbandry department, from the forest department, and also from LSD department. And I would like to thank each and every one of you to make this workshop a success. And I would like to acknowledge the services, acknowledge the advices that has been given to us by our eminent faculties, eminent moderators in putting up this program chart, and also in putting up this whole workshop. I would like to acknowledge the services of District Administration, Kozhikode, DMOH Kozhikode, then NHM Kozhikode, especially Dr. Umar Farooq sir and Dr. Naveen. And also from medical colleges, I would like to acknowledge the guidance given to us by Dr. Sajid sir, Dr. Kuryakos sir, then Rajendran sir and Chandni madam, and also from various facets of life. So I wish everyone a very happy, enjoyable, informative, and interactive session on our very first State Nipah workshop. Thank you all. Thank you all. Thank you all the delegates for attending this workshop. Thank you. And also I would like to thank our national team. We will have a 45-minute session on viral outbreaks, panel discussion on viral outbreaks and preparedness by Director, National Institute of Virology, Pune, Dr. Priya Madam. And also Madam will be joined by our former ICMR scientist, Dr. Raman sir. And also we will have a separate session by Dr. Pragya Yadav. Madam is the scientist F of ICMR NCDC Delhi. And actually Madam's team is behind the invention and introduction of Covaxin in our country. So I welcome all our national speakers also, and also I welcome all the audience that is joining us through our YouTube link, and also our speakers who will be joining us through our Zoom link. Thank you all, and I welcome all of you again. Thank you so much.
Moving on to the first session on Kerala Outbreaks Experience. The session would be moderated by Dr. Kuryakos KM, former Head of Department, Cardiovascular Thoracic Surgery, Government Medical College, Kozhikode. The topics covered under this session would be State Public Health Response by Dr. V. Meenakshi, ADHS Public Health, District Public Health Response and Interdepartmental Coordination by Dr. Naveen A., DPM Kozhikode, Hospital Awareness during Nipah Outbreak Code by Dr. K.G. Sajit Kumar, Professor of Medicine, Government Medical College, Kozhikode, and by Dr. Matthews Numbeli, Assistant Surgeon, FHC Ayambura. Clinical Experience Sharing by Dr. Anup Kumar, AS Baby Memorial Hospital, Kozhikode, and Laboratory Setup by Dr. Kalpana George, Associate Professor of Microbiology, Government Medical College, Kozhikode, and by Dr. Nikhil NKPP State Nodal Officer. A note to all the speakers, the session would be for 60 minutes and each speaker would get a time limit of 7 minutes. So I kindly request the speakers to adhere to this time limit. I kindly invite Dr. V. Meenakshi to do her session on state public health response. I kindly request Dr. Kuriakos KM to invite all the speakers onto the dais. Dr. V. Meenakshi, Dr. Naveen A., Dr. K.G. Sajit Kumar, Dr. Matthews Numbeli, Dr. Anup Kumar, Dr. Kalpana George, and Dr. Nikhilesh. I kindly request you all to be seated on the dais. I kindly request Dr. V. Meenakshi to deliver her session on state public health response.
Good morning to all. Welcome to the first session of today's proceedings of Kerala Outbreak Experience, Session 1. Till May 2018, we had only heard of the Nipah viral disease when we did experience the outbreak. The aim of the session, as in the other cases also, is to share the experience learned from the outbreak, and so that to enable us to formulate guidelines for better preparedness in future outbreaks. So we have 6 speakers in this session who were all in the forefront of the fight against Nipah virus. First, we will have the presentation of all the speakers one by one, followed by a session for open discussion. I request the speakers to strictly adhere to the time schedule, that is 7 minutes for each speaker. So first we have Dr. Meenakshi, ADHS Public Health, to talk on the state public health response to the outbreak.
Good morning, all, and warm welcome to all. I'll be in a hurry because 7 minutes is allotted, so I'll rush through my slides. As you all know, the first ever Nipah outbreak happened in our state, among the South Indian states. Kerala experienced the first ever outbreak of novel virus disease, the Nipah virus disease, which is considered to be one of the highly fatal emerging zoonotic disease globally. The disease was previously reported from countries like Malaysia and Bangladesh from 1998 onwards. Malaysia and Bangladesh from 1998 onwards, and also recurrent outbreaks have been reported from various parts of West Bengal in India from 2001 onwards. But in South India, this was the first instance, and Kerala's disease surveillance system could detect the outbreak in the shortest possible time with timely support from a reputed private lab from Karnataka state, the MCVR. As we all know, the 3 districts were affected. In the first outbreak, Kozhikode, the hosting district, was affected. Kozhikode and Malappuram also affected. The second outbreak in 2019, Ernakulam district was affected with 1 case. And again, the third outbreak in 2021, Kozhikode district was affected. And regarding the first outbreak, a private tertiary care referral hospital at Kozhikode on 17 May 2018 reported a cluster of 3 acute encephalitis syndrome cases who are admitted in the critical state from the field area of PHC Chengarote. The elder brother of the admitted person was also died due to similar illness 15 days back at Government Medical College Hospital, Kozhikode. All admitted cases were epidemiologically linked. They were all relatives, close relatives, and the health system of the state was alerted, and samples sent to Manipal Center for Virus Research and tested positive for Nipah and on 18 May. And it was further confirmed at NIV, Pune. Information regarding the response, information on a novel virus was high, with a high case fatality rate. High fatality potential was shared with our Additional Chief Secretary and Principal Secretary Health. Followed that, the information was also shared with our Honorable Chief Minister and also the Chief Secretary, and the state level alert was issued. The Director of Health Service, State Surveillance Officer, and a team of officers from the Health Directorate moved to Kozhikode suddenly, and incident management system was set up at state headquarters, and also a control room and special Nipah cell was constituted in Kozhikode district headquarters. The Director of Health Service convened district RRT meeting with the officers from the case reported hospital, the senior officers of Government Medical College Kozhikode, then district level program officers of DMOH, and health officer of Kozhikode Corporation, representatives from IMA, IAP, and also other related technical officers from different departments. Then the thrust was to prevent further human-to-human transmission by strengthening the infection prevention and control activities in all hospitals. That was the thrust. The honorable, the political, as we all know that in Kerala, the political leadership and the strong will of all politicians is the driving force behind. The Honorable Health Minister, Shailaja Madam, and also other 2 ministers, that is Ramakrishnan sir and also Shashindran sir. They were all camped in the district and monitored the activities on a daily basis. The consultative meeting was held with technical experts of the district. Then meeting was also concerned at the Panchayat community hall of the affected area to sensitize the local community leaders and to ensure their full participation and cooperation for ensuing preventive measures like contact tracing, isolation, then quarantine of all close contacts of the confirmed and suspected cases. Honorable CM also conducted an online meeting on 3rd June and reviewed the activities. Then this is the multidisciplinary system, this Nipah cell, which is constituted at Government Guest House, Kozhikode, as per the direction of the then District Collector, Sri U.V. Jose, sir. Then I think Dr. Naveen will be elaborating on this. The multidisciplinary system was, one technical advisory group was there, then data management team, media cell team, logistics cell, then 24/7 call center, special administrative wing, then district police department and also the IT wing, then transportation team, dead body management, which was the very challenging this thing, and also there is sample collection and transportation team. All these teams worked in a very coordinated manner to contain the outbreak. Then the state control cell at State Surveillance Unit at headquarters. The State Nipah Prevention and Control Cell established at the Health Directorate, special state RRT meeting convened, and interim Nipah response guideline was formulated by the experts, and it was circulated to all districts with a special focus on the northern districts, which is in close proximity to the affected district. Then Central Surveillance Unit and the Ministry of Central Ministry was also informed on a daily basis the sequence of events by the State Surveillance Unit. Expert teams from Delhi, Chennai, Pune, and Manipal reached Kozhikode district for on-site assistance and evaluation of activities. The training module was prepared by the State Training Division of NHM and disseminated to all districts. SOPs and formats for contact tracing sent to all districts. Logistics by KMSL, that is the very challenging activity. Sufficient quantity of N95 masks, 3-layer masks, PP kits, cleaning lotions, hand rubs, IV fluids, medicines, especially the ribavirin, and even monoclonal antibody was also mobilized and stored in the Kozhikode Medical College, and it was in a very short span of period. That was the remarkable thing. Regarding the outbreak, there were total 19 cases, including the first index case, which was not confirmed. Actually, 18 lab confirmed cases. Out of that, 11 were males, that is 58%. Then out of this 19, 17 died. That is 16 lab confirmed cases were died. The CFR was 89%. Median age was 32 years, ranging from 19 to 75 years. Median incubation period was 11 days, and median duration between admission and death was 2 days, and median duration between onset and death was 7 days, and total of 337 human samples were tested. No new cases after 26 May, and the surveillance continued for 6 weeks, and closure of outbreak was done on July 7, 2018. And this was the coordinated public health response, the state and central ministry, then the laboratories, NIV, MCVR, wildlife division, all departments actively participated, the private sector, all these civil society, local self-government, all. The strategies, multidisciplinary RRT investigation, war room-like control room, then index case and model spread was established, the first case. Then the major 3 hospitals were the point of transmission, the Balusheri, then Talu Hospital, Balusheri, Chengarut, and the medical college. Laboratory confirmation was done by special team with the support of MCVR and NIV. Then isolation wards, contact tracing, quarantine, and safe transportation, all these were arranged. Single institution for best, that is the Government Medical College, Kozhikode was the single institution. Then infection control measures, safe disposal of dead bodies and biomedical waste. The complex challenges faced in the first outbreak was the source of infection was unknown, and the spread through healthcare facilities, which was really challenging, and logistic gaps were there initially. Then handling of dead bodies and burial, then post-traumatic stress, no specific drug was during that time. Then contact tracing, isolation, and quarantining, really a challenging activity. Then social media harm, as we all know. then panic reactions among the community and also the staff. The elements in outbreak response was strong political will and leadership to address all public health emergencies. Then high quality leadership and managerial skill of health and civil administration. Health systems resilience to adapt to any emergency situation. Then optimal use of public-private partnership in laboratory surveillance in the state. Then commitment and result-oriented approach to hospital infection control practices. Community participation and cooperation among during a critical situation. Then skillful management of the media during the outbreak situation. Media helped a lot. Then positive response of the media persons in alleviating panicky moments. Effective use of digital technology of police department in responding to adverse social media reports. Then crowd management in hospitals, community panicky reactions, all these were tackled by the police department. Then motivational skills of the health administrators to facilitate optimum functioning of the workforce, which is again remarkable. Then tremendous support from the Government of India, WHO, CDC, ICMR, NIV, NIHNA, and all, and the Department of Animal Husbandry and Veterinary Sciences University. The second outbreak, 2019, a 21-year-old male resident of Vadakekara Panchayatha, Ferikara CSC of Ernakulam district, that was reported to again a private hospital. Before that, he was taken to 2 or 3 hospitals, but finally on 30th May, with headache and fever, and later showed features of encephalitis. Suspecting Nipah virus infection, his samples were sent to the lab Exciton Bangalore, and it was further confirmed at NIV Pune on 3rd June. 4th June, the government declared it as Nipah virus outbreak. Around 330 contacts were identified and were kept on surveillance. Last contact was released on June 23rd. No further cases and outbreak closed on 6th July. Our Honorable Minister and all the participants, all the leaders were there in the... Then third outbreak, again 3rd September, 12-year-old boy. Can I... Two more. The third outbreak was again in Kozhikode district on 3rd September. A 12-year-old boy who is a resident of the Cherwadi, Chulur, which was presented with the features of encephalitis and myocarditis. Then samples sent to NIV, Pune, and confirmed on 4th September midnight. He died. Unfortunately, that boy died on 5th September in a private hospital. Then no further cases reported, and outbreak closed on 16th. This was the outbreak response during 2nd and 3rd. The previous experience, that is 2019-18 experience, helped us a lot in tackling these later outbreaks. Followed the biosafety guidelines and all those measures. Prompt establishment of early diagnostic point of care test was established with the help of NIV Pune, and all those things. To conclude, the outbreak response activities undertaken by Kerala Health System contained the outbreak in a shortest time of 10 days. Though we lost a very precious 16 lives during the first outbreak period, later outbreaks limited to single case each. Even though the child could not be saved during the third outbreak, the administrative leadership, the political commitment, communities' cooperation, and the health system resilience all have contributed to this remarkable outbreak response. Guidance and support from Central and State Health Ministry was the highest motivation in our response, and inputs from technical experts was of immense help in these strategies. Our sincere gratitude to all the stakeholders involved in this historic venture. Thank you.
Thank you, Dr. Meenakshi. Now we have Dr. Naveen, DPM Kozhikode, to talk about the district response to the outbreak and the interdepartmental coordination.
A kind note to the speakers: a bell would be rung at 5 minutes and the second bell would be rung at 7 minutes. So make sure that you wrap up the presentation after the first bell in time for the second bell. Thank you.
respected dignitaries often on the dais, my dear colleagues, I am talking about District Public Health Response and Interdepartmental Coordination. In 2018, we witnessed a new outbreak called Nipah, and actually I was working as an assistant surgeon in Community Health Center Kondoti, Malappuram, and I was recruited to the activities for Nipah cell, which was constituted in government guest house, Kozhikode. And it was one of the best experience for me in my career. And I started with that career to work with legends in health and administration. And a Nipah cell was constituted under Honorable Chief Minister and Honorable Minister of Health and Family Welfare K.K. Shailaja Teacher and Honorable Minister of Labour and Excise Shri T.P. Ramakrishnan, Minister for Transportation Shri A.K. Shashindran, and 3 ministers camped there and coordinated all the activities. And from Trivandrum itself, our Additional Chief Secretary Shri Rajiv Sadanandan IAS coordinated all national and international activities. And under this, Director of Health Services Dr. Sarita and District Collector Shri Jose IAS and District Medical Officer Dr. Jayashri, now DMO of Ernakulam. And I got the opportunity to work with these legends, and it gave me a confidence to tackle any crisis in my professional and personal life. And it was a new experience, and this type of, now it is common because after Nipah, COVID came, and now we are familiar with this interdepartmental coordination and other DPMCU, District Program Management Support Unit. But on that time, it was very new, and we formed everything day by day. And the main activities of Nipah cell activities were infrastructure and logistics management. It was done from our medical college, Calicut, and under Dr. Kuriakos, Dr. Sajid sir, and other is we formed 16 committees, and we conducted daily activity review under district collector and daily media briefing. And we had to formulate new guidelines, and we followed Ebola guidelines for transportation and funeral guidelines. And there are also, we constituted a control cell and a 24/7 control room for conduct and transportation. And there were so many for getting ambulance drivers, and it will be explained by our colleagues in the next presentations. And we had a lot of expert teams. Without them, it would not be able to manage the Nipah crisis. And we also concentrated on psychosocial interventions also. And all these activities were coordinated under a single cell, it is Nipah cell. And I want to express my gratitude and Kozhikode's gratitude to the expert teams who helped us in the this management: NCDC Delhi, NCDC Kozhikode, Regional Office of Health, Government of India, Trivandrum, team from the EMR Division of MOH, Government of India, Entomology team from NCDC and NIV Pune, Epidemiology team from NIE Chennai, Virology team for MCVR Manipal, Virology team from NIV Pune, technical experts from AIMS Delhi, veterinary experts from the Animal Husbandry Department, experts from the ICMR Division, emergency medicine experts from Apollo Hospitals, Chennai. And in the district, we moved forward with a public-private partnership, and all the private hospitals and other NGOs like PVS, they helped us a lot for discussions and they provided all the support. And all the departments under district administration, one umbrella of district administration, revenue department, disaster management cell, LSGD department, PRD, police department, forest and animal husbandry, Ayush, civil supplies, Kudumbashri, NGOs and volunteers, all departments helped us to tackle this crisis of the new virus. And this was the Nipah cell, and it was the photo taken on the last day of Nipah cell, and it was a nice experience also to work with the people. And coming to the second outbreak in 2021, after 3 years, it was during our COVID pandemic, and the situations have changed, and there are guidelines and protocols in place because our Principal Secretary, Dr. Rajan Gobragade, IAS, took charge in Nipah outbreak in Ernakulam district, and we could release a guideline and protocol in place, which is a interdepartmental coordination was very easy. I would like to remember one workshop by IIM, and it was organized by our District Collector Sri Sambashiva Rao IAS. It was a workshop for all department heads, and all department heads became friends during that workshop, and it was very easy to coordinate the departments. And there are already identified isolation facilities in medical college, and already established equipments like negative pressure ICUs were in place. So we were confident enough, and of course new faces came for as our Honorable Health Minister Srimati Veena George and team, and a strong political will and support as in previous outbreak helped us to accelerate the activities within a short time. Positive result obtained on 4/9/2021, 9:30 p.m. And at that day, 10:30 p.m., we could call a meeting, and we could make an action plan and rapid response to outbreak, control activities, containment zone declaration, and case management. And I would like to go through day by day. This is day 1, positive result from NIV Pune. 10 p.m. higher level meeting, core committee formed, action plan presented, quarantine immediate contacts were quarantined, and a medical college pivot block ready to be occupied within 12 hours, and control room 24/7 call center and patient transportation system was in place in 12 hours. And these are the core committee teams, 18 committees. From the previous experience also, we added more committees. And there was a good action plan implemented in 3 hours. This was the action plan. Two activities, core committee and containment 3 kilometer radius from index case, contact tracing, quarantine symptom surveillance, and central team and expert team visit on the day 2 itself. And day 3, we could establish a point of care lab at a Government Medical College Kozhikode, environmental samples by animal husbandry, contact tracing, and a core committee meeting every day. Day 4, we started community surveillance, how to house visits, and contact tracing continued. And day 5, all party meeting, situation analysis, and we created a CDMS software which will be explained in the next meeting. And we completed all community surveillance and picked all fever cases, and we did the house-to-house lab tests for both Nipah and COVID, and most of the cases were COVID itself. And institutional medical board reviewed contact list assessment. And subsequent days, and it was set within 5 days of outbreak, and we could manage in a more efficient way because we had a previous experience and a strong support from both the government, for both the state and central government and all other institutions. The conclusions: administrative commitment, prompt planning, coordination and action, teamwork, health department, district administration, private participation, national level support, and we are continuing our researches and follow-up and vigilance. And thank you all.
Thank you, Dr. Naveen. Now we have Dr. K.G. Sadish Kumar, Professor of Medicine, Government Medical College, Kozhikode, and presently he is the Vice Principal of the college. and he was the superintendent of the medical superintendent of the hospital during that first Nipah outbreak, and was instrumental in coordinating the activities for the containment of the outbreak. And he is talking about the hospital preparedness during Nipah outbreak in Kozhikode.
Good morning, all. First of all, let me thank the organizers for considering me as one of the faculty for this prestigious Nipah workshop. And I would like to discuss what are the action that we had taken during the first outbreak in Kerala. And Nipah is a viral infection. It is nowadays known to everybody. And the history also, that is the first outbreak in Malaysia. And after that, this is the Sungai Nipah, the village, and thereby the name came. And to contain the infection in Malaysia, they killed roughly around 1 million pigs. This is not moving. And in the Bangladesh, the next year, this in 2001 and 2004, two outbreak, and West Bengal in India, there are two outbreak, Siliguri and Nadia, and the mortality is around 50 to 70%. And this is the data from WHO, and by this, what we understood is it's a serious infection, and the mortality is very high. And this is the newspaper report at that time, and the Apurva Pani, Maranam Munai. And at that time, our Honorable Minister Ramakrishnan sir called us. There is 3 members in a family, they are affected by some disease affecting the brain, and patient is in a very serious condition. They are admitted in a hospital, in a tertiary care center in Calicut, in private sector. And we have to do something because we shifted to the medical college. And there is an emergency meeting, sir come to college, and district collector and Honorable Health Minister also arranged a meeting in the collectorate. And the further proceedings I will discuss. There is the first case of Nipah that was admitted in 5th May in Government Medical College, Kozhikode. It is not serologically confirmed, it's an index case, and first case was confirmed on 19th May. And how do we manage to control this difficult situation? Why this is stuck? What is the problem with, take the previous slide. The problem with the difficulties in Calicut Medical College, it is, we are having very high patient load, disproportionately low infrastructure. In view of highly infectious disease, there is no provision for adequate isolation. And too difficult to cope up with the situation immediately, how to evacuate these patients. It's our college entrance, and this is our casualty. You see the crowd, It is very difficult to manage. And this is not the ward, this is the corridor. Patients were lying on either side, the main veranda. There is no seasonal variation, it is common to all 12 months. And this is again the ward. And the ICU is always full. And May 19th, the first confirmed case of Nipah was declared, and we arranged an emergency meeting, and we had to plan a separate triage and an isolation ward. And we immediately arranged an isolation ward in front of the casualty. We don't know much about the Nipah, only the literature review and the data from Bangladesh and the Singapore data and Malaysian data. And we contacted some of the faculties in the AIMS and from the central service, those who have some experience with the Bengal outbreak. And apart from the triage in front of the casualty, we arranged a separate fever isolation, the observation ward. This is a new building at that time was constructed for the geriatric patients and not open by that time. And for ICU purpose, the Institute of Chest Disease, the 5-bed ICU was taken over. And this is the new ICU. At that time, only 5-bed. Now it is 11-bed ICU. And the central team came to our hospital that is headed by Ravindran sir. It was the additional DGHS and the AIMS professors, four in number, and they came. And they visited all these setup, that is our casualty, the isolation ward, and the chest hospital to check what are the things, how we are arranged. And they told that we had to shift the isolation to a better place, that is the pay ward. I think you have to operate. That is the pay ward. Pay ward, what is the problem with our pay ward? It is already the patients are there, and most of them are post-operative patients with the drain and all. We have to evacuate. The post-operative, the surgery ICU is full. So we have to evacuate these patients, and the pay ward is not having any central oxygen supply. So we had to arrange a central oxygen supply, and the PWD was given the charge, but no people are willing to convert it because of the fever isolation ward is very close. So the people are scared. So we arranged with a team in Wayanad with the help of Kuryakos sir and Dr. Jayesh. Next slide. And this is the pain and palliative clinic. That is their OP session very close to pay ward. We make them or converted it to the triage area. Next slide. Next slide, please. And the separate triaging it is arranged. And this is the way how we'll arrange. That is the separate dawning area, then a fever triage, and the doffing area. And patients will be directly going from the triage to the room in the ground floor of the pay ward. And 3-layered. Next slide. That is for the serologically positive in the ground floor, and those who are in contact and those who are probable cases in separate floor. I think that will be discussed by our community medicine people, what is contact and what is suspect cases. And the infection control, previous slide. Infection control board meeting in every day, separate fever triage, training by the central team, and personal protection equipments. At that time, no idea regarding the personal protection equipment. Now, because of the COVID, everybody knows what is personal protection equipment. Separate donning and doffing room, and Government Medical College Kozhikode, after 1 week, announced as single center for the treatment. Next slide. And isolation ward, the confirmed cases, as I mentioned earlier, the probable case in one layer, contact in another layer, and the confirmed case in the ground floor. Next slide. And duty of the doctors, it's only 6 hours because of PPE kit and specific specimen collection, storage, transport protocol, and separate laboratory services and well-structured management protocol with the help of AIMS people. Next slide. And this is the donning area. Next slide. The cleanliness should be, it is also maintained always. Next. And daily meeting morning and evening and separate committees, the dead body disposal based on standard Ebola protocol and daily classes on infection control. Because the central team trained us and our faculties are master trainers and they trained our nursing assistants, staff nurses and all the staff in the local languages. And daily demonstration of PPE kit. The donning and doffing area, there is a video, how to don, how to doff. Okay, next slide. And they separate, there is the doctors, sisters, and the other staff. They separate the tag, who is the doctor, there is stickers are put on. Okay, next. And this is Dr. Gopagumar, I think he'll be talking this, and how to dispose the body and the burial. It is and our HI team. Next slide. And daily extensive meeting between 8 and 9 at the superintendent level, all the administrators, what are the things happened the last night and what are the gap filling and what are the things has to be done in the next 24 hours. And 9 a.m. to 10 a.m. all administrators will meet at the principal's chamber. And after the work, 3:30 to 5:30, all data will be collected. And again to the evening, already Dr. Naveen had pointed out, that is between 5:30 and 7:30, the Nipah control cell, that is at the West Hill Government Guest House, and everything will be controlled by Honorable Chief Minister and Honorable Ministers, our Health Minister at that time, Madam, and Excise Minister, T.P. Ramakrishnan Sir, and A.K. Shashindran Sir, Transport. They are, most of the days they were there, and they were the proceedings. And MPs and MLA, Mayor, everybody will be part of this program, and Health Secretary at that time, Then Sir, and District Collector U.V. Josa, he is the chairman, and central team from third day onwards, DHS, Dr. Sarida Madam, DMO, Dr. Jayasri Madam, and the health service team, and police officers, veterinary, and Nipah control cell. And this is the structure for this, for the containment. Next slide. And this is a central team and Manipal virology. I would like to mention Dr. Arun Kumar. He was always there, and the sample collection and sending the sample to the Manipal and get the result as early as possible. And the confirmation is only after getting the confirmation from NIV Pune. And he also done the field visit along with our community medicine team in Perambra, the Changarot Panchayat. Next slide. And this is the Nipah cell meeting. The last day we had taken the photograph. Next slide. The experts visit, there are various teams. Team A, NCDC, Dr. Regusar and team. Team B, Pune Virology. Team C, ICMR, Dr. Abhijit and team. Team D, Manipal Virology, Dr. Arun Kumar. At that time, he was working at Manipal Virology, and AIMS team, and Team F, NIE, that is the Epidemiology, National Institute of Epidemiology, headed by Dr. Sugunan Sir and team. Next slide. And economic support, that is Ministry of Health. CM had sanctioned 1 crore for this project initially, and T.P. Ramakrishnan Sir from the fund, 25 thing, from Shipping Corporation and also from Beverages Corporation. There is the public limited companies also helped us. The voluntary organization, NRI firm, Shailaja Teacher Madam had arranged, and political and religious organization and the medical, everybody had cooperated with us. This is the Kerala model. Next slide. The media, the public awareness, we had arranged the meeting in the guest house. And after the meeting, there will be briefing to the media by the ministers and DHS and regarding the management, the medical college team. And the media is very cooperative. They decrease the panic among the public because from the both print media and the channel and through the Facebook and YouTube videos to reduce the panic among the public. Next slide. The impact on the hospital, that is admission to the other illness, be negligible because people were scared and elective surgeries were postponed. Uncomplicated deliveries were shifted to the district and taluk hospital. MBBS students were granted leave because their parents were very panicked because it's a deadly infection and the mortality rate is high. And the hostels, the undergraduate hostels were closed, university exams postponed. Our postgraduate exam we conducted at Trichur Medical College and Pariyara Medical College. Next slide. And this is, I will show some of the pictures. I will finish it within 1 minute. And these are the hospital at that time. Next slide. Next. And the verandas, usually always full, even the veranda, it is almost empty. Next slide. This is the situation in the OP. Next slide. The casualty is overcrowded, but casualty is almost empty. The wards are empty. Next. This is the ward, only few patients, but the mass culture, nowadays it is not uncommon because of COVID. Next. The second Nipah outbreak in Calicut, this is the third in Kerala. The index case that was reported in a private hospital on 3rd September and he expired on September 5th. The KHRW's pay ward NMCH was arranged as an isolation ward. By evacuating, we are already in the pay ward. It is the staff, those who are positive for COVID were admitted. They are immediately shifted and this is rearranged. And pain and palliative OP block were arranged for the triage and this is continued as per the protocol. And second outbreak in the Ernakulam during June in 2019, we had arranged the training team from our college, Dr. Chandini madam, Dr. Sheila Matthew madam, and Dr. Mini, and two staff nurses, Shobha and Srina and Mr. Akash. They worked there, I think at least 7 days to train the staff how to manage, and this is the support that is given from us to the Ernakulam Medical College to arrange the preparation in Nipah outbreak, the second outbreak at Ernakulam. Next slide. And Nipah is definitely a deadly infection. However, we could decrease the spread of infection. It's a combined effort of all, both private, public, as well as administrative level, and from state and central. Everybody had worked as a single force. An outbreak contained in a minimum time of period, at least the minimum number of fatalities. Next slide. Thank you very much for patient listening.
Thank you, Dr. Sajid Kumar. Now here we have Dr. Matthews, former DPM Ernakulam, to talk on the hospital preparedness in Ernakulam.
A warm good morning to all the dignitaries participating in this workshop. I am here to present the Ernakulam experience of Nipah. This is the paper news on June 4th about Nipah landing in Ernakulam. Then the 23-year-old student from Kozhikode Grama Panchayat municipality, he was a student at that time. Then he developed flu-like syndromes on May 23rd. He consulted 3 or 4 hospitals with this syndrome. Laboratory investigations were done from 2 labs. Then finally he landed at Aster Medicity for expert management in the ICU with physical deficit. And there was a good team in Aster Medicity with a neurologist, critical care wing, and infectious disease wing. And they had a suspicion of Nipah, and they sent the sample to Bangalore, and a professional diagnosis was made. Immediately, we had a good relation with all the private hospitals. We had a program there called Unite for Health Ernakulam, and all the hospitals were reporting all the infectious diseases to our DMO office. And immediately, this message was passed on to DMO office. And the surveillance team and the district team, including the collector, went there, and the samples were collected, and all the blood, urine, and CSF samples were collected and sent to NIV Pune for confirmation. The first decision we had to take was where to treat the patient, whether to shift the patient to government side or not. Considering the critical situation of the patient and also about the chance of more infections during the transport, we finally decided to treat the patient in Aster itself. And Aster, even though initially there was some confusion, and they accepted it they accepted it and started the treatment. The only thing they asked was about the medicines, special medicines needed for Nipah, and also they asked for a medical board to, since it was a disease of international concern, they asked to constitute a medical board to support the treatment. Accordingly, a medical board with the experts from Calicut and from all throughout Kerala, under the leadership of Dr. Chandini, was set up there, and the treatment of the patient continued like that. Then, after that, the control cell was set up in the collectorate. Immediately after the provisional diagnosis was made, the control cell was started. Minister, the health minister, the minister in charge of the district, district collector, the DHS team, and all the experts, the experts from Calicut came there and guided us in the management of this situation. There were some 14 wings for the control room, each with a nodal officer, and every day there was a meeting under the leadership of collector, and the nodal officer of each wing participated in the meeting and they reviewed the situation. The contact tracing, contacts were there in Thrissur, Idukki, and Ernakulam district, and the DSO team did a good work to identify 330 contacts altogether. Then they were divided into high risk and low risk contacts, and accordingly the follow-up was done. And the contacts were called from the district control room and also from the field, and also the psychological team was also there to support all the contacts. The setting up the isolation facility, when the contact list increased, we thought that the isolation facility will not be enough. Initially, there was only 9-bedded isolation facility attached to the casualty of Ernakulam Medical College, but 330 contacts altogether was there. So we are in a tricky situation to accommodate the patients if the number increases. So at first we thought about taking some hotels and converting it into a isolation facility like that. But we could find out a 5-story building inside the medical college, which was running as a library and also a hostel. And it was evacuated within 4 hours, and cleaning was done, and all the equipments were bought, and it was changed. That hostel building was changed into a isolation facility with all the facilities, donning, doffing, and everything was like that within 36 hours. So that was a great challenge for us. Thanks to the government now, they are constructing one isolation facility in all the constituencies. 140 isolation facilities will be there. This kind of confusion will not be there if such a facility is there with all the facility. Only thing is this facility can be used for any treatment and can be converted into an isolation facility if there is a need. Then training was done for the medical college team. Special training was given by the Calicut team for the medical college team, and also for all the periphery medical officers and the health staff were trained to handle AES cases and also to isolation for isolation treatment. Then setting up the POC lab was the next challenge. The samples has to be taken to Pune through air. So there was some difficulty in transporting the sample. Actually, the first sample we took it in the the passenger took it with his own hand in the passenger wing. But later it was a problem. But it got streamlined. But when POC lab came, with the support of NIV, POC lab came, the problems resolved, and we could test all the samples of the contacts and also the follow-up sample of the patient. In this case, survived with all the support from the medical board and the Aster team. Then we are following up the survivor. We retested the sample in 2019 and 2022. And now he's having some neurological deficit for which neurological consultation and follow-up is being done. And based on this, AES surveillance was strengthened, and 30 cases identified in 2021 and 7 cases in 2022. And this is a good follow-up of the Nipah case. If any further case comes, we could identify it at the earliest. Thank you. On behalf of the Ernakulam team, I am presenting before you. Thank you.
Thank you, Dr. Matthews. Now we have Dr. Anup Kumar A.S. of Critical Care Medicine, Baby Memorial Hospital, Kozhikode, to talk on the clinical experience of the first serologically confirmed case of Nipah in Kerala. Only because of his high suspicion of an infectious etiology of the clinical presentation of that patient, which has led to the confirmation of Nipah in Kerala.
Good morning. I would really appreciate the organizers for arranging such a nice workshop here, that also based on this One Health concept. So we were hearing about different administrative aspects, how effectively we Nipah outbreaks. So now we'll move on to the clinical experience, what we had before. So to start with, we had the first patient in May 17th in 2018. He was a 26-year-old man. He was initially admitted in a private hospital in Perambra with symptoms like fever, vomiting, etc. He also had breathing difficulty, was not having cough. Then later on, he developed altered sensorium, restlessness. Then he was referred to our hospital. So, the features were suggestive of an encephalitis, like fever with altered sensorium. Unusual features was that he had breathing difficulty also. So usually when we get a patient with encephalitis, the first thing we do is get a CT head, rule out any ICP elevation, then go ahead with CSF analysis. So CT head was done for this patient. Unfortunately, it was showing features of cerebral edema, so he was shifted to the ICU. Here in the ICU, on examination, basically in the vitals itself, he had high blood pressure, he had tachycardia, he was hypoxic, requiring oxygen supplementation, and he was tachypneic as well. That's why we had to tube him immediately, considering his brain edema, and he was put on anti-edema measures as well. In the CNS examination, he was conscious but disoriented. He was restless, but there was no obvious focal neurological deficits at that point of time. And the meningeal irritation signs were also not elicited. And the plantar was flexor, and he was moving all four limbs. In the CVS and the respiratory system examination, he had few scattered crackles, but he was not having any features of cardiac failure, or there was no significant other respiratory signs as well. So, we have a case on May 17th. So, while taking the history, we enquired what are the other, is there any other persons in the family having the similar illness? So they have admitted that his brother died on May 5th in Calicut Medical College with almost similar symptoms. He was initially admitted in Perambra Taluk Hospital, later shifted here, but within few hours he died, immediately after taking an MRI. He developed a cardiac arrest, then he was intubated. So that gives us a clue that there is a link between the first case and this case, that there is a probable incubation period as well. So the next thinking at that point was, definitely the first patient would have infected others also. So we inquired, is there any other family members or the persons in the neighborhood having fever or similar symptoms. So they initially denied that. And another, the fortunate thing happened at that point was, the close relative, the cousin brother of this patient, was a critical care nurse working with us, with me in MIMS before. So we had a good rapport with the family as well. So later on, they agreed that the 3 family members, his mother, his aunt, father, and fiancé, they are also having a fever, but they are fine. They have consulted a local doctor. There is no issues. But on request, they brought these patients also into the hospital. Initially, they were in the ward, but later they were also shifted to the ICU, except that girl with the features of behavior, abnormal, other clinical findings, etc. So now we had with severe features, other one patient in the ward which is not very symptomatic, 2 more patients getting shifted to the ICU with a history of 1 patient dying 2 weeks before. And these patients were all showing some peculiar clinical features like a severe adrenergic response. All were having severe tachycardia, hypertension, etc., which were usual in previous encephalitis which we were treating. And 2 patients had segmental myoclonus. One lady was moving her lower limb. So initially we thought it is because of some psychosomatic issues, like she is anxious that all the relatives are getting sick. But later on, we were able to identify that was a segmental myoclonus. One patient had ptosis, and the segmental sweating was also observed. And again, we were also observing that finding for the first time, a patient with only one part of the body showing the sweating. And like the literature analysis also, this was not reviewed at that point of time, was showing all these features like segmental myoclonus, cerebellar signs, ptosis. All these symptoms were described in the previous Malaysian outbreak as well. So later on, after stabilizing the first patient, MRI was done. That was reported normal at that time. We will come to that later. So as the CSF, the brain edema has subsided, we have proceeded with the CSF analysis, and you can see the CSF analysis in all these patients were almost normal. There was no abnormality at that point, which is showing features of encephalitis. And you can see the previous papers also. The initial, the picture of CSF may be normal. This is applicable in other viral encephalitis also. So if you get a normal CSF picture, that will not exclude the possibility of Nipah or the possibilities of other viral encephalitis. So at this point, we had an index patient who died 2 weeks back. The clustering of cases happening in the family, and again unusual clinical features. So these made us to think about some unusual viral syndrome what we are dealing with, and then we have contacted the virology center in Manipal Virology, Dr. Arun Kumar. He was my friend. Then as per his advice, we have sent urine, blood, throat swab and CSF at that day evening itself. And remember, we had to send all the samples and see the reports. Like initial 3 patients, CSF was negative for all the 3 patients. Then later on, we had 2 more patients. There also the CSF was negative. So always remember, if you are suspecting Nipah, along with other CSF should be, other body samples also should be sent along with CSF. Your CSF may be negative because it's primarily a respiratory virus. And again, this was the routine blood picture, again, not very conclusive. Microalbuminuria and microscopic hematuria was observed in all 5 patients. But see this radiology again, you can see discrete hyperintensities in the subcortical and deep white matter. So this is a typical features of Nipah. And again, whenever you have such a radiological finding in an encephalitis patient, you have to definitely exclude the possibility of Nipah. And this was also described in previous episodes as well. Now we'll come to the next episode in 2019. I don't have a first-hand experience. This is based on the paper published by Dr. Anup Warrior. So there, like as Dr. Matthews was describing, a 21-year-old patient presented with fever-altered sensorium, which was of 12 days duration, and he had also cerebellar signs. So they have done an MRI. Again, that point of time also, the radiologists were not in suspicion of Nipah, but they have sent a multiplex PCR to Bangalore Excitone, which was having Nipah in that panel. And because of that, Nipah was picked at that point. So that is also a very important clue. We also should have a panel where Nipah also should be included to pick up the cases. Then later in 2021 in MIMS, like a 12-year-old child, focal seizures. There, the radiologist and the clinicians picked up the findings in MRI also, and they have correlated the autonomic dysfunction that child had, and with that they have sent the sample, but there also the initial sample was CSF, I feel, but whenever we have the suspicion, as I've shown before, you have to send all the samples. So in 2018, it was the clustering, unusual clinical features with which we picked up the cases, but unfortunately we were not able to isolate the cases immediately after the suspicion because we were not aware at that point. But in 2019 also the same thing was happened, like the patient was not isolated until we get a proper diagnosis or a strong clinical suspicion. Same was repeated in 2021 as well. So that should not happen here afterwards. Like whenever you have a clinical suspicion of Nipah, or when you have having like any clinical clues towards Nipah, from that point onwards, the patient should be isolated. So the clinical clues will be, especially the clustering of cases, then adrenergic response, myocarditis, the cardiomyopathy. So our case was basically a stress cardiomyopathy, which I don't have the time to discuss those points. And again, brainstem signs, cerebellar signs, myoclonus, and all these three outbreaks, we had the MRI findings also. So I think all the clinicians should be aware about these MRI findings, and you can have different profile of patients with encephalitis alone, or combination of encephalitis ARDS, combination of these three, or isolated flu-like symptoms are also possible, like Dr. Matthews were describing. And like these three possibilities, like you can have only prodromal symptoms during presentation, or you can have encephalitis-like symptoms. Like when you are getting a patient on prodromal symptoms, you may miss that case. You cannot help it. But in other areas, you should not miss the cases. So, and again, another thing, like we know that the main spread during that outbreak happened in the local hospital in Perambra and later in medical college also. So that again alert us how effective our infection control practices in the hospital should be, especially when we are having a suspicion about encephalitis. Because of the shortage of time, I'm not going into the treatment details and the development in the research in the treatment aspect, but the recent papers have shown that remdesivir is having a role. Now that drug is also available. There are many other drugs also tried in that. But to conclude, so whenever we have a clinical suspicion, as I've repeatedly told, the patient should be immediately isolated. Then an appropriate personal protection equipment should be used whenever we are handling encephalitis patients in Kerala, I feel. I don't know whether the experts will agree with that, but in my personal experience, I think that should be done. At least the mask and proper hand hygiene should be utilized. Proper history taking, the possibilities of clustering, then again warning clinical features. All the clinicians who are treating such patients should be alerted about that. And we have to do throat swab, urine and blood examination, the PCR examination along with CSF, and never miss the MRI findings or MRI clues. And we should have a strong encephalitis surveillance. And I strongly feel that we should have a customized CSF panel for Kerala itself, including the common viruses here. We have experts like Dr. Srikumar, the Virology Institute director here, and other experts, microbiology experts. So I think this workshop should come up with the proper the multiplex PCR panel for Kerala, which can pick all these cases. And previously, Dr. Ravi from NIMANS has also published few papers on different protocolized way of approaching the CSF in such patients, or like the lab in such patients. Thank you so much.
Thank you, Dr. Anup Kumar. Now we have Dr. Kalpana George, Associate Professor of Microbiology, Government Medical College, Kozhikode, to talk about the laboratory setup during the outbreak.
Respected dignitaries on the dais, those who have gathered here, and to those who are listening to us from other locations, a warm good morning to you all. I have been given this task of sharing our experiences in setting up the Nipah testing lab at GMC Kozhikode under regional VRDL during the latest Nipah outbreak. For the next 7 minutes or so, I'll be very briefly describing how we did it and about the lab policies, lab protocols that we have followed during that time. Previous speakers have already described, elaborated on the timeline of the events that ended up in declaration of an epidemic, of an outbreak on September 5th. And after a series of meetings, it was decided to set up a point-of-care testing lab at VRDL, regional VRDL Kozhikode. And that was a Sunday, if I remember it right, the September 5th. So during the previous two outbreaks in 2018, during the 2018 outbreak, all the samples were collected all the samples collected from contacts and patients were sent to Manipal for further testing. And during the 2019 outbreak, POC lab was set up at GMC Ernakulam. So we had two experiences before us. But the challenge was when the day the decision was taken, this was the situation of our lab. I don't think the picture has captured it completely. There were just few rooms, which these rooms were earmarked for the regional VRDL. It was a newly constructed lab. And the task given to us was to set a lab ready, up and running for starting the testing the next day itself. On September 6th, we started to shift all the equipments. As all of you know, for a basic molecular lab, we require biosafety cabinets, laminar flow cabinets, PCR machines, centrifuges, extraction machines, pipettes, and so many other consumables, PPE. The list is quite long. Because of the COVID pandemic that was going on, and we being a regional VRDL, we had few surplus biosafety cabinets, PCR machines, some of those equipments with us. But the challenge was these machines were lying at two different locations in the campus. These equipments being very heavy, that was a major challenge for us to shift all this stuff to the new lab. Dr. Anukumar, Dr. Sugunan, and his team from NIV Alapi were with us throughout the process, helping us, advising us, guiding us regarding the placement of equipments and setting up of the lab. Dr. Rima Sahe and Dr. Rima Sahe, Dr. Sri Lakshmi and her colleagues and her team members, they arrived at the location the same day itself. They carried with them all the reagents which we didn't have, the consumables which we didn't have, and more importantly, high-level PPE and PAPRs with them. PAPR is powered air purifier respirator, which is essential for carrying out the test. Let me just remind you that Nipah virus is actually a level 4 pathogen. Level 4 pathogen means if someone wants to handle the virus or to live virus, or culture the viruses, or culture this virus, it has to be done at high containment. But if we can ensure that the virus is inactivated and with lab personnel who are adequately trained in wearing using the PPE properly and handling the specimens, we can safely do the basic test in BSL-2 lab. And that's what we did. The NIV Pune team, they conducted a series of training for proper wearing of the PPR. In the picture, you can see what a PPR is, the person wearing a special suit there. So they conducted these trainings for PPE wearing, handling of specimens, and safe disposal of biomedical waste, which is generated in the lab. The training was attended by the regional VRDL, the core staff of regional VRDL, and also field staff who were involved in collecting the specimens. An SOP was prepared at the earliest to define the chain of custody of samples. And it was decided that all samples from asymptomatic cases who were linked epidemiologically to the index case and all those suspected cases which conform to the signs and symptoms of Nipah infection, who were not, but were not epidemiologically linked, would be tested at the local site. And all symptomatic cases, samples from all symptomatic cases who were epidemiologically linked would be sent to ICMR Pune because of the risk of, high risk of isolating the virus. The samples were collected by healthcare workers wearing full PPE. As Dr. Anoop mentioned, these were the samples we collected. If CSF was collected, that too was tested. Because of the COVID, all healthcare workers who were involved with sample collection and all, they were very well versed with triple layer packing. So that was an added advantage. So the major challenge was to run a show like this. There should be, coordination between multiple departments multiple departments in the sense the challenge we faced was having a coordinated effort between the clinicians, the sample collection team, the laboratory itself, the NIV Pune. So it was like a huge teamwork. And all the results which was generated here was immediately communicated to NIV Pune and was disseminated to the healthcare officials and the concerned clinicians. So during the outbreak, we tested samples collected from 120 contacts and 150 samples were tested till date. We are still testing for Nipah virus by RT-PCR. Other than patient samples, we also handled batch samples which was collected from field for serum separation and aliquoting them and shipping them to NIV Pune for further testing. And I would like to take this opportunity to thank the NIV team, both Pune and Alapi, and our core VRDL staff, Dr. Prashant and his team, for their dedicated service for setting up the lab. Thank you so much.
Thank you, Dr. Kalpana. Thanks to all the participants in the presentation. I think they have brought out the challenges we faced during the first outbreak and how the lessons learned from the first outbreak could help us in dealing with the second and third outbreaks more effectively. And now we have 5 minutes left for an open discussion. And, questions are invited from the audience.
I want to show 4 pictures in front of you. That's please. This is the first, some pictures of first outbreak which has happened during 2018. The meetings all the field experiences. Next. Next. It's not there. This is the second outbreak. Second outbreak happened in Ernakulam district. All the ministers and officials and the field who is collecting the samples. This is the third outbreak which again happened at Kozhikode. Our Honorable Minister, Veena Madam, and the other ministers, and also the administrative setup. This is the great tribute to one of our health workers who lost her life, Sister Lini, who lost her life in the Nipah battle. Thank you.
Thank you, speakers, for this really interesting session. I kindly request you to accept the small gift as a token of our appreciation.
So now we conclude the first session. So I think increasing the awareness about emerging and re-emerging diseases is the most important thing, and it should be among the society public also, other than the healthcare providers. And then only we can isolate, identify the cluster, isolate the suspected cases, and prevent the outbreak. So thank you all for participating in this session. Thank you once again.
I'd like to thank all the delegates for their very interesting topics and presentations. Now, moving on, we'll be moving forward with the inaugural ceremony as the Health Minister will be here shortly. For the inaugural ceremony, I'd like to invite onto the stage Dr. V.R. Raju, Director of Health Services in charge, Sri Thottathil Ravindran, the Honorable MLA of North Kozhikode, Advocate P.A. Mohammed Riaz, the Honorable Minister for Public Works and Tourism, Dr. Asha Thomas, IAS, the additional Chief Secretary, Personnel and Administrative Reforms, and Health and Family Welfare Department. Dr. Rajan N. Kobragare, IAS, the Principal Secretary, Department of Health and Family Welfare. Dr. Radhan Kelkar, IAS, the State Mission Director, National Health Mission. Sri P.K. Keshavan, IFS, Principal Chief Conservator of Forests and Head of the Forest Force. Dr. A. Kausigan, IAS, Director, Animal Husbandry Department. Dr. Narasimhagadi T.L. Reddy, IAS, District Collector, Kozhikode. Dr. Thomas Matthew, Joint Director, Medical Education Department. Dr. V. Meenakshi, Additional Director of Health Sciences, Public Health. Dr. K.G. Sajid Kumar, Principal in Charge, Government Medical College, Kozhikode. Dr. Umar Farooq, District Medical Officer of Health, Kozhikode. Sri Chelsasini, IAS, Sub-Collector, Kozhikode. and CEO of Gender Park, and as part of the organizing committee, Dr. Vidya, ADHS, and Dr. Naveen, DPM, Kozhikode. Would all the delegatories who were invited please kindly step onto the stage? Again, I request all the dignitaries who were named to please kindly step onto the stage. Thank you.
Nipah.
I would also like to invite Dr. Arun Zakaria, Chief Forest Veterinary Officer, onto the dais. I repeat, Dr. Arun Zakaria, I invite you onto the stage. Thank you.
നാടിനെ കുറെ നാളുകൾക്ക് ശേഷം മുൾമുനയിൽ നിർത്തിയ വൈറസ് രോഗം. കോഴിക്കോട് രുചികളുടെയും നിറങ്ങളുടെയും ആസ്വദിച്ചുള്ള യാത്രാമധ്യേ ഇതുവരെ കേൾക്കാത്ത, അറിയാത്ത ഒരു രോഗത്തെ നമ്മൾ കേട്ടു. അതിൻ്റെ വ്യാപനം, ചികിത്സയില്ലെന്നുള്ള വിവരണം അറിഞ്ഞു തുടങ്ങിയപ്പോഴേക്കും മരണങ്ങൾ വന്നു തുടങ്ങിയ രോഗം നിപ്പ ഒരു നടുക്കത്തോടെ നമ്മൾ കേട്ടു. വീടിനു പുറത്തിറങ്ങാതെ, ഇഷ്ടജനങ്ങളെ കാണാതെ, നാടിൻ്റെ രുചിയും മണവും നുകരാതെ അടച്ചുപൂട്ടിയിരുന്നു. നമ്മുടെ ഈ അടച്ചുപൂട്ടലിലും നിപ്പയെ കീഴടക്കാനൊരുങ്ങിയ ആരോഗ്യവകുപ്പും ഭരണകൂട സംവിധാനങ്ങളും ഇവർ ഒന്നിച്ചപ്പോൾ ജാതിമത ഭേദമന്യേ രാഷ്ട്രീയ നിറം കലരാതെ ഒത്തൊരുമിച്ച പൊതുജന പങ്കാളിത്തവും പ്രതിരോധം ശക്തിപ്പെടുത്തി നിപ്പയ്ക്കെതിരെ. നിപ്പയുടെ രണ്ടാം വരവ്. നമ്മെ നയിച്ചവരിൽ പുതിയ മുഖങ്ങൾ വന്നു. മികച്ച രീതിയിൽ ഭരണ സംവിധാനം ചലിച്ചു. അതിവേഗം പ്രതിരോധത്തിന്റെ കോട്ടകളും ഉയർന്നു. നിപ്പയ്ക്കെതിരെ നമ്മൾ വിജയം കണ്ടു. നേട്ടങ്ങൾ കൊയ്തപ്പോൾ നഷ്ടങ്ങളുടെ നൊമ്പരങ്ങൾ നമ്മൾ അറിഞ്ഞു. നിപ്പയോട് പൊരുതിയ ലെനി സിസ്റ്റർ, രോഗികൾക്ക് കൂട്ടിരിപ്പിന് വന്നവർ രോഗികളായി മരണമടഞ്ഞപ്പോൾ ആശുപത്രിയിലും വാഹനങ്ങളിലും രോഗികൾക്ക് തുണയായവർ, സമൂഹത്തിന് വേണ്ടപ്പെട്ട ഇവരിൽ ചിലരെ നമുക്ക് നഷ്ടമായി. സ്നേഹത്തിൻ്റെ, ത്യാഗത്തിൻ്റെ പ്രതീകങ്ങളായി ഇവർക്ക് പ്രണാമം. നമ്മുടെ സംവിധാനങ്ങൾ മുന്നോട്ടു പോകുക തന്നെ ചെയ്തു. മാതൃകയായി ഈ ലോകത്തിന് നമ്മൾ വിജയം കൈവരിച്ചു. യാത്ര മുന്നോട്ടു തന്നെ. നിപ്പയ്ക്കെതിരെ പ്രതിരോധം ശക്തിപ്പെടുത്താം. ഉറപ്പാക്കാം ഈ കരുതൽ നമുക്കോരോരുത്തർക്കും. നിപ്പ നമ്മുടെ നാടുകൾക്ക് ശേഷം
We are graced to have among us Srimati Veena George, the Honorable Minister for Health and Women and Child Development. The official inaugural ceremony is about to begin. We are graced to have among us Srimati Veena George, the Honorable Minister for Health and Women and Child Development. Srimati Veena George played a pivotal role in spearheading the state's fight against the COVID-19 pandemic and continues to be a beacon of hope for the future of Kerala's public health. I kindly invite Dr. V.R. Raju, Director of Health Services, to welcome the gathering.
എല്ലാവർക്കും നമസ്കാരം. നമ്മളിന്നിവിടെ ഒരു പുതിയ കാൽവയ്പ്പാണ്. കഴിഞ്ഞ 2018 കേരളത്തിലെ കോഴിക്കോട് ജില്ലയിലും മലപ്പുറം ജില്ലയിലുമായിട്ട് നിപ വന്ന സമയത്ത് കേരളത്തിലെ ആരോഗ്യ മേഖലയിലെയും അതുപോലെ തന്നെ മറ്റ് ഡിപ്പാർട്ട്മെൻറ്റുകളുടെ ഒത്തൊരുമിച്ചുള്ള പ്രവർത്തനം വഴി നമുക്ക് നിപയുടെ മരണനിരക്ക് കുറയ്ക്കാനും അത് ഈ 2 ജില്ലകളിൽ മാത്രം ഒതുക്കി നിർത്തുവാനും നമുക്ക് സാധിക്കുന്നുണ്ട്. അത് എങ്ങനെയാണ് നമ്മൾ ആ ഒരു കാര്യം സാധ്യമാക്കിയത് എന്നുള്ള ഒരു വിശദമായിട്ടുള്ള ചർച്ച നമ്മൾ കഴിഞ്ഞ 1 മണിക്കൂർ ഇവിടെ കേൾക്കുകയുണ്ടായി. സ്റ്റേറ്റ് ലെവലിലും ജില്ലാ ലെവലിലും അതുപോലെ തന്നെ ഇൻസ്റ്റിറ്റ്യൂഷൻ ലെവലിലും ലാബ് ഡയഗ്നോസിൻ്റെ കാര്യത്തിലും ഒക്കെ എന്തൊക്കെ കാര്യങ്ങൾ നമ്മൾ ചെയ്താണ് നമ്മൾ ആ ആക്ടിവിറ്റി ഫലപ്രദമായിട്ട് നമുക്ക് നിയന്ത്രിക്കാൻ സാധിച്ച് എന്ന് നമ്മൾ കഴിഞ്ഞ 1 മണിക്കൂർ നമുക്ക് കേൾക്കുകയുണ്ടായി. അതുമായിട്ട് ബന്ധപ്പെട്ട് അതിന് ശേഷവും കേരളത്തിൽ കഴിഞ്ഞ 2.5 വർഷമായിട്ട് കോവിഡുമായിട്ട് ബന്ധപ്പെട്ടിട്ടുള്ള പ്രവർത്തനങ്ങൾ നമ്മൾ ഒറ്റക്കെട്ടായി നിന്ന് നടത്തിക്കൊണ്ടിരിക്കുകയാണ്. ഓരോ പ്രവർത്തനങ്ങൾ മുന്നോട്ട് പോകുമ്പോഴും നമുക്ക് ഓരോ എക്സ്പീരിയൻസ് ആണ് നമുക്ക് ലഭിക്കുന്നത്. അത് നമ്മുടെ ആരോഗ്യ മേഖലയിൽ പിന്നീടുള്ള പ്രവർത്തനങ്ങൾക്ക് ഫലപ്രദമായിട്ട് മുന്നോട്ട് കൊണ്ടുപോകാൻ നമുക്ക് സാധിക്കുന്നു. ആ ഒരു രീതിയിൽ കഴിഞ്ഞ വർഷങ്ങളിലായി കഴിഞ്ഞ നിപ്പ ഔട്ട് ബ്രേക്കിൽ 18-19 ഉണ്ടായ നിപ്പ ഔട്ട് ബ്രേക്കിൽ നിന്നും അതുപോലെ തന്നെ കഴിഞ്ഞ 2.5 വർഷക്കാലത്തെ കോവിഡ് മഹാമാരിയിൽ നമ്മൾ ചെയ്ത പ്രവർത്തനങ്ങളുടെ എക്സ്പീരിയൻസുകളിൽ നിന്നും നമുക്ക് ആരോഗ്യ മേഖലയിൽ എന്താണ് ഏത് രീതിയിലാണ് മുന്നോട്ട് പോകാൻ സാധിക്കുക എന്നുള്ള ഒരു ചിന്തയിൽ നിന്നാണ് ഈ രീതിയിലുള്ള ഒരു വർക്ക്ഷോപ്പ് നമ്മളിവിടെ ഉരുത്തിരിഞ്ഞ് വന്നിരിക്കുന്നത്. ഇതിൽ പങ്കെടുക്കാൻ എത്തിയിരിക്കുന്ന എല്ലാവരെയും സ്വാഗതം ചെയ്യുക എന്നുള്ളതാണ് എൻ്റെ കർത്തവ്യം. ഈ വർക്ക്ഷോപ്പിൻ്റെ അധ്യക്ഷം വഹിക്കുന്നത് ബഹുമാനപ്പെട്ട MLA ശ്രീ തോട്ടത്തിൽ രവീന്ദ്രൻ സാറാണ്. അദ്ദേഹം ഓൺലൈനായിട്ട് നമ്മുടെ ഈ മീറ്റിംഗ് നമ്മൾ ഓൺലൈനും അതുപോലെ ഫിസിക്കലുമായിട്ട് നടക്കുന്നുണ്ട്. അപ്പം അതിൽ അധ്യക്ഷനായിട്ടിരിക്കുന്ന നമ്മുടെ തോട്ടത്തിൽ രവീന്ദ്രൻ സാറാണ്. സാറിനെ ഞാൻ ഏറെ ആദരവോടെ ഈ യോഗത്തിലേക്ക് സ്വാഗതം ചെയ്യുകയാണ്. കൂടാതെ നമുക്കറിയാം ഇന്നിവിടെ ഈ ഒരു വർക്ക്ഷോപ്പ് ഉദ്ഘാടനം ചെയ്യാൻ എത്തിയിരിക്കുന്ന മുഖവരകളൊന്നും ആവശ്യമില്ലാത്ത നമ്മുടെ എല്ലാം പ്രിയപ്പെട്ട ആരോഗ്യവകുപ്പ് കുടുംബക്ഷേമ ശിശു വനിതാ വികസന വകുപ്പ് മന്ത്രി ശ്രീമതി വീണ ജോർജ് മാഡമാണ്. മാഡത്തിൻ്റെ ഔദ്യോഗിക തിരക്കുകൾക്കിടയിലും ഇവിടെ എത്തി ഈ ഒരു സെഷൻ ഉദ്ഘാടനം ചെയ്യാനായിട്ടിരിക്കുന്ന മാഡത്തെയും ഞാൻ നിങ്ങളുടെ എല്ലാവരുടെയും പേരിലും ആരോഗ്യവകുപ്പിൻ്റെ പേരിലും അതുപോലെ തന്നെ മറ്റ് ഡിപ്പാർട്ട്മെൻറ്റുകളുടെ പേരിൽ ഞാൻ വളരെ ഹാർദവമായിട്ട് സ്വാഗതം ചെയ്യുകയാണ്. ഇവിടെ നമ്മുടെ മുഖ്യ അതിഥികളായിട്ട് എത്തിയിരിക്കുന്നത് നമ്മുടെ മന്ത്രിമാരായിട്ടുള്ള ശശീന്ദ്രൻ സാറ്, ബഹുമാനപ്പെട്ട വനം വന്യജീവി സംരക്ഷണ വകുപ്പ്, അതുപോലെ മുഹമ്മദ് റിയാസ് സാറ്, പൊതുമരാമത്ത് വിനോദസഞ്ചാര വകുപ്പ് മന്ത്രി. അതിൽ മുഹമ്മദ് റിയാസ് സാറ് ഓൺലൈനിലാണ് വരുന്നത്. സാറ് ശശീന്ദ്രൻ സാറ് നമ്മളെ നേരിട്ട് ഇവിടെ എത്തിയിട്ടുണ്ട്. ഈ രണ്ട് മാന്യ വ്യക്തികളെയും ഞാൻ നിങ്ങളുടെ എല്ലാവരുടെയും പേരിൽ ഹാർദവമായിട്ട് സ്വാഗതം ചെയ്യുകയാണ്. അതുപോലെ നമ്മുടെ ഈ മീറ്റിങ്ങിൽ ആശംസകൾ അർപ്പിക്കാൻ എത്തിയിരിക്കുന്ന ആളുകളായിട്ടുള്ള നമ്മുടെ എല്ലാം ബഹുമാനപ്പെട്ട ആഷ തോമസ് മാഡം IAS, അഡീഷണൽ ചീഫ് സെക്രട്ടറി, നമ്മുടെ മെഡിക്കൽ എഡ്യൂക്കേഷൻ ഡിപ്പാർട്ട്മെൻറ്റ്, അതുപോലെ തന്നെ നമ്മുടെ എല്ലാം പ്രിയപ്പെട്ട പ്രിൻസിപ്പൽ സെക്രട്ടറി രാജൻ സാറ്, അതുപോലെ നമ്മുടെ സ്റ്റേറ്റ് മിഷൻ ഡയറക്ടർ രത്തൻ കൽക്കൽ സാറ്, പ്രിൻസിപ്പൽ ചീഫ് കൺസർവേറ്റർ ഓഫ് ഫോറസ്റ്റ് ശ്രീ PK കേശവൻ IFS, ജില്ലാ ഡയറക്ടർ മൃഗസംരക്ഷണ വകുപ്പ് ശ്രീ A കൗശികൻ IAS, ജില്ലാ കളക്ടർ ശ്രീ നരസിംഹപുരി TA റെഡ്ഡി, അതുപോലെ തന്നെ ഡെപ്യൂട്ടി കളക്ടർ കോഴിക്കോട്, പിന്നെ ജോയിൻറ്റ് ഡയറക്ടർ ആൻഡ് ഡയറക്ടർ ഇൻചാർജ് മെഡിക്കൽ വിദ്യാഭ്യാസം ഡോക്ടർ തോമസ് മാത്യു, അഡീഷണൽ ഡയറക്ടർ ഡോക്ടർ മീനാക്ഷി, അതുപോലെ തന്നെ പ്രിൻസിപ്പൽ ഇൻചാർജ് മെഡിക്കൽ കോളേജ് ഡോക്ടർ സജിത്ത്, DMO ഉമ്മർ ഫറൂഖ്, NHM പ്രോഗ്രാമാണ് ഡോക്ടർ നവീൻ, അതുപോലെ മറ്റ് ഇവിടെ വന്നിരിക്കുന്ന മറ്റുള്ള എല്ലാ വിശിഷ്ട വ്യക്തികളെയും ഞാൻ ഈ ഒരു അവസരത്തിൽ വളരെ ഹാർദവമായിട്ട് ഈ ഒരു വർക്ക്ഷോപ്പിലേക്ക് സ്വാഗതം ചെയ്യുകയാണ്. എല്ലാവർക്കും നമസ്കാരം.
Thank you, sir. To deliver the presidential address, we have Sri Throtathil Ravindran, the Honorable MLA, Kozhikode North.
2018 മെയ് 17 ആദ്യമായിട്ട് നമ്മുടെ സംസ്ഥാനത്ത് നിപ്പ റിപ്പോർട്ട് ചെയ്യുന്നത്. കോഴിക്കോട് ജില്ലയിലെ ചെങ്ങരോത്ത് പഞ്ചായത്തിൽ വെച്ച് ആണ് ഈ ഒരു കേസ് വന്നിട്ടുള്ളത്. പക്ഷേ നിർഭാഗ്യവശാൽ നമുക്ക് ആർക്കും അറിയില്ല, ഇത് സംബന്ധിച്ചിട്ടുള്ളൊരു വിവരവുമില്ല. ശരിക്കും പറഞ്ഞാൽ ഇതൊരു സന്ദർഭവശാൽ നമ്മുടെയൊക്കെ ഭാഗ്യം, പെട്ടെന്ന് ഇത് തിരിച്ചറിയാൻ കഴിഞ്ഞു എന്നുള്ളതാണ് ഇതിൻ്റെ ഏറ്റവും വലിയ നേട്ടം. അതിനുശേഷം ഇങ്ങോട്ടുണ്ടായിട്ടുള്ള പ്രവർത്തനങ്ങൾ, കാരണം ശരിക്കും പറഞ്ഞാൽ ആരോഗ്യമന്ത്രി തൊട്ടിട്ട് ആരോഗ്യ മേഖലയിലുള്ള മുഴുവൻ പ്രധാനപ്പെട്ട ആളുകളെ ഒന്നിച്ച് സംഘടിപ്പിച്ചുകൊണ്ട് ഓരോ ദിവസവും കാര്യങ്ങൾ വിലയിരുത്തിക്കൊണ്ട് നമുക്ക് മുന്നോട്ട് പോകാൻ കഴിഞ്ഞതാണ് ഇതിൻ്റെ ഏറ്റവും വലിയ നേട്ടം. തീർച്ചയായിട്ടും നമ്മൾ അതിനെ സംബന്ധിച്ചിട്ടുള്ളൊരു വർക്ക്ഷോപ്പാണ് ഇപ്പം 2021 പിന്നെ ഒരു കേസ് വന്ന് ആ ഒരു കേസിൽ നിർത്താൻ സാധിച്ചു എന്നുള്ളൊരു ചെറിയ നേട്ടമല്ല ശരിക്കും. 18 തന്നെ വന്നപ്പോൾ 18 കേസുകൾ റിപ്പോർട്ട് ചെയ്തതിൽ 16 പേരെ മരണത്തിന്, കാരണം സ്വാഭാവികമായിട്ട് ഇത് വെടിവെട്ടാൽ മരണമല്ലാതെ വേറെ വഴിയില്ല എന്നുള്ളതാണ്. പക്ഷേ 2 പേരെ അതിലും രക്ഷപ്പെടുത്താൻ സാധിച്ചു. ഇതൊക്കെ നമ്മുടെ ഒരു ഒന്നിച്ചിട്ടുള്ള പ്രവർത്തനത്തിൻ്റെ ഭാഗമായിട്ടാണ്. ശരിക്കും പറഞ്ഞാൽ ആരോഗ്യ മേഖലയിൽ നമ്മൾ ഒരുപാട് മുന്നോട്ട് പോയിട്ടുണ്ടെന്ന് തെളിയിക്കുന്ന ഒന്നാണ് ഇതൊക്കെ. തീർച്ചയായിട്ടും ഇവിടെ നടത്തുന്നത് ഏറ്റവും വലിയൊരു വർക്ക്ഷോപ്പാണ് ഇത് സംബന്ധിച്ചത്. നമുക്ക് ഈ വർക്ക്ഷോപ്പ് ജനങ്ങളിലൊരു വലിയ അവബോധം സൃഷ്ടിച്ചെടുക്കാനും ഇത് സംബന്ധിച്ച് ഇനി എന്ത് വന്നാലും നമുക്കതിനെ നേരിടാനുള്ള സുസജ്ജമാണ് നമ്മൾ എന്ന് തെളിയിക്കാൻ നമുക്ക് കഴിയണം. അതിനു വേണ്ടിയിട്ടാണ് ഈ വർക്ക്ഷോപ്പ് നടത്തുന്നത്. എല്ലാ വിജയങ്ങളും ആശംസിക്കുന്നു. ഏറ്റവും നല്ല നിലയിൽ നമുക്ക് മുന്നോട്ട് പോകാൻ കഴിയട്ടെ എന്ന് ആശംസിക്കുന്നു.
I request Srimati Veena George, our Honorable Minister for Health and Women and Child Development, to officially inaugurate this ceremony by lighting the lamp. I request all the dignitaries on the dais to join her to grace this event by lighting the lamp. I invite Srimati Veena George to deliver the inaugural address.
ബഹുമാനനായ യോഗാധ്യക്ഷൻ, കോഴിക്കോട് നോർത്ത് MLA ശ്രീ തോട്ടത്തിൽ രവീന്ദ്രൻ, ആദരണീയനായ സംസ്ഥാന വനം വന്യജീവി സംരക്ഷണ വകുപ്പ് മന്ത്രി ശ്രീ AK ശശീന്ദ്രൻ, ആദരണീയനായ സംസ്ഥാന പൊതുമരാമത്ത് വിനോദസഞ്ചാര വകുപ്പ് മന്ത്രി, ഈ ജില്ലയുടെ ചുമതല കൂടിയുള്ള ശ്രീ PA മുഹമ്മദ് റിയാസ്, എൻ്റെ പ്രിയപ്പെട്ട സഹപ്രവർത്തകർ ഡോക്ടർ ആശ തോമസ് IAS, അഡീഷണൽ ചീഫ് സെക്രട്ടറി മെഡിക്കൽ എഡ്യൂക്കേഷൻ, ഡോക്ടർ രാജൻ N. കൊബ്രാഗിഡെ IAS, പ്രിൻസിപ്പൽ സെക്രട്ടറി ആരോഗ്യ കുടുംബക്ഷേമ വകുപ്പ്, ശ്രീ PK കേശവൻ IAS, ഡോക്ടർ A. കൗശികൻ IAS, സബ് കളക്ടർ ശ്രീമതി ചിൽസാസിനി IAS, ഡോക്ടർ VR രാജു, ഡയറക്ടർ ഇൻചാർജ്, ഡോക്ടർ തോമസ് മാത്യു, ജോയിൻറ്റ് ഡയറക്ടർ മെഡിക്കൽ എഡ്യൂക്കേഷൻ, ഡോക്ടർ V. മീനാക്ഷി, ഡോക്ടർ സജിത്ത്, ഡോക്ടർ വിദ്യ, ഡോക്ടർ ഉമർ ഫറൂഖ്, ഡോക്ടർ അരുൺ സക്കറിയ, ചീഫ് ഫോറസ്റ്റ് വെറ്റിനറി ഓഫീസർ, ഡോക്ടർ നവീൻ ഉൾപ്പെടെ ഇവിടെ സന്നിഹിതരായിരിക്കുന്ന എൻ്റെ പ്രിയപ്പെട്ട സഹപ്രവർത്തകരെ, DMOമാരുണ്ട്, DPMമാരുണ്ട്, അതുപോലെ മറ്റു വകുപ്പുകളിലെ വനം വകുപ്പിലെയും മൃഗസംരക്ഷണ വകുപ്പിലെയും പ്രിയപ്പെട്ട ഉദ്യോഗസ്ഥ സുഹൃത്തുക്കളുണ്ട്. ഇതുകൂടാതെ കോഴിക്കോട് അതുപോലെ സംസ്ഥാനത്തെ മറ്റു ഭാഗങ്ങളിൽ നിന്നും എത്തിയ വിശിഷ്ട വ്യക്തികൾ, പ്രിയപ്പെട്ട സഹോദരീ സഹോദരന്മാരെ, സുഹൃത്തുക്കളെ, നിപ്പായ്ക്കെതിരെയുള്ള പ്രതിരോധം സംസ്ഥാനം ശക്തമാക്കുകയാണ്. അതിൻ്റെ ഭാഗമായി 2 തവണ നിപ്പ റിപ്പോർട്ട് ചെയ്യപ്പെട്ട കോഴിക്കോട് ജില്ലയിൽ നിപ്പ അനുഭവവും പഠനവും എന്ന വിഷയത്തെ ആസ്പദമാക്കി സമഗ്രമായ ഒരു ശില്പശാല സംഘടിപ്പിക്കുകയാണ്. ഇതിൻ്റെ ലക്ഷ്യം നിപ്പയ്ക്കെതിരെ പൊതുജാഗ്രത ഉണ്ടാവുകയും നിലവിലുള്ള നമ്മുടെ പ്രവർത്തനങ്ങളെ വിലയിരുത്തുകയും ഇനി ആവശ്യമായിട്ടുള്ള പ്രവർത്തനങ്ങളെക്കുറിച്ച് ചർച്ച ചെയ്യുകയും അത് ആവിഷ്കരിച്ച് നടപ്പിലാക്കുന്നതിന് വേണ്ടിയിട്ടുള്ള പദ്ധതി തയ്യാറാക്കുകയും ചെയ്യുക എന്നുള്ളതാണ്. ഇന്ന് രാജ്യാന്തര നഴ്സസ് ഡേ ആണ്. ഈ ദിനത്തിൽ കേരളത്തിനകത്ത്, കേരളത്തിന് പുറത്തും, കേരളത്തിൽ നിന്ന് രാജ്യത്തിന് പുറത്തും ജോലി ചെയ്യുന്ന എല്ലാ നഴ്സസിനും ഈ ദിനത്തിൻ്റെ ആശംസകൾ നേരുകയാണ്. 2018 നിപ്പ ഔട്ട്ബ്രേക്ക് കോഴിക്കോട് ഉണ്ടായപ്പോൾ ത്യാഗനിർഭരമായിട്ടുള്ള, അക്ഷരാർത്ഥത്തിൽ തന്നിൽ നിന്ന് മറ്റൊരാളിലേക്ക് ഈ വൈറസ് പകരരുത് എന്ന ദൃഢനിശ്ചയത്തോടുകൂടി പ്രവർത്തിച്ച സിസ്റ്റർ ലിനി അടക്കം എല്ലാവരുടെയും ജോലി സംബന്ധമായി, തൊഴിൽ സംബന്ധമായി, തൊഴിലിനിടെ ഇതുപോലെയുള്ള കോവിഡ് കാലത്ത് ജീവൻ നഷ്ടപ്പെട്ട ആരോഗ്യ പ്രവർത്തകരുണ്ട്. എല്ലാ പ്രിയപ്പെട്ടവരുടെയും ഓർമ്മകൾക്ക് മുന്നിൽ സ്മരണാഞ്ജലി, ആദരാഞ്ജലി അർപ്പിക്കുകയാണ്. ഇന്ന് ഈ പരിപാടി സംഘടിപ്പിക്കുന്നത് ജെൻഡർ പാർക്കിലാണ്. സംസ്ഥാന വനിതാ ശിശു വികസന വകുപ്പിൻ്റെ ഒരു പ്രത്യേക പ്രോജക്റ്റാണ് ഈ ജെൻഡർ പാർക്കിലൂടെ ആവിഷ്കരിക്കപ്പെടുന്നത്. സംസ്ഥാനത്തെ ലിംഗ സമത്വ പദ്ധതികളെ നിരീക്ഷിക്കുന്നതിനും ഇതിൽ ഗവേഷണം നടത്തുന്നതിനും സർക്കാർ ആവിഷ്കരിക്കുന്ന വിവിധ പദ്ധതികൾ പ്രായോഗിക തലത്തിൽ ഏത് തലത്തിൽ നടപ്പാക്കപ്പെടുന്നു എന്നുള്ളത് ഉറപ്പാക്കുന്നതിനും അനുബന്ധമായി വിവിധ വകുപ്പുകളിൽ അല്ലെങ്കിൽ വിവിധ സംഘടനകളിൽ, വിവിധ സ്ഥാപനങ്ങളിൽ ജെൻഡർ ഇക്വാളിറ്റിയുമായി ബന്ധപ്പെട്ടിട്ടുള്ള പ്രവർത്തനങ്ങളെ ത്വരിതപ്പെടുത്തുന്നതിനും അതിന് നേതൃത്വം നൽകുന്നതിനുമുള്ള ഒരു ഇടമായിട്ടാണ് ജെൻഡർ പാർക്ക് വിഭാവനം ചെയ്യപ്പെട്ടിട്ടുള്ളത്. ഈ ജെൻഡർ പാർക്കിലെ ഈ ഓഡിറ്റോറിയത്തിൽ ആദ്യമായി നടത്തപ്പെടുന്ന ഔദ്യോഗിക പരിപാടി കൂടിയാണ് നമ്മുടെ നിപ്പ അനുഭവം പഠനമെന്ന ഈ ശില്പശാല എന്നുകൂടി പറയുവാനായിട്ട് ആഗ്രഹിക്കുകയാണ്. ഇന്ന് ഈ വർക്ക്ഷോപ്പിൽ പങ്കെടുക്കുന്നത് സംസ്ഥാനത്തെ ആരോഗ്യ മേഖലയിലുള്ള എല്ലാ ജില്ലകളിൽ നിന്നുമുള്ള ഞാൻ നേരത്തെ സൂചിപ്പിച്ച DMOമാരുണ്ട്, DPMമാരുണ്ട്, മെഡിക്കൽ എഡ്യൂക്കേഷനിൽ നേതൃത്വം നൽകുന്നവരുണ്ട്. ഇതുകൂടാതെ വനം മൃഗസംരക്ഷണ വകുപ്പുകളിലെ ഉദ്യോഗസ്ഥർ നേരിട്ടും അല്ലാതെയും ഓൺലൈനായി ഈ പരിപാടിയിൽ സംബന്ധിക്കുന്നുണ്ട്. ICMR-ഉം NCDC, NIV പൂനെ, NIV ആലപ്പുഴ, സംസ്ഥാന വൈറോളജി ഇൻസ്റ്റിറ്റ്യൂട്ട് ഇവയിലെ പ്രതിനിധികൾ ഇന്ന് നടക്കുന്ന വിവിധ ചർച്ചകളിൽ അവർ പങ്കെടുക്കുന്നുണ്ട്. നമുക്കറിയാം, നിപ്പ കേരളത്തിൽ ആദ്യം റിപ്പോർട്ട് ചെയ്തപ്പോൾ വാസ്തവത്തിൽ ഇതിനെക്കുറിച്ച് നമുക്കൊരു മുന്നറിവ് ഉണ്ടായിരുന്നില്ല. 2018 ഏറ്റവും അധികം പെട്ടെന്ന് അല്ലെങ്കിൽ മോർട്ടാലിറ്റി റേറ്റ് ഹൈ ആയിട്ടുള്ള ഒരു പകർച്ചവ്യാധിയാണ് നിപ്പ. 70 മുതൽ 100% വരെയാണ് ഇതിൻ്റെ മരണനിരക്ക് എന്ന് കണക്കാക്കുമ്പോഴാണ് നിപ്പയുടെ തീവ്രത അല്ലെങ്കിൽ അത് എത്രത്തോളം ഗൗരവതരമാണ് എന്നുള്ളത് നമുക്ക് പൊതുസമൂഹത്തിന് ബോധ്യപ്പെടുന്നത്. 1998 മലേഷ്യയിലാണ് ആദ്യമായി ഒരു ഔട്ട്ബ്രേക്ക് കണ്ടെത്തപ്പെട്ടിട്ടുള്ളത്. ആ സ്ഥലത്തിൻ്റെ പേരാണ് കാംപൂങ് സുംഭായ് നിപ്പ. ആ നിപ്പ എന്ന സ്ഥലത്തിൻ്റെ നാമധേയത്തിലാണ് ഈ പകർച്ചവ്യാധി അറിയപ്പെടുന്നത്. പിന്നീട് സിംഗപ്പൂരിൽ, അതിനുശേഷം വീണ്ടും ബംഗ്ലാദേശിൽ അതൊരു വലിയ ഔട്ട്ബ്രേക്ക് ആയിരുന്നു. 100 പേരോളം ഔട്ട്ബ്രേക്കിൽ മരണപ്പെട്ടു. വീണ്ടും 2004 അന്ന് പനങ്കള്ള് കഴിച്ചവരിലാണ് ഈ നിപ്പ രോഗബാധ ഉണ്ടായിട്ടുള്ളതായി കണക്കാക്കപ്പെടുന്നത്. 2018-ലും 2019-ലും കഴിഞ്ഞ വർഷവും 2021-ലും കോഴിക്കോട് 2 പ്രാവശ്യവും എറണാകുളത്തും റിപ്പോർട്ട് ചെയ്യപ്പെട്ടിട്ടുള്ള കേസുകൾ ICMR നടത്തിയ ജന്തുക്കളിൽ നിന്ന്, വവ്വാലുകളിൽ നിന്ന് ശേഖരിച്ച സാമ്പിളുകളിൽ നിന്നുള്ള പരിശോധനാ ഫലങ്ങൾ വ്യക്തമാക്കുന്നത് ഇത് പഴംതീനി വവ്വാലുകളിൽ നിന്നാകാം ഈ വൈറസ് മനുഷ്യരിലേക്ക് പകർന്നിട്ടുള്ളത് എന്നുള്ളതാണ്. 2018-ലും 2019-ലും ICMR പ്രസിദ്ധീകരിച്ചിട്ടുള്ള അവരുടെ ആർട്ടിക്കിളിൽ വവ്വാലുകളിൽ ലൈവ് വൈറസ് കണ്ടെത്തിയതായിട്ടാണ് അവർ പറയുന്നത്. 2021-ൽ, അതായത് കഴിഞ്ഞ വർഷം, ഒരു കുഞ്ഞിൻ്റെ മരണത്തിന് ഇടയാക്കിയ ആ ഒരു നിപ്പ ബാധ അന്ന് ICMR ഇവിടെ നടത്തിയ പഠനങ്ങളിൽ വളരെ വ്യാപകമായി നമ്മൾ അവിടെ ആ പ്രദേശത്തും തൊട്ടടുത്തുള്ള പ്രദേശങ്ങളിലുമെല്ലാം ഈ പരിശോധനകൾ, സാമ്പിളുകൾ കളക്ട് ചെയ്തിരുന്നു. മുൻ 2 വർഷങ്ങളിലും ലൈവ് വൈറസിൻ്റെ സാന്നിധ്യം കണ്ടെത്തിയെങ്കിലും 2021-ൽ ICMR നമുക്ക് നൽകിയ റിപ്പോർട്ട് അനുസരിച്ച് ഈ വവ്വാലുകളിൽ നിപ്പയ്ക്കെതിരെയുള്ള ആൻറ്റിബോഡിയുടെ സാന്നിധ്യമാണ് ഉള്ളത്. അപ്പോൾ ഈ ഘട്ടത്തിൽ പ്രത്യേകമായിട്ടുള്ള ഒരു മെൻഷൻ കൂടി അർഹിക്കുന്നുണ്ട് എന്ന് ഞാൻ കരുതുന്നു. അത് നമ്മുടെ ആരോഗ്യ പ്രവർത്തകരാണ്. 2018-ൽ നമുക്കൊരു മുന്നറിവുണ്ടായിരുന്നില്ല. 2021-ൽ നമുക്ക് ഈ ഒരു നിപ്പ രോഗബാധ ഉണ്ടായപ്പോൾ അത് ആരോഗ്യ പ്രവർത്തകരിലേക്കും മറ്റുള്ളവരിലേക്കും പകരാതിരുന്നത് അന്ന് നിലവിലുണ്ടായിരുന്ന ഒരു കോവിഡ് അപ്രോപ്രിയേറ്റ് ബിഹേവിയർ മൂലമാണ് എന്നുള്ളത് നമ്മൾ പ്രത്യേകമായി കാണേണ്ടതാണ്. മാസ്ക് ധരിക്കുകയും അതോടൊപ്പം തന്നെ PP കിറ്റൊക്കെ ഇടുകയും ആശുപത്രികളിൽ പ്രത്യേകിച്ച് കാഷ്വാലിറ്റികളിലൊക്കെ ഉൾപ്പെടെ ആ രീതിയിലുള്ള ഒരു ഇടപെടലും അങ്ങനെയുള്ള ഒരു കോവിഡ് അപ്രോപ്രിയേറ്റ്, ഇതിൽ കോവിഡ് അല്ല നിപ്പയാണ് പകരാതെ ഇരുന്നതെങ്കിൽ പോലും അങ്ങനെ ഒരു ബിഹേവിയർ ഉണ്ടായിരുന്നത് കൊണ്ടാണ് അത് കൂടുതലായി കഴിഞ്ഞ വർഷം മറ്റൊരാളിലേക്ക് പകരാതെ ഇരുന്നത് എന്നുള്ളത് കാണേണ്ടതാണ്. ഞാൻ പറയാൻ ആഗ്രഹിച്ചത് ആരോഗ്യ പ്രവർത്തകരുടെ നിസ്തുലമായിട്ടുള്ള സേവനമാണ്. നമുക്ക് നിലവിൽ സംസ്ഥാനത്തൊരു പ്രോട്ടോക്കോളുണ്ട്. നിപ്പയുമായി ബന്ധപ്പെട്ട് ഏത് രീതിയിലാണ് നമ്മുടെ സമീപനങ്ങൾ, അത് 2 രീതിയിൽ, ചികിത്സ സംബന്ധിച്ചും അല്ലാതെയും ഇത് കണ്ടെയ്ൻമെൻറ്റ് സംബന്ധിച്ചുമുള്ള സംവിധാനങ്ങൾ ഏത് രീതിയിലാകണം എന്നത് സംബന്ധിച്ച് നമുക്ക് വളരെ കൃത്യമായിട്ടുള്ള ഒരു പ്രോട്ടോക്കോളുണ്ട്. അപ്പോൾ ആ പ്രോട്ടോക്കോളിൻ്റെ അടിസ്ഥാനത്തിലാണ് അത് നമ്മുടെ അനുഭവത്തിൻ്റെ കൂടി അടിസ്ഥാനത്തിൽ നമ്മൾ ആവിഷ്കരിച്ചിട്ടുള്ള ഒരു പ്രോട്ടോക്കോളാണ്. ആരോഗ്യപ്രവർത്തകർ മാത്രമല്ല, ഇപ്പോൾ ഓരോ ജില്ലയിലെയും 2 ജില്ലകളിലും കോഴിക്കോടും എറണാകുളത്തും നമ്മുടെ മുഴുവൻ ടീമും ഒരു ജില്ല എന്നടങ്കം സർക്കാർ സംവിധാനങ്ങളെല്ലാം, സർക്കാർ മാത്രമല്ല പ്രൈവറ്റ് മേഖലയും 2 തവണയും പ്രൈവറ്റ് മേഖലയിൽ നിന്നാണ് ആദ്യം ഈ നിപ്പയാണ് എന്ന് കണ്ടെത്തപ്പെടുന്നത്. അപ്പോൾ അതുകൊണ്ട് പ്രൈവറ്റ് മേഖലയിലും സർക്കാർ മേഖലയിലും നടന്നിട്ടുള്ള വളരെ ശക്തമായിട്ടുള്ള പ്രവർത്തനങ്ങൾ, യോജിച്ചുള്ള പ്രവർത്തനങ്ങൾ, രാപ്പകലില്ലാതെ, രാത്രിയെന്നും പകലെന്നുമില്ലാതെ എല്ലാവരും നടത്തിയിട്ടുള്ള അത്യധ്വാനത്തെ കൂടി ഞാൻ ഈ അവസരത്തിൽ അഭിനന്ദിക്കുകയും ഏറ്റവും നന്ദിയോടുകൂടി ഓർക്കുകയും ചെയ്യുന്നു. നിശ്ചയമായിട്ടും ഇനി തുടർ പ്രതിരോധ പ്രവർത്തനങ്ങളിൽ അത് നമുക്കൊരു പ്രോത്സാഹനമാകും എന്നുള്ളതിൽ ഒരു സംശയവുമില്ല. ഈ ഘട്ടത്തിൽ നമുക്ക് വലിയ രീതിയിലുള്ള ജാഗ്രത, ഒരു അലേർട്ട്നെസ് നമ്മുടെ മുഴുവൻ സിസ്റ്റത്തിനും ഉണ്ടാകേണ്ടതായിട്ടുണ്ട്. അതിൽ പ്രധാനപ്പെട്ട ഒരു കാര്യം ആരോഗ്യ വകുപ്പുമായി ബന്ധപ്പെട്ട്, ചികിത്സയുമായി ബന്ധപ്പെട്ട് നമുക്ക് മസ്തിഷ്ക ജ്വരത്തിൻ്റെ എൻകഫലൈറ്റിസിൻ്റെ ഒരു സർവേ, അക്യൂട്ട് എൻകഫലൈറ്റിസിൻ്റെ ഒരു സർവേ ആവശ്യമായിട്ടുണ്ട്. ഇത് ഒരു മസ്തിഷ്ക ജ്വരം വരുന്നതിനുള്ള കാരണം എന്ത് എന്നുള്ളത് ഇതിൻ്റെ ഭാഗമായി നമുക്ക് അന്വേഷിക്കപ്പെടേണ്ടതുണ്ട്. ഇതിന് ഫീൽഡ് സർവേ കൂടി ആവശ്യമായി വരുന്നുണ്ട്. ഇത് കൂടാതെ നമ്മുടെ ചികിത്സ സംബന്ധിച്ച് മെഡിക്കൽ കോളേജുകളിലും അതുപോലെ തന്നെ മറ്റ് DHSന് കീഴിലുള്ള ആശുപത്രികളിലും ഈ ഒരു ജാഗ്രതയും ശ്രദ്ധയും അലേർട്ട്നെസ്സും ഉണ്ടാകുമ്പോഴും പുറത്ത് നമുക്ക് പൊതുസമൂഹത്തിൻ്റെ ഒരു ശ്രദ്ധയും ജാഗ്രതയും ഇതിലുണ്ടാകേണ്ടതാണ്. ഈ പ്രവർത്തനങ്ങളിലെല്ലാം 2018-ലും 19-ലും 21-ലും സർക്കാർ സംവിധാനങ്ങൾക്കൊപ്പം നിലനിന്നത് ഈ നാട്ടിലെ പൊതുസമൂഹമാണ്, പൊതുജനങ്ങളാണ്. അതോടൊപ്പം തന്നെ മാധ്യമങ്ങൾ വളരെ കൃത്യമായി ഈ വാർത്തകൾ ജനങ്ങളിലേക്ക് എത്തിക്കുന്നതിനും അവബോധം സൃഷ്ടിക്കുന്നതിനും മാധ്യമങ്ങൾ വളരെ കൃത്യമായിട്ടുള്ള പങ്ക് വഹിച്ചിട്ടുണ്ട്. ഇനി അങ്ങോട്ടുള്ള പ്രവർത്തനങ്ങളിലും ഈ പൊതുസമൂഹത്തിൻ്റെ പങ്കാളിത്തം നമുക്ക് ഉണ്ടാകേണ്ടത് അനിവാര്യതയാണ് എന്നും പൊതുസമൂഹത്തിൻ്റെ ശ്രദ്ധയും മാധ്യമങ്ങളുടെ പിന്തുണയും ഇക്കാര്യത്തിൽ ഉണ്ടാകണം എന്നുകൂടി ഈ അവസരത്തിൽ അഭ്യർത്ഥിക്കുവാനായിട്ട് ആഗ്രഹിക്കുകയാണ്. പ്രത്യേകമായ ചില കാര്യങ്ങൾ നമുക്ക് തദ്ദേശ വകുപ്പും വന്യജീവി വകുപ്പും മൃഗസംരക്ഷണ വകുപ്പും മറ്റ് ലൈൻ ഡിപ്പാർട്ട്മെൻറ്റ്സും അതോടൊപ്പം പൊതുസമൂഹവും നമുക്ക് ഒരുമിച്ച് പ്രവർത്തിക്കേണ്ടതാണ്. ഈ ഒരു സീസൺ പ്രത്യേകിച്ച് നമ്മൾ ശ്രദ്ധിക്കേണ്ടത് പൊതുസമൂഹത്തിൽ അത് ബോധവൽക്കരണ പ്രവർത്തനങ്ങളായി നടത്തണമെന്ന് ആഗ്രഹിക്കുകയാണ്. ഈ പഴങ്ങൾ, ഫ്രൂട്ട്സ്, അത് തൊലി പൊട്ടിയതും അല്ലെങ്കിൽ മുറിഞ്ഞതും കിളികളോ മറ്റ് വവ്വാലുകളോ ഒക്കെ കഴിച്ചതിൻ്റെ ബാക്കിയായിട്ടുള്ള പഴങ്ങൾ നമ്മുടെ കുഞ്ഞുങ്ങൾ പുറത്തേക്ക് പോകുമ്പോൾ, കളിക്കാൻ പോകുമ്പോൾ കളിക്കുന്ന ഇടത്ത് നിന്ന് അവരറിയാതെ തന്നെ ഇതെടുത്ത്, മാമ്പഴത്തിൻ്റെയൊക്കെ കാലമാണ്, അപ്പോൾ അത് കഴിക്കുന്ന ഒരു സാഹചര്യം ഉണ്ടാകാൻ പാടില്ല എന്നുള്ളതാണ്. ഇതിലുള്ള ഒരു സന്ദേശം പൊതുസമൂഹത്തിൽ നിലനിൽക്കുന്നുണ്ട്, പക്ഷേ അത് കുറച്ചുകൂടി ശക്തമായി നമുക്ക് കൊടുക്കേണ്ടതായിട്ട് ഉണ്ട്. ഇതോടൊപ്പം വാട്ടർ സോഴ്സസ്, ഇപ്പോൾ കഴിഞ്ഞ 2021 അതിനടുത്തൊരു പുഴയുണ്ടായിരുന്നു. അതിൽ ഈ മരങ്ങളുടെ അല്ലെങ്കിൽ ഇങ്ങനെയുള്ള വവ്വാലുകളുടെ ഹാബിറ്റാറ്റ്സ് ഉള്ള സ്ഥലങ്ങളിലെ വെള്ളം പ്രത്യേകിച്ചും അത് കുടിവെള്ളം ഉപയോഗിക്കുമ്പോൾ അത് തിളപ്പിച്ച് നന്നായിട്ട് ബോയിൽ ചെയ്തതിന് ശേഷം മാത്രമേ അത് ഉപയോഗിക്കാവൂ എന്നുള്ളതാണ്. അപ്പോൾ അങ്ങനെയുള്ള ബോധവൽക്കരണ പ്രവർത്തനങ്ങൾ ആരോഗ്യ വകുപ്പ് എന്നുള്ള രീതിയിലും തദ്ദേശ വകുപ്പ് എന്നുള്ള രീതിയിലും നമുക്ക് പൊതുവായി സമൂഹത്തിലേക്ക് നൽകേണ്ടതായിട്ടുണ്ട്. അതുപോലെ തന്നെ പ്രധാനപ്പെട്ട ഒരു കാര്യമാണ് നമ്മുടെ അപ്രോപ്രിയേറ്റ് ബിഹേവിയർ. മാസ്ക് ധരിക്കുന്നതും ഗ്ലൗസ് ധരിക്കുന്നതും PP കിറ്റ് ധരിക്കുന്നതും ഒക്കെ തന്നെ ഈ കോവിഡ് കാലത്ത് നമ്മുടെ ശീലമാണ്. അപ്പോൾ അത് കൃത്യമായി നമ്മുടെ ആരോഗ്യ സംവിധാനങ്ങളിൽ അത് ഉണ്ടാകുന്നുണ്ട് എന്നുള്ളതും ഉറപ്പാക്കേണ്ടതാണ്. ഈ സാഹചര്യത്തിൽ ഇന്ന് നടക്കുന്ന ഈ സംസ്ഥാനതല ശില്പശാല ഏറ്റവും ഫലപ്രദമാകട്ടെ. നമ്മുടെ പ്രവർത്തനങ്ങൾ എവിടെ നിൽക്കുന്നു എന്ന് വിലയിരുത്തുന്നതിനും നമ്മൾ എവിടേക്കാണ് പോകേണ്ടത് എന്ന് മനസ്സിലാക്കുന്നതിനും അതിനുള്ള നിർദ്ദേശങ്ങൾ ഉരുത്തിരിയുന്നതിനും ഇന്നത്തെ ഈ ശില്പശാല സഹായകരമാകട്ടെ എന്ന് ആഗ്രഹിക്കുകയാണ്, ആശംസിക്കുകയാണ്. ഇപ്പോൾ നമുക്ക് കോഴിക്കോട് ഇതിനോടനുബന്ധിച്ച് ചില അടിസ്ഥാന സൗകര്യ വികസനങ്ങൾ കൂടി പാരലലായിട്ട് സമാന്തരമായി നമുക്ക് നടക്കേണ്ടതായിട്ടുണ്ട്. അതിലൊന്ന് നമ്മുടെ കോഴിക്കോട് മെഡിക്കൽ കോളേജിലുള്ള ലാബുമായി ബന്ധപ്പെട്ടിട്ടുള്ള കാര്യമാണ്. അത് കേന്ദ്ര പൊതുമരാമത്ത് വകുപ്പാണ് അതിൻ്റെ നിർമ്മാണം നടത്തുന്നത്. കേന്ദ്രവുമായി നിരന്തരം ബന്ധപ്പെട്ടുകൊണ്ട് അതിൻ്റെ നിർമ്മാണം ത്വരിതപ്പെടുത്തുന്നതിന് വേണ്ടിയിട്ടുള്ള നിരന്തര അഭ്യർത്ഥനകൾ നടത്തുന്നുണ്ട്. അതുപോലെ തന്നെ നമുക്ക് നമ്മുടെ വൈറോളജി ഇൻസ്റ്റിറ്റ്യൂട്ട്, അത് ഒരു റീജിയണൽ വൈറോളജി ഇൻസ്റ്റിറ്റ്യൂട്ടായി അത് ഉയർത്തപ്പെടേണ്ടതായിട്ടുണ്ട്. അപ്പോൾ ഇത് ICMRന് മുൻപാകെ നമ്മുടെ ഒരു ആവശ്യമാണ്. അപ്പോൾ ആ രീതിയിൽ ഈ വൈറോളജി ലാബിനെ ആ രീതിയിൽ ഉയർത്തുന്നതിന് വേണ്ടിയിട്ടുള്ള കേരളത്തിൻ്റെ ഒരു ആവശ്യവും ഉണ്ട് എന്നുള്ളതും, അത് ICMRുമായി ഇക്കാര്യത്തിൽ ആശയവിനിമയം നടത്തിയിട്ടുണ്ട് എന്നുള്ളതും കൂടി അറിയിക്കുന്നതിന് ഈ അവസരം ഉപയോഗിക്കുന്നു. ഞാൻ എൻ്റെ വാക്കുകൾ ചുരുക്കുകയാണ്. ഈ കോൺഫറൻസിൽ സംബന്ധിക്കുന്ന, ഈ വർക്ക്ഷോപ്പിൽ സംബന്ധിക്കുന്ന എല്ലാവരോടുമുള്ള നന്ദി അറിയിക്കുന്നു. നിങ്ങളെല്ലാവരും സമയം കണ്ടെത്തി ഇതിലേക്ക് സംബന്ധിച്ചതിൽ നന്ദി അറിയിക്കുന്നു. നമുക്കിവിടെ മാത്രമല്ല, കോഴിക്കോട് എറണാകുളത്ത് മാത്രമല്ല, നമ്മുടെ ഒരു വെസ്റ്റേൺ ഗട്ട്സിൻ്റെ ചരിവിലുള്ള മുഴുവൻ പ്രദേശങ്ങളിലും, അതോടൊപ്പം തന്നെ എല്ലാ ജില്ലകളിലും ഈ ഒരു ജാഗ്രത ഉണ്ടാകേണ്ടതാണ്. അപ്പോൾ അതിനുവേണ്ടിയാണ് എല്ലാവരും ഇതിൽ സംബന്ധിക്കണം, എല്ലാ ജില്ലകളിൽ നിന്നുമുള്ള ഉത്തരവാദിത്തപ്പെട്ടതിൽ സംബന്ധിക്കണം എന്നുള്ളത് ആവശ്യപ്പെട്ടത്. എല്ലാവരോടുമുള്ള എല്ലാവിധമായിട്ടുള്ള നന്ദിയും അറിയിച്ചുകൊണ്ട് ഏറ്റവും നന്നായി ഈ വർക്ക്ഷോപ്പ് സംഘടിപ്പിക്കപ്പെടട്ടെ എന്ന് ആശംസിച്ചുകൊണ്ട് ഔപചാരികമായി ഈ ശില്പശാലയുടെ ഉദ്ഘാടനം നിർവഹിക്കുന്നതായി അറിയിച്ചുകൊള്ളുന്നു. നന്ദി, നമസ്കാരം.
Thank you, ma'am, for those really insightful words. Next, we have our chief guest, Advocate P.A. Mohammad Riaz, the Honorable Minister for Public Works and Tourism, to address the gathering.
ബഹുമാനപ്പെട്ട ആരോഗ്യമന്ത്രി, ബഹുമാനപ്പെട്ട വനം വന്യജീവി വകുപ്പ് മന്ത്രി, വേദിയിലും സദസ്സിലുമുള്ള ബഹുമാന്യരെ, ആരോഗ്യ പ്രവർത്തകരെ, കേരളത്തിലാകെ പരിഭ്രാന്തിയിലാക്കുന്ന നിപ്പ വൈറസ് ബാധയെ അതിജീവിച്ചതിനെ സംബന്ധിച്ചുള്ള വർക്ക്ഷോപ്പിന് എല്ലാവിധ ആശംസകളും നേരുന്നു. കേരളത്തിലെ ആരോഗ്യ വകുപ്പിനെ സംബന്ധിച്ചും മറ്റു വകുപ്പുകളെ സംബന്ധിച്ചുമെല്ലാം ഏറെ പ്രശംസനീയമായ പ്രവർത്തനം നടന്ന ഘട്ടമാണ് നിപ്പ ബാധിത ഘട്ടം. സർക്കാരിന് ജനങ്ങൾക്കൊപ്പം നിന്ന് ജനങ്ങളുടെ പരിഭ്രാന്തി അകറ്റുവാനും ജനങ്ങളോടെല്ലാം കമ്മ്യൂണിക്കേറ്റ് ചെയ്യുവാനും ഈ ഘട്ടത്തിൽ സാധിച്ചു എന്നുള്ളതും പ്രത്യേകം ഞാനിവിടെ പറയാൻ ആഗ്രഹിക്കുന്നു. ഇതുവരെ പരിചിതമില്ലാതിരുന്ന രോഗത്തെ നാം നേരിട്ടതിൻ്റെ അനുഭവം പങ്കിടുന്നതും പരിശോധിക്കുന്നതും മാതൃകാപരമായൊരു പ്രവർത്തനമാണ്. ഇത്തരം അനുഭവങ്ങൾ പുതിയ തലമുറക്ക് പകർന്നു നൽകാനും അവരെ പരിചിതമാക്കാനും ഇത്തരം സെമിനാറുകൾ ഗുണം ചെയ്യും. 2 ഘട്ടങ്ങളിൽ കോഴിക്കോട് ജില്ല ഏറ്റവും മാതൃകാപരമായ പ്രവർത്തനമാണ് നിപ്പ പ്രതിരോധത്തിനായി കാഴ്ചവെച്ചത്. ആദ്യഘട്ടത്തിൽ മെയ് 17 നിപ്പ റിപ്പോർട്ട് ചെയ്തത്. അന്ന് വലിയ ആശങ്ക നമുക്ക് മുന്നിലുണ്ടായിരുന്നു. എന്നാൽ നിലവിലുള്ള രോഗബാധിതരിൽ നിന്നും കൂടുതൽ പേരിലേക്ക് രോഗം പോകാതിരിക്കാൻ നമുക്ക് കൂട്ടായ്മയിലൂടെ സാധിച്ചു. നല്ല പ്രതിരോധ പ്രവർത്തനമായിരുന്നു നടത്തിയത്. 2ാം ഘട്ടത്തിൽ ഒരാളിൽ തന്നെ ഒതുക്കി നിർത്താനും കഴിഞ്ഞ നമ്മുടെ നേട്ടമാണ്. 2ാം ഘട്ടത്തിൻ്റെ സമയത്ത് കോഴിക്കോട് കേന്ദ്രീകരിച്ച് ആരോഗ്യവകുപ്പ് മന്ത്രിയോടൊപ്പം ആരോഗ്യ പ്രവർത്തകരോടൊപ്പം ഈ പ്രതിരോധ പ്രവർത്തനത്തിൽ പങ്കെടുത്ത അനുഭവം അത് ജീവിതത്തിൽ ഒരിക്കലും മറക്കാൻ പറ്റാത്തതാണ്. എത്രത്തോളം സജീവമായിട്ടാണ്, ആസൂത്രിതമായിട്ടാണ്, ടീം വർക്ക് എന്ന നിലയിലാണ് കോഴിക്കോട്ടെ ആരോഗ്യ പ്രവർത്തകർ മുന്നോട്ട് പോകുന്നത് എന്നുള്ളത് നേരിട്ട് ബോധ്യപ്പെട്ട സമയമായിരുന്നു ഈ സമയം. അത് എല്ലാ നിലയിലും പ്രശംസിക്കേണ്ട ഒരു പ്രവർത്തനമാണ്. ആരോഗ്യ പ്രവർത്തനങ്ങളെ, ആരോഗ്യ സംവിധാനങ്ങളെ ഒക്കെ ചലിപ്പിക്കുന്നതിനോടൊപ്പം തന്നെ നമുക്ക് ഇത്തരം സംവിധാനങ്ങളെയും ഫലപ്രദമായി യോജിപ്പിക്കാൻ സാധിച്ചിട്ടുണ്ട്. നിപ്പക്കെതിരായ പോരാട്ടത്തിൽ ജീവൻ നഷ്ടപ്പെട്ട സിസ്റ്റർ ലിനി ഉൾപ്പെടെയുള്ള ആരോഗ്യ പ്രവർത്തകരെല്ലാം ഈ ഘട്ടത്തിൽ നമുക്ക് പ്രചോദനമാണ്, ഊർജ്ജമാണ്, കരുത്താണ്. ആരോഗ്യ സംവിധാനത്തെ ആകെ കൂടുതൽ ജനകീയമാക്കുവാനും ശക്തിപ്പെടുത്തുവാനും ഇത്തരം ശില്പശാലകൾ തീർച്ചയായിട്ടും ഉപകരിക്കും. എല്ലാവർക്കും നന്ദി, നമസ്കാരം.
We have among us the Honorable Minister for Forest and Wildlife, Sri A.K. Shashidharan, as our chief guest today. I kindly invite you, sir, to felicitate the gathering.
പ്രിയപ്പെട്ട അധ്യക്ഷൻ, പ്രിയങ്കരനായ MLA ശ്രീ തോട്ടത്തിൽ രവീന്ദ്രൻ, നമ്മുടെ ഈ സംസ്ഥാനതല വർക്ക്ഷോപ്പിൻ്റെ ഉദ്ഘാടന കർമ്മം നിർവഹിച്ച കേരളത്തിൻ്റെ ബഹുമാനിയായ ആരോഗ്യ, വനിതാ, ശിശു വികസന വകുപ്പ് മന്ത്രി ശ്രീമതി വീണ ജോർജ്, ബഹുമാനപ്പെട്ട പൊതുമരാമത്ത് വിനോദസഞ്ചാര വകുപ്പ് മന്ത്രി ശ്രീ PA മുഹമ്മദ് റിയാസ്, അഡീഷണൽ ചീഫ് സെക്രട്ടറി ഡോക്ടർ ആശ തോമസ് IAS, ആരോഗ്യവകുപ്പിൻ്റെ പ്രിൻസിപ്പൽ സെക്രട്ടറി ഡോക്ടർ രാജനൻ കോബ്രേഗഡ് IAS, ഡോക്ടർ രത്തൻ കേൽക്കർ IAS, ഡോക്ടർ A കൗശികൻ IAS, ജില്ലാ കളക്ടർ ഡോക്ടർ തോമസ് മാത്യു, ഡോക്ടർ V മീനാക്ഷി, മെഡിക്കൽ കോളേജ് പ്രിൻസിപ്പൽ ഡോക്ടർ സജിത്, DMO ഡോക്ടർ ഫാറൂഖ് V, സ്വാഗതം ആശംസിച്ച ഡോക്ടർ VR രാജു ഉൾപ്പെടെ ഈ തികച്ചും പുതിയതായ ഈ വർക്ക്ഷോപ്പിൽ പങ്കെടുത്തുകൊണ്ടിരിക്കുന്ന സഹോദരി സഹോദരന്മാരെ, ഇക്കഴിഞ്ഞ 3 വർഷക്കാലം നമ്മുടെ സംസ്ഥാനം ദുരന്തങ്ങളുടെ നാടായിരുന്നു. ഏറ്റവും ഒടുവിൽ നാം അഭിമുഖീകരിച്ചുകൊണ്ടിരിക്കുന്നത് കോവിഡുമായി ബന്ധപ്പെട്ട തരംഗങ്ങളെയാണ്. പ്രകൃതി ദുരന്തം നമ്മെ വല്ലാതെ പ്രയാസപ്പെടുത്തുകയും ചെയ്തു. ഇതിൻ്റെ എല്ലാം തുടക്കത്തിലാണ് കോഴിക്കോട് ജില്ലയിൽ ചങ്ങരോത്ത് ഒരു അജ്ഞാത രോഗം പിടിപെട്ടതിൻ്റെ ഭാഗമായി രോഗികൾ ചികിത്സക്കെത്തുന്നു എന്ന വിവരം നമുക്ക് മനസ്സിലാക്കാൻ വേണ്ടി കഴിഞ്ഞത്. ഇവിടുത്തെ ഡോക്ടർമാർ വളരെ പെട്ടെന്ന് തന്നെ ഇതൊരു പ്രത്യേകതരം രോഗമാണ്, പ്രത്യേകതരം രോഗമാണ് എന്ന് മാത്രമല്ല വളരെ മാരകമായ ഫലങ്ങളുണ്ടാകുന്ന രോഗമാണ്. അടിയന്തര നടപടികൾ സ്വീകരിച്ചില്ലെങ്കിൽ അതൊരു ദുരന്തത്തിലേക്കാണ് അവസാനിക്കുക എന്ന് തിരിച്ചറിഞ്ഞതിൻ്റെ ഫലമായി യുദ്ധകാലാടിസ്ഥാനത്തിലുള്ള പ്രവർത്തനങ്ങൾ നമ്മൾ നടത്തുകയുണ്ടായി. ബഹുമാനപ്പെട്ട ആരോഗ്യമന്ത്രിയും പൊതുമരാമത്ത് വകുപ്പ് മന്ത്രിയും ഇവിടെ സൂചിപ്പിച്ചതുപോലെ യുദ്ധകാലാടിസ്ഥാനത്തിൽ തന്നെ പ്രവർത്തനങ്ങൾ ആരംഭിച്ചു. ഒരു ദുരന്തമുഖത്ത് എങ്ങനെയാണ് നാം പെരുമാറേണ്ടത് എന്നതിനെ സംബന്ധിച്ച് വാചാലമായ അറിവ് നൽകുന്ന വലിയ അനുഭവമാണ് ഞങ്ങളെപ്പോലുള്ളവർക്ക് അന്നുണ്ടായത്. ആരോഗ്യമന്ത്രിയുടെ നേതൃത്വത്തിൽ ആശാ വർക്കർമാർ മുതൽ ആരോഗ്യവകുപ്പിൻ്റെ പ്രിൻസിപ്പൽ സെക്രട്ടറി ഉൾപ്പെടെയുള്ളവർ ഒരു ടീമായി മത്സരബുദ്ധിയോടെ അർപ്പണബോധത്തോടെ പ്രവർത്തിച്ചിരുന്ന ദൃശ്യങ്ങൾ നമുക്ക് കാണാൻ കഴിഞ്ഞു. പങ്കുചേരാൻ കഴിഞ്ഞ എനിക്ക് എൻ്റെ ജീവിതവും ഓർമ്മിക്കാൻ കഴിയുന്ന ദിവസങ്ങൾ ഞാൻ ഇപ്പോഴും കാത്തു സൂക്ഷിക്കുന്നുണ്ട്. അന്നവിടെ ടീം വർക്കിൽ അംഗങ്ങളായിരുന്നവർ ഇപ്പോഴും പരസ്പരം കാണുമ്പോൾ ആ ദിവസങ്ങളെക്കുറിച്ചാണ് ഓർക്കുക. അന്നത്തെ DHS മുതൽ എല്ലാവരും. അപ്പോൾ ഒരു ദുരന്തത്തെ നേരിടേണ്ടി വരുമ്പോൾ കാണിക്കേണ്ട അർപ്പണ മനോഭാവത്തിൻ്റെ പ്രതീകങ്ങൾ രൂപം എന്തായിരിക്കണം എന്നെല്ലാവരെയും പഠിപ്പിച്ച നാളുകളായിരുന്നു അത്. നമുക്ക് വളരെ വേഗം അതിനെ നിയന്ത്രിക്കാൻ കഴിയുകയും ചെയ്തു. ഇവിടെ ചൂണ്ടിക്കാണിച്ചതുപോലെ നഴ്സിംഗ് അസിസ്റ്റൻ്റായിരുന്ന ലിനിയുടെ മരണം നമ്മെ വേദനിപ്പിക്കുകയും ചെയ്യുന്നു. ഈ നേഴ്സ് അഖില ലോക നഴ്സസ് വാരാച ദിനമായ ഇന്ന് നമ്മളിവിടെ ഇരിക്കുമ്പോൾ ലിനിയുടെ സ്മരണയ്ക്ക് മുമ്പിൽ ആദരാഞ്ജലികൾ അർപ്പിക്കാനും ഈ സന്ദർഭം ഞാൻ ഉപയോഗപ്പെടുത്തുകയാണ്. പിന്നീടാണ് അതങ്ങ് മാറി എന്ന് നമ്മൾ ആശ്വസിക്കുമ്പോഴാണ് ഒരു ദിവസം ഏതാണ്ട് 12-12:30 മണിക്ക് ആരോഗ്യവകുപ്പ് മന്ത്രി എന്നെ വിളിക്കുന്നത്. ഇങ്ങനെയൊരു പ്രശ്നം കോഴിക്കോട് റിപ്പോർട്ട് ചെയ്തിട്ടുണ്ട്, മിനിസ്റ്റർ വന്നുകൊണ്ടിരിക്കുകയാണ് എന്നെന്നോട് പറഞ്ഞപ്പോൾ ഇവിടെ സൂചിപ്പിച്ചതുപോലെ 3 മണിക്കൂറിനകം പ്രാരംഭ പ്രവർത്തനങ്ങളുടെ മാസ്റ്റർ പ്ലാൻ തയ്യാറാക്കുകയുണ്ടായി. എത്ര ചടുലമായ വേഗത്തിൽ എത്ര കാര്യക്ഷമമായി അതുണ്ടാക്കിയത് എന്നത് ഓർക്കുമ്പോൾ നമുക്കിങ്ങനെയൊക്കെ കഴിയും, വേണമെന്ന് വിചാരിച്ചാൽ ഇങ്ങനെയൊക്കെ കഴിയും എന്ന് നാം തെളിയിച്ചു. അപ്പം നമ്മുടെ അർപ്പണബോധത്തിൻ്റെ കരുത്ത് തെളിയിച്ച ആ നാളുകൾ നാളെയും നമുക്ക് ഇത്തരം ദുരന്തങ്ങൾ അഭിമുഖീകരിക്കാനുള്ള വഴികാട്ടിയായി തീരും എന്ന് ഞാൻ ആശിക്കുകയാണ്. നമ്മളിപ്പോഴും പരീക്ഷണങ്ങൾ പൂർത്തിയാക്കിയിട്ടില്ല, അല്ലെങ്കിൽ പരീക്ഷണങ്ങൾ നടന്നുകൊണ്ടേയിരിക്കുകയാണ്. യഥാർത്ഥ കാരണം വവ്വാലിൽ നിന്ന് തന്നെയാണോ, മറ്റേതെങ്കിലും ജീവികളിൽ ഇതുണ്ടാകുന്നുണ്ടോ, അവർ മുഖാന്തരം ഈ രോഗമുണ്ടാകുന്നുണ്ടോ? അപ്പോൾ അത്തരം ചോദ്യങ്ങൾക്ക് തൃപ്തികരമായ ഉത്തരം കണ്ടെത്താനുള്ള ശ്രമത്തിലാണ് ഇന്ന് ആരോഗ്യവകുപ്പ് ഏർപ്പെട്ടുകൊണ്ടിരിക്കുന്നത്. ആ ശ്രമങ്ങൾക്ക് വഴികാട്ടിയാകാൻ ഈ വർക്ക്ഷോപ്പ് സഹായകമായി തീരണമെന്ന് ഞാൻ ആഗ്രഹിക്കുകയാണ്. പല രോഗങ്ങളുണ്ട്. ഇപ്പോൾ കഴിഞ്ഞ ആഴ്ചയാണ് മനുഷ്യന്മാർക്ക് മാത്രമല്ല ഇങ്ങനെ തിരിച്ചറിയാൻ കഴിയാത്ത രോഗങ്ങളുള്ളത് എന്ന് കഴിഞ്ഞ ആഴ്ചയാണ് എനിക്ക് മനസ്സിലായത്. നമ്മുടെ മൂന്നാർ മേഖലയിലെ മറയൂരിൽ 2400 ചന്ദന മരങ്ങൾക്കൊരു വൈറസ് ബാധിച്ചിട്ടുണ്ട്. പകർച്ചരോഗമാണത്. തൊട്ടടുത്ത വൃക്ഷങ്ങളെയും ബാധിക്കും. 2400 ചന്ദന മരങ്ങൾ എന്ന് പറഞ്ഞാൽ കോടികളാണ്. എന്താണ് കാരണം എന്ന് കണ്ടുപിടിക്കാൻ കഴിയില്ല. എന്താണ് ചികിത്സ എന്ന് കണ്ടുപിടിക്കാൻ കഴിഞ്ഞിട്ടില്ല. ബാംഗ്ലൂരിലെയും ചെന്നൈയിലെയും പീച്ചിയിലെയും നമ്മുടെ റിസർച്ച് സെൻ്ററുകളിൽ വർഷങ്ങളായി പരിശോധന നടത്തിയിട്ടും പരീക്ഷണങ്ങൾ നടത്തിയിട്ടും ഉത്തരം കണ്ടെത്തില്ല. അപ്പോൾ ഇങ്ങനെ ഉത്തരം കണ്ടെത്താൻ കഴിയാത്ത മാരകമായ പകർച്ചവ്യാധികളെ എങ്ങനെ നേരിടാൻ എന്താണ് എന്ന് ഉത്തരം കണ്ടുപിടിക്കുന്നതിലേക്കുള്ള ഒരു വഴികാട്ടിയായും നമ്മുടെ ഈ ചർച്ചയും ഈ വർക്ക്ഷോപ്പും മാറട്ടെ എന്ന് ആശിച്ചുകൊണ്ട് ഈ പ്രവർത്തനങ്ങൾക്കെല്ലാം എല്ലാവിധ ഭാവുകളും നേർന്നുകൊണ്ട് ഈ 2-3 ഘട്ടങ്ങളിൽ പകർച്ചവ്യാധിക്കെതിരെ പോരാട്ടത്തിൻ്റെ വളണ്ടിയർമാരായി പ്രവർത്തിച്ച, വളണ്ടിയർമാരെ പോലെ പ്രവർത്തിച്ച എല്ലാവരെയും അഭിനന്ദിച്ചുകൊണ്ട് ഇത്തരം പ്രവർത്തനങ്ങൾ ഭാവിയിൽ നമ്മുടെ ദുരന്ത നിവാരണ പ്രവർത്തനങ്ങൾക്ക് മാതൃകയാകട്ടെ എന്നുകൂടി ആശിച്ചുകൊണ്ട് ഈ ചടങ്ങിൽ പങ്കെടുക്കാൻ സാധിച്ചതിലുള്ള സന്തോഷം രേഖപ്പെടുത്തിക്കൊണ്ട് എൻ്റെ വാക്കുകൾ ഉപസംഹരിക്കുന്നു. നിങ്ങൾക്ക് നന്ദി.
Thank you, sir, for joining us today and enlightening us with your words.
We now have Dr. Asha Thomas, IAS, the Additional Chief Secretary, Personnel and Administrative Reforms and Health and Family Welfare of the Medical Education Department. We kindly invite you to felicitate the gathering. Moving on, now we have Dr. Rajan N. Kozhikode, IAS, the Principal Secretary of the Health and Family Welfare Department, to felicitate the gathering.
Respected President of today's function, Chief Guest, and our Honorable Health Minister, Madam Veena George, and all the distinguished guests on the dais, it is indeed our pleasure that such a apt and appropriate workshop has been arranged today by the Department of Health and Family Welfare. As I am participating in the next session, so I will use my time during the allotted session. I wish all the best for this endeavor, and on this occasion, we give our commitment to Honorable Chief Minister, Honorable Health Minister, Honorable Forest Minister, and all others that we will work together in such a way that we will face any consequences as a health emergency, especially Nipah, and we will try our level best that there will not be a single case of Nipah during this financial year. Thank you very much.
Thank you, sir, for those wise and insightful words. Now we have Dr. Ratan Kelkar, IAS, the State Mission Director of the National Health Mission, to address the gathering. Next, we have Dr. Arun Zakaria, the Chief Forest Veterinary Officer. I invite you, sir, to felicitate the gathering.
ബഹുമാനപ്പെട്ട തോട്ടത്തിൽ രവീന്ദ്രൻ സാർ, ബഹുമാനപ്പെട്ട ആരോഗ്യമന്ത്രി, ബഹുമാനപ്പെട്ട ഫോറസ്റ്റ് മിനിസ്റ്റർ ശശീന്ദ്രൻ സാർ, ബഹുമാനപ്പെട്ട പൊതുമരാമത്ത് മന്ത്രി മുഹമ്മദ് റിയാസ് സാർ, വേദിയിൽ ആശ തോമസ് മാഡം, രാജൻ കോബ്രഗഡെ സാർ, രത്തൻ കേൽക്കർ സാർ, ഞാൻ എൻ്റെ ഹെഡ് ഓഫ് ദ ഫോറസ്റ്റ് ഫോഴ്സിൻ്റെയും ഫോറസ്റ്റ് ഡിപ്പാർട്ട്മെൻറ്റ് ഹെഡ് ഓഫ് ദ ഫോറസ്റ്റ് ഫോഴ്സിൻ്റെയും ഫോറസ്റ്റ് ഡിപ്പാർട്ട്മെൻറ്റിൻ്റെ പേരിലാണ് സംസാരിക്കുന്നത്. ഇത്രയും പ്രൗഢഗംഭീരമായ ഒരു വർക്ക്ഷോപ്പ് സംഘടിപ്പിക്കാൻ കഴിഞ്ഞതിൽ ആരോഗ്യ കുടുംബക്ഷേത്ര വകുപ്പിനെ അതിൻ്റെ നേതൃത്വം നൽകിയവരെ അനുമോദിക്കുന്നു. ഞങ്ങളുടെ ഫോറസ്റ്റ് ഡിപ്പാർട്ട്മെൻറ്റ് യഥാർത്ഥ ജോലി ഇതുപോലത്തെ ഒരു ഔട്ട്ബ്രേക്കിൽ ഒരു സോഴ്സ് പലപ്പോഴും കണ്ടെത്തുക എന്നുള്ളതാണ്. ആ സോഴ്സ് മാനേജ്മെൻറ്റ് എവിടെയാണ് ഇതിൻ്റെ ഒരു യഥാർത്ഥ വൈറസ് സോഴ്സ് കണ്ടെത്തുക. ഇത് നമ്മൾ 3 ഘട്ടങ്ങളിലും 3 ഔട്ട്ബ്രേക്കുകളിലും, മൂന്നാമത്തെ ഔട്ട്ബ്രേക്ക് എന്ന് പറയാൻ പറ്റില്ല, 3 ഘട്ടങ്ങളിലും നമ്മൾ വളരെ എഫക്റ്റീവായിട്ട് ചെയ്തിട്ടുണ്ട്. ഒരു സപ്പോർട്ടീവ് റോളാണ് ഞങ്ങൾക്കുള്ളത്. ഇനിയും അത് തുടരും എന്ന് ഹെഡ് ഓഫ് ദി ഫോറസ്റ്റ് ഫോഴ്സിൻ്റെ നിർദ്ദേശപ്രകാരം അറിയിക്കാൻ താല്പര്യപ്പെടുന്നു. എന്തായാലും ഇങ്ങനെ ഒരു വർക്ക്ഷോപ്പ് ഏറ്റവും ഗംഭീരമായി നടത്താൻ കഴിയുന്നതിലും ഇതിൻ്റെ ഒരു നല്ലൊരു പ്രൊഡക്റ്റീവ് ഔട്ട്കം വരാൻ സാധിക്കട്ടെ എന്നും ആശംസിക്കുന്നു. താങ്ക് യു.
Thank you, sir, for those insightful words. Next up, we have Dr. A. Kaushigan, IAS, the Director of Animal Husbandry Department, to felicitate the gathering.
Good morning, everybody. Honorable President of today's function, Honorable MLA Shri Totatil Ravindran, Honorable Minister for Health and Family Welfare, Srimati Veena George ma'am, Honorable Minister for PWD and Tourism, Shri P.A. Mohammad Riyaz sir. Honorable Minister for Forests and Wildlife, Shri A.K. Shashindra. Respected Principal Secretary, Dr. Rajan Kogrode sir. Head of the Forest Post, P.K. Keshavan sir. Dr. V.K. Raju, Director Health Services. Distinguished guests, our own Dr. Arun Zakaria, and dignitaries participating in this national and state level workshop. At the outset, let me convey my congratulations to the health department. I mean, be it Nipah, be it COVID, they have been doing excellent work. And I mean, we as a sister department, we are quite proud of associating with the health department in all endeavors, especially in all those One Health endeavors that the department has been, embarking upon. As far as Nipah is concerned, in particular, unlike the highly pathogenic avian influenza that we have, I mean, for HPAI, we have a very clear set of guidelines from Government of India. We have an action plan for the animal side of highly pathogenic avian influenza. The Department of Animal Husbandry and Dairying has come out with an action plan, which we have been successfully following and then nipping highly pathogenic avian influenza in the bud. But as far as Nipah is concerned, I mean, there is a vacuum. I mean, fortunately, I mean, as our health minister had pointed out here, I mean, I think we have only seen antibodies, Nipah antibodies in bat specimens. But of course, pigs are a species of concern. And fortunately, so far, we have not had the antigen being detected in pigs, be it wild pigs, be it domestic pigs. But in case there is a antigen detection happening in some animal, then what would be those set of protocols that the animal husbandry department will have to follow? So that there is a vacuum, and noting this, our Honorable Minister for Animal Husbandry, Dr. Chinchurani ma'am had posed this issue at the Government of India level, and Government of India is now in the process of framing those draft action plans so that whenever there is a Nipah outbreak in animals, or if there is some detection in animals, then the protocol should be followed will be laid down soon. So that will fill a gap. And of course, the Animal Husbandry Department is very keen to associate with all the departments, including especially the health department, so that under the One Health banner, we take care of zoonosis, food safety, as well as AMR. I think these are three major areas where there can be a lot of collaboration, and we are open to it, and we are very keen to associate with the health department. I salute the health department for this wonderful workshop, and as well as the yeoman work they have been doing, both in the face of Nipah as well as COVID. So thank you very much for this opportunity. Thank you.
Thank you for enlightening us with those wise words. Now, we have Dr.
Namaskar.
Dr. Narasimhagadi T.L. Reddy, IAS, the District Collector of Kozhikode, to speak a few words.
നമസ്കാരം. ബഹുമാനപ്പെട്ട ഉദ്ഘാടകൻ ആരോഗ്യ വകുപ്പ് മന്ത്രി ശ്രീമതി വീണ ജോർജ് അവർകൾ, ബഹുമാനപ്പെട്ട എ കെ ശശീന്ദ്രൻ മന്ത്രി അവർകൾ, വേദിക്കിലിരിക്കുന്ന ആരോഗ്യ വകുപ്പിൻ്റെ ഉയർന്ന ഉദ്യോഗസ്ഥരും സദസ്സിലിരിക്കുന്ന എല്ലാ മാന്യരെ, നമ്മുടെ കോഴിക്കോട് ജില്ല നിപ കോൺഫറൻസിന് വേദിയായത് വളരെ ഒരു പ്രാധാന്യമുള്ള കാര്യമാണ്. 2018 2021 2 തവണ നമ്മളെ ജില്ല നിപ എതിർത്തിട്ടുണ്ട്. സക്സസ്ഫുള്ളായിട്ട് നമ്മുടെ ഹെൽത്ത് വകുപ്പ് 2 തവണയും വളരെ ഫലപ്രദമായിട്ട് ഇടപെട്ട് നിപ്പാനെ നിയന്ത്രിക്കാൻ നമുക്ക് സാധിച്ചിട്ടുണ്ട്. ഇതിൻ്റെ പിന്നാലെ പ്രവർത്തിച്ചിട്ടുള്ള എല്ലാ ആരോഗ്യ പ്രവർത്തകരെ ആദ്യം അഭിനന്ദിക്കേണ്ടതുണ്ട്. അതുമാത്രമല്ല, ഇനി ഈ നിപ അതുപോലെ തന്നെ മറ്റ് ജന്തുജന്യ രോഗങ്ങൾ അവോയ്ഡ് ചെയ്യാനാണ് ഈ ഒരു കോൺഫറൻസ് സ്റ്റേറ്റ് ലെവലിൽ തന്നെ സംഘടിപ്പിച്ചിട്ടുള്ളത്. ഈ കോൺഫറൻസിനെ കൊണ്ട് ഞാൻ മനസ്സിലാക്കിയെടുത്തോളം ഉദ്ദേശിക്കുന്നത് വൺ ഹെൽത്ത് കോൺസെപ്റ്റ് സംസ്ഥാനം മൊത്തം പബ്ലിസൈസ് ചെയ്യാനും അതിൻ്റെ ഒരു മെസ്സേജ് ജനങ്ങളിലേക്ക് എത്തിക്കാനും എന്നാണ്. ജന്തുജന്യലും അനിമൽസ്, ട്രീസ്, ഹ്യൂമൻസ് എല്ലാവരും ഒറ്റ ഒരു എൻവിറോൺമെൻറ്റിലാണ് ജീവിക്കുന്നത്. അവരെല്ലാവരും ഹെൽത്തി ആയിരിക്കുമ്പോഴാണ് നമ്മുടെ സൊസൈറ്റിയിലെ ഇങ്ങനെയുള്ള ഡിസീസസ് വരാതിരിക്കാനും അത് നമുക്ക് ഫലപ്രദമായിട്ട് കൺട്രോൾ ചെയ്യാനും സാധിക്കുന്നത്. ഈ കോൺസെപ്റ്റ് ഈ ഒരു കോൺഫറൻസുകളിലൂടെ നല്ല രീതിയിൽ ജനങ്ങളിലേക്ക് എത്തട്ടെ. നമ്മുടെ ആരോഗ്യവകുപ്പ് എല്ലാ ജില്ലകളിലും കോഴിക്കോടിൽ നടന്ന മാതൃകാപരമായ നിപ പ്രതിരോധ കാര്യങ്ങളിൽ നിന്ന് പഠിച്ച് അവരും അവരുടെ വരാതിരിക്കട്ടെ, എന്നാൽ വന്നാൽ ഇങ്ങനെയുള്ള ഔട്ട്ബ്രേക്കിനെ ഫലപ്രദമായിട്ട് ഡീൽ ചെയ്യാനുള്ള കഴിവ് ഈ കോൺഫറൻസുകളിലൂടെ നേടട്ടെ എന്ന് ആശംസിച്ചുകൊണ്ട് ഞാൻ നിർത്തുന്നു. നന്ദി.
Thank you very much, sir, for those enlightening words. Now, we have Dr. Thomas Matthew, the Joint Director of the Medical Education Department, to felicitate the gathering.
ശരിയായ അതിഥികൾ, പ്രിയങ്കരായ സഹപ്രവർത്തകരെ, ബഹുമാന്യനായ രാജൻ കോബ്രഗഡെ സർ, ആരോഗ്യവകുപ്പിൻ്റെ നേതൃത്വത്തിൽ എല്ലാ മേഖലകളിലുള്ളവരെയും ഒത്തൊരുമിപ്പിച്ചുകൊണ്ട് നടത്തുന്ന ഈ വർക്ക്ഷോപ്പ് വലിയൊരു ഉത്തരവാദിത്തമാണ് നമുക്ക് നൽകുന്നത്, അഥവാ നമ്മുടെ മുമ്പിൽ വയ്ക്കുന്നത് എന്ന കാര്യം മറന്നുകൂടാ. ആരോഗ്യ വിദ്യാഭ്യാസ മേഖലയിൽ പ്രത്യേകിച്ചും ടെർഷറി കെയർ ആശുപത്രികളിൽ പ്രവർത്തിക്കുന്ന എല്ലാ വിഭാഗത്തിലും പ്രവർത്തിക്കുന്ന ഡോക്ടർമാരെ സംബന്ധിച്ച്, മെഡിക്കൽ വിദ്യാർത്ഥികളെ സംബന്ധിച്ചിടത്തോളം ഇത് ഒരു പുതിയ ഉത്തരവാദിത്വം അവരെ ഏൽപ്പിക്കുന്നതിന് തുല്യമാണ്. കാരണം ഇതിലൂടെ പകർന്നു കിട്ടുന്ന ഇൻഫർമേഷൻ, ഇതിൻ്റെ എല്ലാവിധമായ പ്രിവെൻറ്റീവ്, പ്രൊമോട്ടീവ്, ക്യൂറേറ്റീവ് എല്ലാ സ്ട്രാറ്റജികളും വിദ്യാർത്ഥി തലം മുതൽ അധ്യാപക തലം വരെ എത്തിക്കുവാനും ഇനിയും ഒരു ചെറിയ ഒരു അനക്കം പോലും നിതാന്തമായ ജാഗ്രതയിലൂടെ ഒരു കേസ് വന്നാൽ പോലും കണ്ടുപിടിക്കുവാനും അതിനെ തടയുവാനുമുള്ള കൂട്ടായ പ്രവർത്തനം നമ്മുടെ ഉത്തരവാദിത്തമായി നമ്മൾ ഏറ്റെടുക്കുന്നു എന്നുകൂടി ഈ വർക്ക്ഷോപ്പിന് അർത്ഥമുണ്ട്. ഈ വർക്ക്ഷോപ്പിന് എല്ലാവിധ നന്മകളും നേരുന്നു. നന്ദി, നമസ്കാരം.
Thank you, sir. Dr. V. Meenakshi, the Director of Health Services Public Health, and Dr. K.G. Sajid Kumar, Principal in charge of Government Medical College Kozhikode, have conveyed their regards and best wishes for the smooth conduction of this conference on Nipah, Kerala experiences and learning. I invite Dr. Umar Farooq, District Medical Officer of Health, Kozhikode, to address the gathering.
വേദിയിലും സദസ്സിലും ഇരിക്കുന്ന ബഹുമാനരെ, പ്രിയപ്പെട്ടവരെ, ഏകാരോഗ്യം അഥവാ വൺ ഹെൽത്തിൻ്റെ പ്രാധാന്യം, ആ കൺസെപ്റ്റിൻ്റെ പ്രാധാന്യം നമ്മെ ഓർമ്മിപ്പിക്കുന്ന അല്ലെങ്കിൽ നമ്മൾ ഓർമ്മിപ്പിക്കുന്ന വിധത്തിലായിരുന്നു കഴിഞ്ഞ വർഷങ്ങളുണ്ടായ സൂനോട്ടിക് വൈറൽ ഡിസീസ്, മാരകമായ സൂനോട്ടിക് വൈറൽ ഡിസീസായ നിപ രോഗം. നമുക്ക് അറിയാം, ഫലപ്രദമായി നമുക്കിതിനെ പ്രതിരോധിക്കാനും തുരത്താനും കഴിഞ്ഞു. അതോടൊപ്പം നമുക്കുണ്ടായ ആ അനുഭവ സമ്പത്ത്, കേരളത്തിനും വിശിഷ്യ കോഴിക്കോടും ഉണ്ടായ ആ അനുഭവ സമ്പത്ത് തീർച്ചയായും ഇന്ത്യക്ക് മാത്രമല്ല ലോകത്തിന് തന്നെ ഒരു പാഠമായിരുന്നു. അപ്പോൾ അത് ഉൾക്കൊണ്ടുകൊണ്ട് ഇന്നിവിടെ സംസ്ഥാന ആരോഗ്യവകുപ്പ് ഇവിടെ സംഘടിപ്പിച്ചിട്ടുള്ള ഈ വർക്ക്ഷോപ്പ് തീർച്ചയായും അതിൻ്റെ അനുഭവ സമ്പത്ത് അതുപോലെ തന്നെ ഇനിയുള്ള അതിനെ എങ്ങനെ തടയാനും എന്നുള്ള ക്ലാസ്സുകളടക്കമുള്ള ഫാക്കൽറ്റീസ് സംസ്ഥാനത്തിനകത്ത് മാത്രമല്ല സംസ്ഥാനത്തിന് പുറത്ത് ICMR അതുപോലെ തന്നെ NAV പൂന പോലുള്ള സ്ഥാപനങ്ങളിലെ ഫാക്കൽറ്റീസ് വരെ പങ്കെടുക്കുന്ന ഈ വർക്ക്ഷോപ്പ്, അതോടൊപ്പം തന്നെ ഈ വർക്ക്ഷോപ്പിൻ്റെ കൂടെ തന്നെ നമ്മൾ നമ്മുടെ ആക്ഷൻ പ്ലാൻ, ഗ്രൂപ്പ് തിരിഞ്ഞ ആക്ഷൻ പ്ലാനും ഉണ്ടാക്കുന്നുണ്ട്. തീർച്ചയായും ഞാനടക്കമുള്ള നമ്മുടെ ഡെലിഗേറ്റ്സിന് ഇത് ആരോഗ്യവകുപ്പ് നൽകുന്ന ഏറ്റവും ഈ രംഗത്തുള്ള വിഭവ സമൃദ്ധമായ ഒരു സദ്യ തന്നെയാണ്. തീർച്ചയായും അത് എല്ലാവരും അത് ഇതിൽ ഉൾക്കൊള്ളുന്നെന്നും മാത്രമല്ല ഈ നമ്മൾ സംഘടിപ്പിച്ചിട്ടുള്ള ഈ ജെൻഡർ പാർക്കിൽ നിങ്ങൾക്ക് ഈ ഉച്ചയ്ക്ക് 1 മണി മുതൽ 2 മണിയുള്ള സമയത്ത് ഇവിടെ പോസ്റ്റർ കോർണറുണ്ട്. അതോടൊപ്പം തന്നെ സൈറ്റ് സീയിങ്ങിനും നിങ്ങൾക്ക് സമയം ചെലവാക്കാമെന്നാണ്. ഒരു പുതിയ അനുഭവമായിരിക്കും കൂടി പറയാൻ ഈ സമയം ഉപയോഗിക്കുകയാണ്. മാത്രമല്ല ഈ പരിപാടിക്ക് ശേഷം വാലറ്ററി ഫംഗ്ഷനായിട്ട് നമുക്ക് സാൻഡ് ആർട്ട് കൂടി ഇവിടെ ഒരുക്കിയിട്ടുണ്ട്. എല്ലാവരും പരിപാടി കഴിഞ്ഞ് അതും കൂടി കണ്ടതിന് ശേഷമേ മടങ്ങിപ്പോകൂ എന്ന് കൂടി പറയുകയാണ്. ഞാൻ എൻ്റെ കർത്തവ്യത്തിലേക്ക് അടക്കാം. ഈ ഉദ്ഘാടന പരിപാടിക്ക് നന്ദി പറയുക എന്നാണ് എൻ്റെ ഉത്തരവാദിത്വം. നമ്മുടെ ബഹുമാനിയായ ആരോഗ്യ വകുപ്പ് മന്ത്രി ശ്രീമതി വീണ ജോർജ് തിരക്കുകൾക്കിടയിലും നമ്മുടെ ഈ പരിപാടിക്ക് വേണ്ടി മാത്രം ഇവിടെ വരികയും ഉദ്ഘാടനം ചെയ്ത് മടങ്ങും ചെയ്തുകൊണ്ട് മാഡത്തിന് എല്ലാവിധ നന്ദിയും കൃതജ്ഞതയും അർപ്പിക്കുകയാണ്. അതുപോലെ തന്നെ ഈ പരിപാടിയിൽ അധ്യക്ഷം വഹിച്ചത് നമ്മുടെ സ്ഥലം MLA തോട്ടത്തിൽ രവീന്ദ്രൻ സാർ അവർകളാണ്. സാറിനെയും ഈ നന്ദി അറിയിക്കുന്നു. മുഖ്യാതിഥികളായിട്ട് നമ്മുടെ പരിപാടിയിൽ പങ്കെടുത്ത് സംസാരിച്ച പൊതുമരാമത്ത് വകുപ്പ് മന്ത്രി ശ്രീ PA മുഹമ്മദ് റിയാസ്, അതുപോലെ തന്നെ വനവകുപ്പ് മന്ത്രി ശ്രീ AK ശശീന്ദ്രൻ അവർക്കും ഞാൻ എൻ്റെ സ്വന്തം പേരിലും ഐരോപ്പിൻ്റെ പേരിലും എല്ലാവിധ നന്ദി അർപ്പിക്കുന്നു. ഇവിടെ ആശംസകൾ അർപ്പിച്ച ഡോക്ടർ ആശ തോമസ് IAS, ഡോക്ടർ രാജൻ കോപ്രഗഡെ പ്രിൻസിപ്പൽ സെക്രട്ടറി ആരോഗ്യവകുപ്പ് കുടുംബക്ഷേമ വകുപ്പ്, ഡോക്ടർ രത്തൻ ഗോൽക്കറെ സ്റ്റേറ്റ് മിഷൻ ഡയറക്ടർ എന്നിവർക്കും പ്രത്യേകം നന്ദി അർപ്പിക്കുന്നു. അതുപോലെ തന്നെ ഇവിടെ പ്രിൻസിപ്പൽ ചീഫ് കൺസൾട്ടൻറ്റ് ശ്രീ PK കേശവൻ IFS, ഡയറക്ടർ മൃഗസംരക്ഷണ വകുപ്പ് ഡോക്ടർ A കൗശികൻ, നമ്മുടെ ജില്ലാ കലക്ടർ നരസിംഹ റെഡ്ഡി IAS അവർകൾ, നമ്മുടെ ഇവിടെ സ്വാഗതം പറഞ്ഞ നമ്മുടെ ബഹുമാന്യായ DHS ഡോക്ടർ VR രാജു അവർക്കും നന്ദി അർപ്പിക്കുകയാണ്. പിന്നെ ഇവിടെ സ്റ്റേജിലുള്ള മീനാക്ഷി മാഡം, അതുപോലെ ഡോക്ടർ സുജിത്ത്, ജോയിൻറ്റ് ഡയറക്ടർ ഇൻചാർജ് തോമസ് മാത്യു, പ്രിൻസിപ്പൽ ഇൻചാർജ് മെഡിക്കൽ കോളേജ് ഡോക്ടർ സജിത്ത്, കൂടാതെ ഇവിടെ എത്തിയിട്ടുള്ള എല്ലാ ഡെലിഗേറ്റ്സിനെയും ഒറ്റവാക്കിൽ നന്ദി അർപ്പിക്കുന്നു. അതുപോലെ മീഡിയ ബിസിനസിനെയും ഇവിടെയുള്ള എല്ലാ മീഡിയ ബിസിനസിനും നന്ദി അർപ്പിച്ചുകൊണ്ട് അധ്യക്ഷൻ്റെ അനുമതിയോടെ ഈ ഉദ്ഘാടന പരിപാടി നിർത്തിവെച്ചായിട്ട് അറിയിക്കുന്നു. നന്ദി, നമസ്കാരം.
Thank you very much, Dr. Roma, for those insightful words. Now, we will be moving on to the second session of the program on viral outbreaks and preparedness. The session will be moderated by Dr. Rajan N. Khobragade, the Principal Secretary for Health, and the panelists will be Dr. Priya Abraham, the Director of the National Institute of Virology in Pune, and Dr. Raman Ganga Kedkar, the former head epidemiologist at the ICMR.
Thank you very much, Master of Ceremony. In fact, my request to the host that, if possible, can, bring panelists also on the screen so that I think everybody will be able to see our esteemed panelists. So I'll take this opportunity to once again congratulate the organizers for organizing such a very apt and a specific workshop in context of Nipah, but how we can handle any kind of health adversities, especially the outbreaks of the epidemic, be it any pathogen. That is what we want to discuss today, and we will have a better understanding as this workshop ends. So it is indeed a very good opportunity for all of us. Along with me, our National Institute of Virology Director, Dr. Priya Abraham, Madam is with us, and also our Dr. Ganga Khedkar, who was head of epidemiology, is the head epidemiologist, retired from ICMR. He has been working in our sector for last 40 years, done pioneering work in HIV, later on in setting up various laboratories all over the country in order to understand how the diseases are behaving in our country and giving lead not only for the country but also internationally to do research. So with us, such esteemed faculties, Dr. Priya Abraham and Dr. Raman Ganga Khedkar, they are here with us, and we welcome both of them to this technical session. Briefly, in fact, the way I have planned this session is, as we have to bring the focus on the preparedness and also based on the past experience, what are the next steps, each of the geography in our context in the state of Kerala, what we need to take, do further. That is one area. So I will do the session in this way, just for information of our esteemed panelists, that we will start with the director NIV, and I will have a first round, so few areas which we can discuss, and then we will have a, if time permits, second round, and then we will go for sum up. In the meantime, if there are any kind of queries from the audience and also those who are working online, my request to Dr. Naveen and the team who are facilitating this online technical session, that we can request them to ask the question, and then you can put it in the chat box, and then from the chat box I will also keep on browsing, and then I will request our panelists if there is any response related to those queries. So with these few words, in fact, straight away, I would like to mention that Kerala Health is having excellent systems, and therefore, in fact, when any new disease pop up, in fact, we are succeeding to identify, and this is possible because not only in government setup but also in private setup, they are very much vigilant, and there is an excellent partnership. Now, as a result of that, in fact, many people, whenever I attend any meeting at the national or other forums, they ask me, how come these diseases are only happening or we are noticing from Kerala? So my answer is, in fact, if you are taking effort, then you will be able to identify the pathogen. And if you are keeping a blind eye, then you will say that, okay, this is not my turn, it is a day, So what is required is that our vigilance. What is that vigilance, and in what way lab diagnosis? Because if to identify, why the diseases are happening, what are the causes of diseases, and whether the disease is happening because of a particular pathogen, that we have to understand. So lab diagnosis plays a very vital role in all this scheme of things. Once we understand based on the diagnosis, then we can very well, go ahead with the not only a research related many other areas, but also how to control that particular disease or outbreak. So in context of that, I would request Dr. Priya to tell us that what all preparedness of lab diagnosis in context of Nipah in particular one should have, so that we will have an efficient system, and based on that we will take further action. Over to you, Dr. Priya.
Thank you very much, Dr. Khobragane sir. Let me start with felicitations to the honorable state and district level dignitaries, the esteemed clinicians, laboratorians, public health specialists who are present at this workshop, as well as delegates. And I want to congratulate the state of Kerala for holding the state level workshop on Nipah reflecting on the experiences of the past and the learnings. So in response to your question, sir, I think, first of all, our network has to be strengthened. Like you very rightly said, Kerala picks up diseases that other states don't pick up. It's probably because of a greater level of vigilance and awareness. So you may be aware that we have 4 virus reference diagnostic laboratories in Kerala itself, despite being a fairly small state. We have a regional level laboratory in Kozhikode itself, a state level laboratory in Alapi, which is our ICMR NIV's Kerala unit. We have 2 other VRDLs in Thrissur and in Thiruvananthapuram. So I feel that they need to have, they've already had a training after the 2019 outbreak with regard to biosafety, donning, doffing, handling of suspected specimens. But on a larger scale, I think all government colleges as well as VRDLs need to revisit one, the differential diagnosis and case definitions of diseases such as Nipah. Because in the lab, they should also be aware that there might be doctors who might call in and say, we have this particular presentation. So laboratory personnel must be aware of the criteria to have a suspicion of say, a Nipah case. And on a wider scale, all government medical colleges should be trained in the donning and doffing of PPE. It might be a retraining for some government laboratories, and also to follow the strict guidelines in the safe packaging and transportation of suspected clinical specimens to these 4 VRDLs. Obviously, testing for a dangerous pathogen like this cannot be expanded to innumerable set of laboratories. But we have 4 VRDLs who should take the leadership and should be stewards of being able to interrogate an unusual agent such as Nipah, a deadly agent, and therefore all government laboratories should be able to receive these samples, handle them safely, extremely safely, and package them as per standard international guidelines to these 4 VRDLs. At the VRDLs, we know even from the first outbreak itself, it was apparent that the state had to be given the capacity to do on-site testing. And because of that, a POC was developed and validated from an initiative from ICMR NIV. And you know that in the 2019 outbreak, this point of care test was actually used in that single case that was detected in 2019 in Ernakulam. And that allowed the lab involved to actually offer a 24/7 testing. And in 2021, again, because of the lab's enhanced capacity, testing was and confirmation was done within the state of Kerala with outside confirmatory testing from NIV Pune. And we know today the Kozhikode laboratory does have the POC machine. We had come there to teach them how to test, giving them the the PPE, the use of PPE, all the reagents. So they are well trained. This has to be disseminated also to Thrissur and Trivandrum. So I think it's just a matter of forming a very robust network.
Okay, thank you. Some quick points, related to correlated with the disease in particular. So I would like now Dr. Ganga Ketkar to tell us something about epidemiology and also strengthening of the field capacity to tackle Nipah in particular. And once we cover that area, then what are your views that, because today we know, suppose we take a sample and then, we detect Nipah, but if there are unknown virus and certain other, because of the zoonotic diseases spreading fast because of the climate change, then what should be the, our method of preparedness and futuristic plan of action?
Thank you, sir. With respect to how we should be handling Nipah now, if I was to say something, one fact that I would always say is whatever our past experiences are teaching us, it teaches one thing, that Nipah is not so rapidly spreading kind of an organism. You look at the past episodes of the outbreaks that have occurred, right? This is not so only because you have bat as the reservoir from where it is jumping into human beings. What is important to recognize is if it is that the pigs, the way one of the speakers in the inauguration said, perhaps it's going to change the kind of outbreak that may occur. Now, one fact that we need to remember is Kerala has a very strong hill system. One of the things which has happened and perhaps is documented by the success that you have seen after the first outbreak, there are no more deaths. You tend to see only a case or so. This is happening because of strong public health system and the initiatives that Kerala has started. That we need to remember, we need to retrain the medical colleges as well as those in private sector, because in last two episodes it was private sector which managed to pick up, just because we have been ensuring that they remember that Nipah could come and what are the classical symptoms and signs that are associated with it, and therefore early detection occurs, and when early detection occurs, containment tends to become very easy for that matter. What is also important for us to, if we want to curtail the spread of this outbreak, is to ensure that community is again made aware of the signs and symptoms, why Nipah occurs, what precaution they have to take before this occurs, because we have consistently seen this is a phenomena that you tend to see most often around May 15th, all the time. That's something which is critical, because these are fruit bats. We know the way the fruit bats can actually be coming in contact with human beings so easily during this period. So if we look at Bangladesh experience, they have been able to overcome this problem mainly through public education. So this is one thing which we have to remember. For Nipah, where we are fairly well placed, it's just reorientation of people, and we should be in a better position to try and stop this infection. Now, one thing which is also important for us to remember, that most often we tend to see this only one in last 3 years in Kerala, and that too in Kozhikode district. Now, does this mean that it is not occurring elsewhere? Perhaps it could be occurring. It's just that the public health surveillance mechanisms, the IDSP, has to ensure that the detection tends to occur of unknown disease X like syndromes that are occurring in the community, and they get reported for investigation. Now, the next issue that you asked, for Nipah, it's fine, whatever has happened. Now, how do we investigate others? If it comes to other organisms, that's going to be a bigger challenge. For Nipah, there is a classical thing that you tend to see in this zoonotic disease, that you will find that you will not be able to detect it early among animals, because animals are essentially asymptomatic, whether we talk of bats, whether we talk of pigs or whatever. So essentially, your detection system tends to focus more on human beings. But then when it comes to other emerging infections, you might suddenly find that the role for One Health, for the veterinary side or those who are from forestry, suddenly becomes important. Perhaps one thing which we may remember is KFD. In KFD, early detection essentially tends to depend on how the deaths are reported in monkeys, and then you move along. So every disease would have a different pattern to handle if we want to control this particular issue. Now, what is critical is to find out those undetected or those which are unknown syndromes that are occurring should be picked up by IDSP, and then one may have to use those syndromic algorithms to try and detect what organism may be causing it based on these algorithms, and then probably try and ensure that you would perhaps be using certain specific tests to diagnose. So one demand that may come up is for multiplex PCRs, and these multiplex PCRs would be extremely important to pick up what kind of organism is causing this particular syndrome, and then go by the classical POCs which you could utilize to discuss. I'm sorry, I might have forgotten the second half. I'm really sorry.
No problem, doctor. So, taking the lead from what just now you said, now suppose the state, takes, in fact, in our state, we are going on a e-health track. More than 500, 400 institutions are on e-health track, and very soon by this March, I think we will definitely cross more than, I think, 600 institutions. We are having around 1,500 institutions. So one will be definitely be able to get the morbidity patterns and also, the fatalities. So from that, as you have indicated, that one will be able to successfully identify which are the undetected syndromes. Now getting, in fact, undetected means there is a detection happening, but one would not have perceived it as it is a major problem. So one will definitely come to know that what is the pattern of, the syndromes which are occurring, and then one will be able to go in depth. So from that context, as in the case of NCD, we have taken one generic initiative that about 30 years, all the population once in a year, like for the many other executive health checkup, we will also go for the health checkup, and from the parameters one will be able to understand whether that individual is having diabetes or hypertension or COPD or other things. So that we are starting. So in context of communicable diseases, what is a generic strategy one should adopt in the state to identify whether there are any kind of a new thing popping up? Can we work out something futuristic way? So this is the question to both of you. From the diagnostic point of view, how one can look at it. And by bringing, like Dr. Raman Gangakedkar has very rightly pointed it out, a strong public health system, involvement of people will always generate a better response to tackle those diseases, whether we are having medicine in place or not. Because even with the prevention activity for centuries, our forefathers have been tackling some of the few diseases with a differential efficacy. So what should be our approach in context of communicable diseases? Yeah, Dr. Priya, you can go, and then we will request Dr. Gangakedkar to add on the points on this. Yeah.
Sure. So as Dr. Gangakedkar had said, and you have further, consolidated that, the approach is to involve not only the government laboratories and hospitals, as well as the private sector. Because we know a large number of our population does go to the private sector. So not only an awareness, but a strengthening of the private sector in terms of risk communication, telling them what are the good kits that are available to detect major pathogens of high consequence. For me, I would say, there is a nice document by the WHO called the Blueprint Priority Diseases. These are diseases for which they have a certain amount of public health emergency involved, because there are not necessarily efficacious drugs or vaccines for them. And amongst that, Nipah is one such. Nipah and other related Nipah viruses. Then we have, in the state of Gujarat and Rajasthan, which, it doesn't mean it needn't come down to, right down to the southern state of Kerala, is Crimean Congo hemorrhagic fever. There is also, Zika virus. Zika may not be causing fatalities, but what it can cause to the unborn child is something of grave concern. And we know last year, we had an outbreak of Zika from the Thiruvananthapuram district. Also, more high consequence pathogens would be viruses that have not yet come into our country, but those could be Ebola, Marburg, Lassa fever, yellow fever. We have the vector for it, but by some great providential, interference, we have not yet got yellow fever in our country. So actually in 2019, in August, again, all state level and district level VRDLs, I'm stressing on this is because we have to have a pan strengthening of laboratories. Since my mandate is to talk more from the laboratory angle, we have to have a pan strengthening of laboratories. And in August 2019, actually these VRDLs which I had mentioned were trained to handle pathogens like Ebola, Marburg, Crimean Congo hemorrhagic fever, yellow fever, and of course Nipah. So that was done in August of 2019. And after the second outbreak again of Nipah in Ernakulam, there was a subnational Ebola preparedness workshop for all rapid response teams, including the rapid response team from the state of Kerala. This happened in the latter part of 2019. So I think there is need, one, to train and retrain, right from awareness of the disease, what is the presentation, how to receive the samples, how to handle it or package them for transport to any of the VRDLs. Then, of course, for the VRDLs to be able to test them based on the syndromic approach, we are committed to provide them with reagents. Hopefully, we will work towards making more point of care assays so that it will be easier for smaller labs to be able to test. We have a point of care assay for KFD. KFD, as you know, is another threat in the Western Ghats. So I think one will be to know about what are the viruses when we have a particular syndrome, to know how to handle and transport and test them, and be able to enhance testing capacity with timely reporting to the regional VRDL.
Okay. Okay. So just to give you a pointer, Dr. Raman, is, based on your experience, the way we have rolled out sentinel surveillance for HIV, what I am toying with the idea, somewhere we have to start this. So what I am thinking is, we should make a matrix that these are the symptoms or, syndromes. And, for this, we should run this multiplex, we should run this test mandatory. Okay. Now with this, suppose we identify in 14 districts of Kerala, sentinel sites, or irrespective of the sentinel sites, suppose we, do the peg marking that these are the symptom complexes, and therefore following number of tests should be performed. And if we do it, in a methodical way, in fact, that will be a very good surveillance system which will be in place, which should be giving us an insight. So what are your views and further details regarding this? So can we do something which is very unique, which has not been yet tried out anywhere? And what we usually do is, it is totally dependent on the clinician's expertise, because unless and until clinicians are updated and have an open mind of differential diagnosis, even the simpler thing get missed out, So, and then the investigation would not happen. And eventually the case reaches to the fatality. And perhaps sometimes after, getting into that kind of a shock, then we start working. So to preempt everything, can we bring an efficient system based on some of the framework points what just now I mentioned to you? And can you just elaborate something on that?
Definitely, sir. There are a few things which I would say. No, firstly, no, what we need to do is go by syndromic approach. But when we think in terms of syndromic approach, does it not exist today in India? It does. NCDC, which conducts this IDSP program, is actually having the syndromes and what kind of investigation should be done. So one of the recommendations that we had recently made to the ministry when we were reviewing VRDLs as well as NCDC with respect to this was they need to have a better coordinated action. I think the work has to be distributed really well. One of the key challenges is everybody wants to do the genomics related work, which has value only up to an extent and nothing beyond. So one question which I had asked them that, why should people feel that NCDC's IDSP program is valuable to the state because state tends to feel they are able to do everything. When it comes to role of VRDL, suddenly you find NCDC feels, oh, they are able to do it. And this issue will become more complex because now you have all these sequencing machines placed across because of COVID, and this issue will become more complex. So vision of work is something which is very important. I don't see the reason why a state should not be doing the surveillance to an extent that they don't go to genomic work per se, but they could move up to the point that they report it to IDSP for further investigation, and then IDSP interacts with VRDLs and try to establish the diagnosis, and specific tests could be offered to them. Now, when we think in terms of these algorithms, syndromic algorithms, one of the things which we have to realize is we have to look at the sensitivity and specificity of these algorithms in picking up right kind of cases. Because one of the accusations that tends to come is, have you picked a new infection? No, you will not pick up a new infection unless you have tested these syndromes that you have and the tests that you are offering. So you will only then know whether you will be able to pick up right things. The second thing which we have to do, currently, if we actually look at what is
Sir,
happening,
sorry to interrupt.
find
Just a
that we are
kind
focusing on-
reminder that the time limit has been completed.
Okay. Yeah, go ahead.
So one of the things which we have to do is do Delphi across, whether it is state or the country at country level, to try and shortlist the organisms from the high-risk pathogen list, from emerging and re-emerging infections per se, and try to focus more on them in terms of developing capacity to diagnose. If there are no tests that are available, you should have one. Now, I'll give you a crude example. While I was at ICMR, we recognized that leptospira diagnosis was becoming very difficult. And therefore, a point of care test, to my mind, leptospira causes more public health problems. With climate change, it can cause far more problems because of the climate change issues itself. So we developed a POC, and this POC is also has been approved for the first time by DCGI. Now, those kinds of approaches can be developed by shortlist those organisms, map out the areas where I need to strengthen, whether it is for diagnostics, whether it is for the drugs, whether it is for development of vaccine. Third thing which you have to do is develop a vulnerability map. Now, unless I have a vulnerability map, I will not be able to go ahead and place in the entire intervention so easily at this point in time. So development of these vulnerability maps, and what is important for us, you will still, despite doing everything, you are also more likely to see that a new disease X tends to come, which you had not imagined. I would call disease X in quotes, not as a classical X, but it could be that you have not picked it up so far. That is the case, you should be in a position to develop diagnostics. What COVID has taught us. If you look at COVID diagnostics came from China and South Korea within a month of the report of the infection. They went so fast. Now that's a classical issue that both the systems, whether it is public health system or systems related to biomedical research, they need to be efficient in delivering the solutions, whether it is diagnostics, whether it is rapid drug development platforms or rapid vaccine development platforms. I think it is time player has to define one's own area and invest into it and ensure that the community remains prepared to detect or suspect an illness or suspect an outcome like death or hospitalization, which could be questionable, and they themselves go ahead and report it to the system. There are two ways in which things can always happen. One is through the healthcare professionals, the reporting can occur. But to my mind, what is most important, perhaps you have to involve the community in reporting what they don't understand and what they feel this is a sudden death. It can perhaps be or cluster of deaths are occurring because of some suspicious illness, which should be investigated either first by state or IDSP per se. But these mechanisms have to clearly evolve and well.
Okay, so I think there is some connectivity problem at. Okay.
No, I'm sorry.
No problem.
The coordination
connectivity problem. Yeah, but I think host is requesting us that we are up with our time, right? So
yeah, but what I would say is for
please go ahead.
For Kerala, there is a unique. No, just one line I would say.
Yes.
Kerala is uniquely positioned. Compared to rest of the country, you do not find that kind of collaborative approach that you are getting in Kerala from veterinary, from environment, from forestry, from public health. All these divisions are coming together. I think it would be good to pilot how One Health approach can come. So we tend to speak about One Health. There are no clearer strategies. Nowhere in the world, the One Health approaches are so well defined. I think it is time that we start with Kerala and develop a model for One Health surveillance. Over.
Yeah, thank you, Dr. Ganga Kedkar. Thank you, Dr. Priya. Just 2 lines, as Dr. Raman has said that we are having core competencies, we are having capacities, and also, we should develop the whole program of One Health. Just for the information of our experts and the audience, Kerala government has last year, our Honorable Chief Minister has already held a discussion with World Bank, and under Rebuild Kerala initiative, our Honorable Health Minister and Chief Minister has given us approval, and we are going ahead implementing One Health. Some pre-activities are already over, and on 17th of this month, Honorable Chief Minister is going to launch One Health program at the state level, and also 4 project districts to begin with, and we are going to expand One Health program in all the remaining 10 districts. So in 1 year's time, we will have a preliminary activity. Next year, it will be consolidation, and we are very confident that our One Health approach will have a synergy of all the laboratories of Fisheries Department, Animal Husbandry Department, Forest Department, and the Health Department, of course. So we will have a very good surveillance system. The second point, which I at the last asked both of you, as Dr. Priya has suggested, we will continue our effort of capacity building and strengthening our lab network. And 15th Finance Commission Award has given us excellent opportunity to improve lab network. And we will, work more in depth that what are the syndromic approaches, syndromes we are seeing, what are the symptoms, and for that already known pathogen related tests what we are having. And we will add on some more things just to explore whether the newer pathogen has already entered into our, vicinity. So that kind of a matrix we will inbuild so that our surveillance, on a different way will be strengthened. For that, I will have a continued discussion with the field level colleagues and also experts like both NIV and ICMR and also Dr. Raman. And with this, I conclude. I thank profusely to both Dr. Priya and Dr. Raman Ganga Khetkar, because with a short notice, both of them readily agreed to have this technical session. And we will have a further, action points to strengthen our response to not only Nipah, but any other pathogens, which I think as a health emergency we will have to face. Once again, I thank both of you and also our coordinator. Thank you very much. And now I leave it to the host. Over to you.
Thank you.
Thank you, respected dignitaries, for the valuable session on viral outbreaks and preparedness. Moving on to the third session for today's workshop on Kerala outbreak experience. The moderator for the session would be Dr. R, Head of Department of Emergency Medicine, Government Medical College, Kozhikode. The topics covered during this session would be Nipah surveillance by Dr. Sarla Nair, non-COVID DSO, Kozhikode, and Dr. Seethu Ponnu Thampi, Medical Officer, FHC, Pudupadi. Challenges faced in transportation, Dr. Ladika VR, JAMO, Kozhikode, and Arjun C, Medical Officer, CHC, Mepadi. Dying with Dignity by Dr. R.S. Gopakumar, Health Officer, Thiruvananthapuram. Public Health Interventions, Education Media Handling by Mr. Baby Nappali, District Mass Media Officer, Kozhikode. Declaration of Outbreak Containment by Dr. Jayasri, DMO Ernakulam, former DMO of Kozhikode. I invite the moderator and the speakers onto the dais. A kind reminder for the moderator and the speakers, the total time for this session would be 45 minutes and each speaker would get a time limit of 7 minutes. All speakers are kindly requested to adhere to this time slot as we are running short in our schedule.
Good morning, and from myself and on behalf of all those who are in the session, we extend our sincere thanks for giving us this opportunity and continuing to the learning or experiences that we had in Nipah 2018, 2019, and 2021. And after an energizing session by Dr. Rajan sir, Dr. Raman Ganga Khetkar sir, and Dr. Priya ma'am, we are moving on to this session, and I'm very straight away, because we are running late, I'll be moving to the session straight away, and I invite Sarla Nair, non-COVID DSO, Kozhikode, along with Dr. Seethu and Dr. Minu, but you can present her. Sarla can present her. You can. And we'll be discussing on Nipah surveillance, and the team with the Medical College, they were actively doing this and they're sharing their experience. Over to Dr. Sarla. Request all the speakers to stick to the time because the session is already late.
Good morning, everybody. As mentioned earlier, Kozhikode district witnessed 2 outbreaks of Nipah, one in 2018 and 2021. The first outbreak of 2018 of Kerala. It was the first outbreak. During that outbreak, due to lack of previous precedents or guidelines, it was the biggest challenge for us. So, during the 2018 outbreak, we had total 18 cases and 18 confirmed cases, and out of which 2 had survived. Coming to the chain of transmission, here the index case was a 26-year-old male who presented to a private hospital, to Taluk Hospital, Perambra, with fever, headache, and vomiting. He was admitted there on 4th of May. Then next day, due to worsening of symptoms, he was referred to Medical College Hospital. And by evening, he expired. At Taluk Hospital, Perambra, we had 4 primary contact cases. One was a staff nurse, 1 bystander, and 2 patients. Then household contacts, we had 3 cases. One was his father, brother, and aunt. At Medical College, we had 12 cases, primary contact cases, out of which 4 were from Malappuram district. And 4 cases from this were probable cases with epidemiological link and similar clinical features, which we got after active search of death records for AES, for ARDS and encephalitis during this period. We also had 3 secondary contact cases, 1 from Taluk Hospital Balisheri and 2 from Medical College Hospital. These are the health facilities where the cases had gone. There were 3 private hospitals, 1 medical college, and 2 Taluk hospitals. We had to trace contacts at all these institutions. Coming to the incidence of Nipah cases by the date of onset, we had the first case on 3rd of May, the onset was 3rd of May, and the last was 27th of May, and we had maximum cases between 11th of May and 17th of May. At the onset, we took a proper history of the case, identified the hotspots, and then we had to trace the contacts. Contacts were identified at hospital level, household contacts, and also the community level. Besides this, once the route map was ready and we made it public, we started receiving calls at our call center, and in fact, people started self-reporting. And this also helped us to complete our contact list. We traced 2,649 contacts, of which 45% were from the hospital contact, 21 were household contacts, and 34 were community contacts. These are the number of contacts traced for each Nipah case. All these contacts were contacted over the phone twice daily for symptom monitoring, and during the entire quarantine period, that is 21 days. And these symptomatics, if any, were referred to the patient management team who would decide the further management of these patients. We collected a total of 334 samples, out of which 18 turned out to be positive. Now, from the lessons that we learned from the previous 2018 outbreak, we were better equipped and could respond promptly during the 2021 outbreak. And also, due to the ongoing COVID pandemic, mask was in use and people were following safe practices. So we had a single case here. The single case here was a 12-year-old boy who was admitted at the private hospital in Kozhikode district. Before coming to this hospital, he had actually visited a private clinic, 2 private hospitals, medical college, and then he had come here. As this was a case of suspected case of AES, sample of this child was admitted on this child was admitted on 1st of September to this private hospital. On 2nd of November, 2nd of September, we sent the sample of this child for viral paneling. And we also informed the local PHC Chulur, about this case, and they had also visited this site. Report came as positive on 4th of September at night, and we could immediately start our control activities. The control room was established by the next morning itself at Government Guest House. We were able to trace 240 contacts at 6 places. out of which there were healthcare workers and non-healthcare workers. We had 166 healthcare workers, mostly from Medical College Hospital and also from MIMS Hospital. Our surveillance team contacted each and every person and monitored the symptoms, and also we also ensured quarantine. We had contacts from other districts also, like Malappuram, Wayanad, Kannur, Palakkad, Kottayam, Kollam, Ernakulam, and also Kasaragod district. And we had communicated this to the other districts also, and they also had helped us for follow-up activities ensuring quarantine. These contacts were assigned community volunteers who could be contacted if the control room did not get them over the phone. And these community volunteers were Kudumbashri workers, Panchayat members, and RRT members. Within 4 days, our CDMS software was also established, and so activities could be monitored by all concerned. Containment zone of 3 kilometers radius from the epicenter was first marked, which included 5 panchayats of Kozhikode district and 1 panchayat from Malappuram district, Varayur. In this zone, people were instructed to stay at home, and they were also given food kits with the help of LSGDs. Health volunteers surveyed this area, and awareness was given, posters and notices were distributed in this area. We surveyed a total of 16,732 houses with 76,074 people, out of which 13 were linked cases. And during the survey, we got 93 people with symptoms. Symptoms were mainly fever. And samples with the help of the mobile team was taken from 50 persons, and all came as Nipah negative, but then we got 19 cases of COVID positive from them. And after 21 days of monitoring, all the contacts were released from quarantine, starting from 15th of September, and the last was on 26th of September. And on 26th of September, restrictions imposed in the containment zone also was lifted. That is the surveillance activities.
Thank you, Sarita ma'am, for covering it in the allotted time. It's very easily said, and I think she tried to finish in 7 minutes. But the activity started. We were informed that there is something unusual and dangerous has happened. And on the same day, the activity started even before declaration. And it's a huge task. And the list will be as we work on it. And we should congratulate the team involved. Thank you so much. And now we move on to the next presenter. Challenges faced in transportation. Dr. Latika, Dr. Arjun, and the entire team was doing it. And I invite Dr. Latika to present. And this may not be that impressive, but we need to look back to 2018 when more people were dying and people were really afraid in transportation. Over to Latika.
Good morning. As soon as the first confirmation of case, first Nipah case confirmed, District Health Authority decided to have a dedicated transportation system in place because it has following benefits. First, quicker response to ensure delays. It is free of cost to the public. It will lessen the financial burden of the affected persons. maintains quarantine. During transit also, there is no risk of infection to the public. The ambulance staff is trained, so risk of infection to health personnel is also reduced. After every transport, the ambulance is disinfected and cleaned. When we introduced this idea to the ambulance drivers, initially there was a reluctance due to their fear of the disease and also lack of training. So, district collector chaired a meeting with the district health department, also with the ambulance association driver, and also Angels representative were also present. After that, a detailed training is given about infection control practices, PPE kit usage, and also disinfection of the vehicles. Adequate PPE kits were allotted to them. Also, further need, they are asked to collect it from nearest government health facility. Daily review meetings were held to improve the system. This is the flowchart we followed in the first outbreak in 2018. Medical officer identifies the person in need of transport. They informs the district health nodal officer. She assigns an ambulance in the nearest location. Then the patient is transported to the MCH triage. After every transport, the ambulance is disinfected in a dedicated space in Medical College compound. In the case of second outbreak, in September 2021, ongoing COVID-19 pandemic ensured an established transport system under COVID control cell with 31 108 ambulances and other private ambulances. The staff were already trained in infection control. So decision is made to allot 5 108 ambulances exclusively for Nipah transport, Nipah case transport. This is the flowchart we followed in 2021 outbreak. Suspected cases were in home quarantine. First, we transported the high-risk contacts immediately to the isolation ward in Medical College. Low-risk cases are kept at home. Their risk assessment done by district team every day. When they become symptomatic, the medical officer informs the control cell and they are transported in dedicated ambulances to the MCH isolation ward. Transportation also discharges were allotted by this dedicated ambulance. Conclusion, 92 high-risk contacts were transported in the second outbreak. Funeral also discharge services are provided by the control room. Take-home message, establishing a dedicated ambulance transport, which is managed by the control room in district itself, is a must in such pandemics. Thank you.
Thank you, Dr. Ladhiga. Transportation was a huge 24-hour responsibility, and on the first outbreak itself, the lesson we learned was training and empowering the ambulance drivers has actually taken away the fear. So similar situations, I think an empowered, trained system should be in place so that we can kickstart the activities. Thank you for the presentation. And the next is by Dr. Ardas Gobaguma, Health Officer, Thiruvananthapuram. He was the Health Officer in Kozhikode, and it's our responsibility to ensure that patients should be respected even in death, dying with dignity. Over to Dr. Gobaguma.
Thank you, ma'am. To all dignitaries in stage and on the dais and off the dais. As long as the body fluids are present in the body, virus remains infective. Post-death care and transports needs to be carried out in a scientific manner. Goal is to prevent further spread of the infection, both to the caretaker and general public, along with the keeping up the sensitivities of traditional practices of different religions. Resistance and anxieties of public and traditional crematorium staff was there. Lack of previous precedents or guidelines for management, because Nipah had set the trend. COVID continued almost the same SOP or standard operating procedures in the starting stage. Only minimal modification had happened till now. Containment of the spread of the infection was a challenge. Absence of support from relatives and ancillary staff due to fear and stigma of unknown disease. You know, that time all medias, print and press, all medias were very hype about this Nipah. So common public was very scared about it. Resistance and anxieties faced, fear of new, unknown and deadly virus, opposition against deviation from normal religious practices. That was a very big challenge, but with help of our Health Minister, Shailaj teacher, we had come over that part. Public resistance due to fear of pollution and spread of infection. First time problems hitherto unheard of case. No prior experience in managing post-death care. Real threat of transmission of infection. A standard operating procedure, nothing was there. And that time we made a standard operating procedure taking from the Ebola procedures. Exposure to Nipah virus is highly hazardous, as we know. Secretion and excretion from the decreased person are considered to be equally infectious. Like that of a living infected person, adequate precautionary measures have to be taken during handling such dead body, during transportation, washing and burial or cremation. However, due regard should be given to the sentiments of the relatives and prevailing local customs. Handling of human remains should be kept to the minimum. Personal handling the bodies or secretions should be wearing a PPE. Healthcare workers handling the dead body should provide information to the family members to follow the basic infection control precautions. At the hospital or the place of death, the remains should be placed in a air-sealed, leak-proof, fluid impermeable double-layer body bag. The body bags were not available on the initial cases, but after around, I think, 10 or 12 deaths, only body bags were available that time. And protective equipment worn by the personnel handling the dead body also should be utmost care, because after cleaning the body, he should change the PPE, and then if he is going for transportation, again he should have to wear another PPE. No family, relative or friend should be allowed to touch or kiss the dead body prior to the placing of air-sealed bag. Transport the body to the burial ground in a crematorium in dedicated hearse van. But hearse vans are not available over here, but this was the protocol created. And all crematorium or the burial ground rituals, it should be done, it should be minimum 3 meters of distance, and the mortal remains should not be touched. The persons are handling the dead body during the burial cremation should wear PPE, and these PPEs should be properly disinfected. In case of burial, that was the main part. You have to, usually burial will be on 6 feet, and here it should be of 10 feet depth. Sharp waste should be decontaminated and disinfected. Decontaminate the mortuary and the room where the dead body has been kept using hypochlorite or hydrogen peroxide. And hand wash with soap and water. During that time, all these hand sanitizer, hand wash were a new thing. But now, due to COVID, it is a common practice. The practical problems faced was educating laypersons regarding PPE and other protocols to be followed. Because most of the people who assisted me were either a common layman or corporation sanitation workers. Sometimes I got a little bit trained HIs. Disinfecting the ambulance used for transporting was the biggest problem we faced in our crematorium. Then social stigma due to fear psychosis was there. Nobody was, even if I go to some place, everybody will stand minimum 2 or 3 meters away from me. That was the fear that time. And we had to create temporary platforms, had to be set up on the crematorium premises. In a war footing base, we had done that. And non-related volunteers like Ivor Madam, who came for the cremation, they accepted the risk of Nipah and worked with me. And the denial of ambulance, ma'am had told that ambulance services, and chain was established only after the COVID. There is a denial of service stations to wash ambulance after transporting of the body was a big thing. It was solved by pipe line laying over night in the crematorium. It was made possible by excellent state government supports from district administration and water authority also. With social media spewing dreaded half-baked newses of Nipah, after a few days, even relatives refused to come anywhere near the body. Nobody was willing to come to do rituals also. Very few had come for rituals. Even in one case, no one was present in the crematorium during that period. This emotional stress of caring for a body with no kith and kin was managed with support from dedicated volunteers and selflessly working health office staff of Kozhikode Corporation. That's all I can tell. Thank you. Thank you very much.
Thank you, Dr. Gopakumar. Yes, it has presented it in a very crisp way, but it was the most difficult part at that point of time. And the emotional stress and trauma for the relatives as well as the healthcare workers and those who were involved in this was tremendous. And there were a lot of public health interventions and actions at that point. And it was actually done by Dr. Baby Napoli, District Education Mass Media Officer. Over to you, Mr. Baby.
Thank you, Madam. ജില്ലാ മാസ് മീഡിയ ഓഫീസർ എന്ന നിലയ്ക്ക് വലിയൊരു ചലഞ്ചാണ് നിപ്പ മാസ് മീഡിയ വിങ്ങിൻ്റെ മുമ്പിലേക്ക് തന്നത്. 2018 മെയ് മാസം 17 ചെങ്ങരോത്ത് PHC നിന്നുള്ള ഹെൽത്ത് ഇൻസ്പെക്ടർ ശ്രീ രാജൻ, അദ്ദേഹത്തിൽ നിന്നൊരു ഇൻഫർമേഷൻ കിട്ടിയത് മുതൽ ജില്ലാ മെഡിക്കൽ ഓഫീസിൽ ചേർന്നുള്ള ഒരു RRT മീറ്റിംഗ്, വളരെയധികം പ്രത്യേകതയുള്ള ഒരു RRT മീറ്റിംഗ്, അതുവരെ ചേർന്നിട്ടുള്ള RRT മീറ്റിങ്ങുകളിൽ നിന്നൊക്കെ വളരെ വ്യത്യസ്തമായിട്ടുള്ള ഒരു RRT മീറ്റിംഗ് ആണ് ഇവിടെ നടന്നത്. ഉടൻ തന്നെ അതിൻ്റെ ഗൗരവം മനസ്സിലായ ഉടൻ തന്നെ നാഷണൽ ഹെൽത്ത് മിഷൻ്റെ ജൂനിയർ കൺസൾട്ടൻറ്റ് ശ്രീമതി ദിവ്യയോടൊപ്പം, അതോടൊപ്പം പബ്ലിക് റിലേഷൻ ഡിപ്പാർട്ട്മെൻറ്റിൻ്റെ ഡിസ്ട്രിക്ട് ഇൻഫർമേഷൻ ഓഫീസർ ശ്രീ മധുസൂദനുമായി ഒന്ന് ചേർന്നുകൊണ്ട് ഞങ്ങൾ പെട്ടെന്ന് തന്നെ ഞങ്ങളൊരു ടീം അവിടെ രൂപീകരിക്കുകയും പ്രസ് ക്ലബ്ബ്, FM റേഡിയോ, ലോക്കൽ ചാനലുകളൊക്കെ ആയിട്ട് ഞങ്ങൾ ഉടൻ തന്നെ ബന്ധപ്പെടുകയും ചെയ്തു. മാത്രമല്ല തുടർന്ന് നടന്ന ഹൈ ലെവൽ മീറ്റിംഗ്, അതിനുശേഷം നടന്ന എല്ലാ മീറ്റിങ്ങിലും പങ്കെടുക്കുന്നതിന് വേണ്ടി ബഹുമാനപ്പെട്ട ജില്ലാ മെഡിക്കൽ ഓഫീസർ ജയശ്രീ മാഡം ഞങ്ങൾക്ക് അനുവാദം തരികയും എല്ലാ മീറ്റിങ്ങുകളിലും നമുക്ക് പങ്കെടുക്കാനും അത് കാര്യങ്ങളൊക്കെ റിപ്പോർട്ട് ചെയ്യുകയും ചെയ്തു. അതിൻ്റെ അടിസ്ഥാനത്തിൽ ലഭ്യമായിട്ടുള്ള എല്ലാ അറിവുകളും ഞങ്ങൾ ശേഖരിക്കുകയും സ്റ്റേറ്റ് മാസ് മീഡിയ ഓഫീസർ ശ്രീ ശശി സാറിൻ്റെ ആയി ബന്ധപ്പെടുകയും സ്റ്റേറ്റിൽ നിന്ന് ലഭിക്കുന്ന ഇൻഫർമേഷനെല്ലാം സ്വീകരിച്ചുകൊണ്ട് ഞങ്ങൾ തുടക്കം കുറിച്ചു. ഞങ്ങൾ ആദ്യമായിട്ട് തന്നെ ഞങ്ങളൊരു ലീഫ്ലെറ്റ് തയ്യാറാക്കി. അതോടൊപ്പം തന്നെ നമുക്ക് ഇതിനെക്കുറിച്ചുള്ള ഒരു ഇൻഫർമേഷൻ, ഒരു ഹാഫ് പേജ് പ്രധാനപ്പെട്ട 3 പത്രങ്ങളിൽ നിപയെക്കുറിച്ചുള്ള ഒരു അവയർനെസ്, ഒരു പരസ്യം ഞങ്ങൾ കൊടുത്തു. അതിനുശേഷം ഒരു നല്ലൊരു നോട്ടീസ് തയ്യാറാക്കുകയും, നമുക്കറിയാം ആരോഗ്യ രംഗത്ത് പ്രവർത്തിക്കുന്ന ഓരോ വ്യക്തിക്കും അത് ഓരോ വീടുകളിലും എത്തിക്കുന്നതിനാവശ്യമായിട്ടുള്ള ഒരു നോട്ടീസ് ആവശ്യമായി വരും. അപ്പം അതിന് ഒരു നോട്ടീസ് തയ്യാറാക്കുകയും അതിൻ്റെ തെറ്റുകുറ്റങ്ങളൊക്കെ പല ഘട്ടങ്ങളിൽ പല ഒഫീഷ്യൽസുമായിട്ട് ചോദിച്ച് മനസ്സിലാക്കിക്കൊണ്ട് തന്നെ അത് തിരുത്തി നല്ലൊരു നോട്ടീസ് തയ്യാറാക്കുകയും ചെയ്തു. തുടർന്ന് ആവശ്യമായിട്ടുള്ള കുറേ പ്രിൻ്റഡ് പോസ്റ്റേഴ്സ് തയ്യാറാക്കി. എങ്ങനെയാണ് നമ്മൾ PPE കിറ്റ് ധരിക്കേണ്ടത്, എങ്ങനെയാണത് ഒഴിവാക്കേണ്ടത്, ഇത്തരത്തിലുള്ള കാര്യങ്ങളെല്ലാം തന്നെ നമ്മൾ മനസ്സിലാക്കി. തുടർന്ന് നമ്മൾ പ്രിൻ്റഡ് പോസ്റ്റേഴ്സിന് ശേഷം നമ്മൾ കുറേ ഓൺലൈൻ മീഡിയയിലേക്ക് നമ്മൾ കടന്നു. അങ്ങനെയാണ് നമ്മൾ മാസ് മീഡിയയുടെ പ്രവർത്തനങ്ങൾ പ്രിൻ്റഡ് മീഡിയയിൽ നിന്നും ഓൺലൈൻ ഇതിലേക്ക് നമ്മൾ കടക്കുകയാണ് ചെയ്തത്. അപ്പോൾ അതിൽ നാഷണൽ ഹെൽത്ത് മിഷൻ്റെ ഫേസ്ബുക്ക് പേജ്, അതുപോലെ തന്നെ മാസ് മീഡിയയുടെ മാസ്റ്റർ കമ്മ്യൂണിക്കേഷൻ വാട്സാപ്പ് ഗ്രൂപ്പ്, അതുപോലെ തന്നെ ഒരു സ്വകാര്യ സ്റ്റാർട്ടപ്പ് കമ്പനി ആയിട്ടുള്ള ക്യൂകോപ്പി, ഇവരെയൊക്കെ നമുക്ക് ഉപയോഗപ്പെടുത്താൻ സാധിച്ചു. അതോടൊപ്പം തന്നെ നമുക്ക് അവിടെ രൂപീകരിച്ചിട്ടുള്ള കൺട്രോൾ സെൽ, നിപ കൺട്രോൾ സെൽ, അത് ഡിസ്ട്രിക്ട് കൺട്രോൾ സെൽ മാത്രമല്ല സ്റ്റേറ്റ് നിപ കൺട്രോൾ സെല്ലും DMO ഓഫീസിനോട് ചേർന്ന് തന്നെയാണ് പ്രവർത്തിച്ചുകൊണ്ടിരുന്നത്. അതോടൊപ്പം തന്നെ നമുക്ക് വിവിധ തരത്തിലുള്ള ക്യാമ്പയിനുകൾ നമുക്ക് FM റേഡിയോസിലൂടെ നമുക്ക് നടത്താൻ നമുക്ക് സാധിച്ചു. അതുപോലെ തന്നെ ലോക്കൽ ചാനലുകളിൽ സ്ക്രോളിംഗ് ന്യൂസ് നമുക്ക് കൊടുക്കാൻ സാധിച്ചു. മറ്റൊരു പ്രധാനപ്പെട്ട ഒരു കാര്യം നമുക്ക് മീഡിയ ഹാൻഡിൽ ചെയ്ത ഒരു കാര്യമാണ് ഇതിൽ എടുത്തു പറയാനായിട്ടുള്ളത്. ഈ മീഡിയ ഹാൻഡിൽ ചെയ്യുന്നതിന് മുമ്പായിട്ട് ജില്ലാതലത്തിൽ ജില്ലാ കലക്ടറും ആരോഗ്യവകുപ്പ് മന്ത്രിയും അതുപോലെ തന്നെ മറ്റ് മിനിസ്റ്റേഴ്സും ഉൾപ്പെടുന്ന ഒരു ഹൈ ലെവൽ മീറ്റിങ്ങിൽ ഒരാൾ മാത്രം മീഡിയയോട് സംസാരിച്ചാൽ മതി എന്നുള്ള ഒരു നല്ലൊരു തീരുമാനം അവിടെ എടുക്കുകയുണ്ടായി. എല്ലാവരും ഇൻഫർമേഷൻ പാസ് ചെയ്ത് ഒരാൾ മാത്രം ഇൻഫർമേഷൻ പാസ് ചെയ്താൽ മീഡിയയോട് സംസാരിച്ചാൽ മതി എന്നുള്ളൊരു നല്ല ശക്തമായൊരു തീരുമാനമെടുത്തു. അങ്ങനെ അത് മീഡിയ ബ്രീഫിംഗ് നടത്തുന്നത് ആരോഗ്യവകുപ്പ് മന്ത്രിയുടെ നേതൃത്വത്തിലാണ് ഭൂരിഭാഗം മീഡിയ ബ്രീഫിംഗ് നടന്നിട്ടുള്ളത്. അപ്പോൾ ഇത് മീഡിയയെക്കുറിച്ച് പറയുമ്പോൾ മീഡിയയ്ക്ക് വ്യക്തമായിട്ടുള്ള അതുപോലെ തന്നെ കൃത്യതയാർന്നിട്ടുള്ള, അവർക്ക് ഏറ്റെടുക്കാൻ പറ്റുന്ന, അതല്ലെങ്കിൽ അവർക്ക് കൈമാറാൻ പറ്റുന്ന, അതല്ലെങ്കിൽ അവർക്കും അവർ കൈമാറുന്ന ആളുകൾക്ക് മനസ്സിലാക്കാൻ സാധിക്കുന്ന അത്രയും വ്യക്തമായിട്ടും സുതാര്യമായിട്ടുള്ള മെസ്സേജുകളാണ് അവർക്ക് ആവശ്യം. നമ്മൾ ഓരോ മീറ്റിംഗ് നടക്കുമ്പോഴും വളരെ ക്ഷമയോടുകൂടി അവർ ക്യാമറമാനും റിപ്പോർട്ടറും വളരെ കൃത്യമായി നമ്മുടെ മീറ്റിംഗ് റൂമിന് പുറത്ത് അവർ അക്ഷമരായി കാത്തുനിന്നിട്ടുണ്ടായിരുന്നു. കോഴിക്കോട് മാധ്യമപ്രവർത്തകർ എത്ര പ്രശംസിച്ചാലും മതിയാവില്ല, അത്രമാത്രം ത്യാഗസന്നദ്ധതയും സേവന താൽപര്യമുള്ള മീഡിയ പ്രവർത്തകരാണ് കോഴിക്കോട് ജില്ലയുടെ മുഖമുദ്ര. വളരെയധികം ഈ പ്രവർത്തനങ്ങൾ നമുക്കൊരു എഡ്യൂക്കേഷൻ മോഡിൽ ജനങ്ങളെ എഡ്യൂക്കേറ്റ് ചെയ്യുന്നതിന് വേണ്ടി അവർ വളരെ നല്ല രീതിയിലാണ് ആരോഗ്യ വകുപ്പിനോട് നമ്മൾ പ്രതികരിച്ചത്. അപ്പോൾ മീഡിയ ബ്രീഫിംഗ് ആയാലും ശരി, നമുക്ക് ഡെയിലി പ്രസ് മീറ്റിംഗ് ആയാലും ബുള്ളറ്റിൻ നമുക്ക് കൊടുക്കുന്ന കാര്യത്തിലായാലും നമുക്ക് കൗണ്ടർ ആയിട്ടുള്ള ന്യൂസുകൾ വരുന്ന സമയത്ത് അത് അഡ്രസ്സ് ചെയ്യുന്നതിന് വേണ്ടിയിട്ടൊക്കെ നമുക്ക് വളരെയധികം സഹായിച്ചു. അപ്പം ആരോഗ്യ വകുപ്പ് മന്ത്രിയിൽ നിന്നും അതുപോലെ തന്നെ ബഹുമാനപ്പെട്ട മുഖ്യമന്ത്രിയിൽ നിന്നും ഒരു മാസ് മീഡിയ ഓഫീസർ എന്ന രീതിയിൽ പഠിച്ചൊരു പാഠം, നമ്മൾ എത്ര ഒരു പാനിക്കായിട്ടുള്ളൊരു സിറ്റുവേഷൻ ഉണ്ടായാൽ പോലും അതിന് തൊട്ട് മുമ്പ് അതിൽ എക്സ്പേർട്സ് ആയിട്ടുള്ള ആളുകളോട് സംസാരിച്ച് അത് കൃത്യത വരുത്തിക്കൊണ്ട് യാതൊരു തരത്തിലുള്ള ചാഞ്ചല്യവുമില്ലാതെ മീഡിയയെ അഭിമുഖീകരിക്കുക എന്നുള്ളതാണ്. മീഡിയയോട് സംസാരിക്കുന്ന സമയത്ത് അത് ആ വളരെ സൂക്ഷ്മതയോടുകൂടി സംസാരിക്കുന്ന ആ ഒരു പാഠവും തീർച്ചയായിട്ടും അത് നമ്മുടെ മിനിസ്റ്റേഴ്സിൻ്റെ ഭാഗത്തു നിന്ന് കണ്ടുപിടിച്ച ഒരു കാര്യം തന്നെയാണ്. അപ്പോൾ ധാരാളം ന്യൂസുകൾ നമുക്ക് മീഡിയയിലൂടെ നമുക്ക് കൊടുക്കാൻ സാധിച്ചു. വളരെ നല്ല പ്രാധാന്യത്തോടു കൂടി നമുക്കത് കൊണ്ടുവരാൻ നമുക്ക് സാധിച്ചു. ബഹുമാനപ്പെട്ട മുഖ്യമന്ത്രിയൊക്കെ പറയുന്ന കാര്യം ജനങ്ങൾ അത്രമാത്രം സൂക്ഷ്മതയോടെ ശ്രദ്ധിക്കാനുണ്ടായ കാരണം അത് നമ്മുടെ കാര്യത്തിലായാലും പിന്നീട് വന്ന കോവിഡിൻ്റെ ആ കാര്യങ്ങൾ വളരെ വ്യക്തതയോടുകൂടി വളരെ സൂക്ഷ്മതയോടുകൂടി മീഡിയയ്ക്ക് മനസ്സിലാക്കുന്ന രീതിയിൽ സംസാരിച്ചത് കൊണ്ട് തന്നെയാണ് എന്നുള്ളത് നമ്മൾ മനസ്സിലാക്കുന്നത്. അതുപോലെ തന്നെ നമുക്ക് ഫേക്ക് ന്യൂസ് നമുക്ക് അഡ്രസ്സ് ചെയ്യാൻ നമുക്ക് സാധിച്ചു. വിവിധ തരത്തിലുള്ള വീഡിയോസ്, ഷോർട്ട് വീഡിയോസ് നമുക്ക് ഈ കുറഞ്ഞ സമയം കൊണ്ട് നമുക്ക് എടുക്കാൻ നമുക്ക് സാധിച്ചു. അതുപോലെ തന്നെ വളരെ പ്രധാനപ്പെട്ടൊരു പോയിൻ്റാണ് നമുക്ക് മറ്റ് ഡിപ്പാർട്ട്മെൻറ്റുകളുമായിട്ട് ലൈൻ ഡിപ്പാർട്ട്മെൻറ്റുകളായിട്ടുള്ള ലൈസനിങ്ങും അതുപോലെ തന്നെ സപ്പോർട്ടും, അത് ഗവൺമെൻറ് അതോറിറ്റിയിൽ നിന്ന് നിർലോഭമായിട്ടുള്ള സപ്പോർട്ടും അതുപോലെ തന്നെ നമ്മുടെ ലൈൻ ഡിപ്പാർട്ട്മെൻറ്റിൽ നിന്നുള്ള നമുക്ക് നിർലോഭമായിട്ടുള്ളൊരു സപ്പോർട്ട് നമുക്ക് ഈ സമയത്ത് നമുക്ക് കിട്ടിയിട്ടുണ്ടായിരുന്നു. തീർച്ചയായിട്ടും നമുക്ക് ആരോഗ്യ വകുപ്പിലെ ഏറ്റവും പൊതുജനാരോഗ്യ വിഭാഗത്തിൽ ജൂനിയർ ഹെൽത്ത് ഇൻസ്പെക്ടർമാർ മുതൽ അതിൽ ആശാപ്രവർത്തകർ, ജൂനിയർ പബ്ലിക് ഹെൽത്ത് നഴ്സുമാർ, ഇവർക്കെല്ലാം ശരിക്കും മാതൃകയാക്കേണ്ട ഒരു കാര്യം നമ്മൾ നടത്തുന്ന മീറ്റിങ്ങുകൾക്ക് മറ്റു ഡിപ്പാർട്ട്മെൻറ്റുകളുടെ ഒരു സാന്നിധ്യം ഉറപ്പിക്കുന്നതിന് വേണ്ടി ഈ നിപ്പയുടെ നമുക്ക് ഇൻ്റർസെക്ടർ മീറ്റിങ്ങുകളൊക്കെ നമ്മളെ വളരെയധികം സഹായിച്ചിട്ടുണ്ട് എന്നുള്ള കാര്യത്തിൽ യാതൊരു തർക്കവുമില്ല. അതുപോലെ തന്നെ നമുക്ക് പ്രൈവറ്റ് ഹെൽത്ത് കെയർ പ്രൊവൈഡേഴ്സുമായിട്ടും NGOസുമായിട്ടും അതുപോലെ തന്നെ എടുത്തു പറയേണ്ട കാര്യം നമുക്ക് ആ സമയത്ത് നിപ്പ വന്ന സമയത്ത് ബ്ലഡിൻ്റെ ഒരു ഷോർട്ടേജ് നമുക്ക് സംഭവിച്ചിരുന്നു. അതുപോലും പരിഹരിക്കുന്നതിന് വേണ്ടി ബ്ലഡ് ഡൊണേഷൻ ഫോറമൊക്കെ വളരെ കൃത്യമായിട്ട് രംഗത്ത് വരികയും നമുക്ക് ചെയ്തിട്ടുണ്ട്. അവരെയൊക്കെ നമുക്ക് മൊബിലൈസ് ചെയ്യാൻ നമുക്ക് സാധിച്ചിട്ടുണ്ട്. ആംബുലൻസിൻ്റെ സർവീസ് നമുക്ക് ഉറപ്പുവരുത്താൻ നമുക്ക് സാധിച്ചിട്ടുണ്ട്. അതുപോലെ തന്നെ നമുക്ക് കുറേ വാക്കുകൾ, ആരോഗ്യ വകുപ്പിൽ ഉപയോഗിച്ചിരുന്ന കുറേ വാക്കുകൾ നമുക്കത് പോപ്പുലറൈസ് ചെയ്യാൻ നമുക്ക് സാധിച്ചിട്ടുണ്ട്. റൂട്ട് മാപ്പ്, ഒരു ഔട്ട് ബ്രേക്ക് ഉണ്ടായി കഴിഞ്ഞിട്ടുണ്ടെങ്കിൽ റൂട്ട് മാപ്പ് എന്നുള്ളതിന് അതിൻ്റെ ഒരു വളരെയധികം പ്രാധാന്യം അവിടെ കൈവന്നിട്ടുണ്ടായിരുന്നു. അതുപോലെ തന്നെ കോൺടാക്ട് ട്രേസിംഗ് എന്നുള്ളൊരു വാക്ക് അത് വളരെയധികം പ്രചാരം നേടിയ ഒരു വാക്കാണ്. അതുപോലെ തന്നെ മോഡ് ഓഫ് ട്രാൻസ്മിഷൻ എന്നുള്ളത് നമ്മൾ ആരോഗ്യ വകുപ്പിലെ ആൾക്കാർ മാത്രം സംസാരിച്ചിരുന്ന കാര്യം അത് വളരെ വ്യക്തതയോടുകൂടി ജനങ്ങൾക്കും കൂടി മനസ്സിലാക്കാൻ സാധിച്ചു. അതുപോലെ തന്നെ ഇൻക്യുബേഷൻ പീരീഡ് എന്താണ് എന്നുള്ളത് ജനങ്ങൾ മനസ്സിലാക്കിയിട്ടുണ്ട്, പൊതുജനങ്ങൾ മനസ്സിലാക്കിയിട്ടുണ്ട്. അതുപോലെ ക്വാറന്റൈൻ എന്താണ് എന്നുള്ളത് നിപ്പയുടെ സമയത്താണ് ജനങ്ങൾ കൂടുതലായിട്ട് മനസ്സിലാക്കിയിട്ടുള്ളത്. അത് തീർച്ചയായിട്ടും നമുക്ക് വീണ്ടും കോവിഡ് വന്ന സമയത്ത് നമുക്കത് വളരെയധികം ഉപകാരപ്പെട്ടിട്ടുണ്ട്. അതുപോലെ തന്നെ ഐസൊലേഷൻ്റെ ഒരു പ്രാധാന്യം എന്താണെന്നുള്ളത് ജനങ്ങൾ മനസ്സിലാക്കിയിട്ടുണ്ട്. അതുപോലെ തന്നെ പേഴ്സണൽ പ്രൊട്ടക്ഷൻ എക്യുപ്മെൻസും അതുപോലെ തന്നെ പേഴ്സണൽ ഹൈജീൻ്റെ ഒരു പ്രാധാന്യം നമുക്ക് നിപ്പയുടെ സമയത്ത് അവിടെ മുതൽ നമ്മൾ കൈ കഴുകാൻ തുടങ്ങിയതാണ്. അതുപോലെ തന്നെ അവിടെ മുതൽ നമ്മൾ മാസ്ക് ധരിച്ച് നമ്മൾ പഠിച്ചിട്ടുണ്ട്. അപ്പോൾ അതൊക്കെ നമുക്ക് സമൂഹത്തിലേക്ക് നമുക്ക് നിതാന്ത ജാഗ്രതയോട് നമുക്ക് കൊണ്ടുവരാൻ നമുക്ക് സാധിച്ചിട്ടുണ്ട്. അതുപോലെ തന്നെ നമുക്കറിയാം, നമുക്ക് സെൽഫ് ആയിട്ട് ഇമ്പോസ്ഡ് ആയിട്ടുള്ള ഒരു ലോക്ക്ഡൗൺ പോലും നമുക്ക് അത് ജനങ്ങളുടെ ഭാഗത്ത് അവർ തന്നെ അത് ശീലിച്ചു എന്നുള്ളതാണ് അതിൻ്റെ ഒരു പ്രത്യേകത. നമുക്ക് ഈ സമയത്ത് നമുക്കൊരു കമ്മ്യൂണിക്കബിൾ ഡിസീസ് മാനേജ്മെൻറ്റിനുമായിട്ടുള്ളൊരു സിസ്റ്റം നമുക്ക് കോഴിക്കോട് ജില്ലയിലേക്ക് കൊണ്ടുവരാൻ നമുക്ക് സാധിച്ചിട്ടുണ്ട്. അതുപോലെ തന്നെ ധാരാളം തിരിച്ചറിവുകൾ നമുക്ക് ഈ സമയത്തുണ്ടായിട്ടുണ്ട്. നമുക്കറിയാം, പൂരമായിട്ടുള്ള ഒരു തൃശ്ശൂർ പൂരം കഴിഞ്ഞിട്ടുണ്ടെങ്കിൽ മറ്റു പൂരങ്ങൾക്കൊന്നും പ്രാധാന്യം ഉണ്ടാകാതെ പോകാറുണ്ട് പലപ്പോഴും. നമുക്കറിയാം, നിപ്പ വന്നതിന് ശേഷം നമുക്കറിയാം മറ്റ് രോഗങ്ങൾക്കൊക്കെ ഒരു പ്രാധാന്യം കുറഞ്ഞോ എന്നൊരു പലപ്പോഴും സംശയമുണ്ട്. പക്ഷേ ഒരിക്കലും അങ്ങനെ ആ ഒരു കുറവ് വരാത്ത രീതിയിൽ ജനങ്ങളുടെ കൊച്ചു ആരോഗ്യ പ്രശ്നങ്ങൾ പോലും അത് കൈകാര്യം ചെയ്യുന്നതിന് വേണ്ടിയുള്ള ഓർമ്മപ്പെടുത്തലുകൾ നമ്മൾ നിരന്തരമായിട്ട് നമ്മൾ നടത്തിക്കൊണ്ടിരുന്നു. അതുപോലെ തന്നെ കമ്മ്യൂണിറ്റിയാണ് സ്റ്റേക്ക് ഹോൾഡേഴ്സ് എന്ന രീതിയിലേക്ക് നമുക്ക് കൊണ്ടുവരാൻ നമുക്ക് സാധിച്ചിട്ടുണ്ട്. ഡിജിറ്റലിൻ്റെ ഒരു അതിപ്രസരം നമുക്ക് എല്ലാ സ്ഥലത്തും പറ്റില്ല. പക്ഷേ ആവശ്യമായ സമയത്ത് നമുക്ക് പരമ്പരാഗതമായിട്ടുള്ള കമ്മ്യൂണിക്കേഷൻ മാധ്യമങ്ങൾ കൂടി വേണമെന്ന് നമുക്ക് മനസ്സിലാക്കാൻ സാധിച്ചിട്ടുണ്ട്. മാസ് മീഡിയ എന്ന് പറയുമ്പോൾ, അല്ലെങ്കിൽ നമ്മൾ മീഡിയ നിരന്തരം സംസാരിച്ചു കൊണ്ടിരിക്കേണ്ട ഒരു സംഗതിയാണ് എന്നുള്ളത് നമുക്ക് ഇതോടുകൂടി നമുക്ക് ബോധ്യപ്പെട്ടിട്ടുണ്ട്. ലോകം അതിവേഗം മാറിക്കൊണ്ടിരിക്കുന്ന സമയത്ത് ഉത്കണ്ഠയും ആശങ്കയും അന്വേഷണവും കൂടുതലായിരിക്കും ജനങ്ങളുടെ ഇടയിൽ നിന്ന് നമുക്ക് മനസ്സിലാക്കാൻ നമുക്ക് സാധിച്ചിട്ടുണ്ട്. തീർച്ചയായിട്ടും നല്ലൊരു ആരോഗ്യ സംരക്ഷണത്തിന് വേണ്ടി ആശയവിനിമയത്തിൻ്റെ ഏകോപനം അത് വളരെ അത്യാവശ്യമാണ് എന്ന് ബോധ്യപ്പെട്ടിട്ടുള്ള ഒരു കാലഘട്ടമായിരുന്നു നമുക്ക് കടന്നുപോയിട്ടുള്ളത്. അപ്പം ആരോഗ്യ സംരക്ഷണത്തിന് ആശയവിനിമയം അത് ശരിയായ രീതിയിൽ നടത്തുക എന്നുള്ള ഒരു തിരിച്ചറിവ്, അതല്ലെങ്കിൽ ആ ഒരു ബോധ്യപ്പെടുത്തൽ നമുക്ക് തീർച്ചയായിട്ടും ഉണ്ടായിട്ടുണ്ട്. നമ്മുടെ മാധ്യമ പ്രവർത്തകർക്ക് തീർച്ചയായിട്ടും വിവിധ ഔട്ട് ബ്രേക്കുകൾ ഉണ്ടാകുമ്പോൾ അവർക്കും ശില്പശാലകളും ഒക്കെ നമുക്ക് സംഘടിപ്പിക്കേണ്ടതുണ്ട്. നമ്മുടെ ആരോഗ്യ രംഗത്തുള്ള എല്ലാ ആളുകളെയും നാഷണൽ ഹെൽത്ത് മിഷൻ്റെ മുഴുവൻ ആളുകളെയും അതുപോലെ തന്നെ നമ്മൾ സപ്പോർട്ടീവായിട്ട് നിൽക്കുന്ന മറ്റ് ഡിപ്പാർട്ട്മെൻറ്റുകളൊക്കെ കോർത്തിണക്കിക്കൊണ്ട് മാത്രമേ നമുക്ക് ഔട്ട് ബ്രേക്ക് സാധ്യമാകൂ എന്നുള്ള ഒരു വലിയൊരു തിരിച്ചറിവ് സമൂഹം ഒറ്റക്കെട്ടായിട്ട് മുന്നോട്ട് കൊണ്ടുപോകുന്നതിന് വേണ്ടിയുള്ള തിരിച്ചറിവുണ്ടായിരിക്കണം. ഒന്നും മറച്ചു വെക്കേണ്ടതില്ല, എല്ലാം സുതാര്യമായ രീതിയിൽ മീഡിയ പ്രവർത്തനം നടത്തണം എന്നുള്ള ഒരു തിരിച്ചറിവാണ് ഈ നിപ്പ തന്നിട്ടുള്ളത്. അതുതന്നെയാണ് ഒരു മാസ് മീഡിയ ഓഫീസർ എന്ന നിലയിൽ എനിക്ക് കിട്ടിയിട്ടുള്ള ഏറ്റവും വലിയ ഒരു പഠനം. താങ്ക് യു.
Thank you, Mr. Baby. And that time has actually taught us how media briefing and public interventions are, how much important in such situations. And we need, whenever we have an outbreak, it's outbreak declaration as also closure of the outbreak is very, very important. And we are with us Dr. Jayashree, currently DMO Health Ernakulam, but she was with us during 2018 and 2021, and such a very cool person in our administrative level. And I have never seen her running around or anxious any of this pandemic situation. So cool. So over to Dr. Jayashree, how did you close or declare or plan closure of the outbreak? Over to you.
Thank you, madam. Good afternoon to one and all. As already told, Kozhikode witnessed 2 Nipah outbreak in 2018 and 2021. I would say that containment was effective by the strong administrative commitment with prompt planning, coordination and action, as well as intersectoral coordination between health department and animal husbandry department, coordination between district team, medical college team, private hospital and peripheral health institution, and also with state level and national level teams helped in controlling the outbreak. As already discussed, in the first outbreak, it was 18 positive cases and 2 survivors and 16 deaths. Total 2,649 contacts were traced and they were placed under quarantine for 21 days. Usually, the incubation period for Nipah is 4 to 14 days. But in this scenario, we have taken incubation period up to 21 days to rule out any possibility of getting infection. And high-risk and symptomatic cases were tested. Even if they are tested negative, we were kept under surveillance for 21 days. No further exposure occurred once the virus was confirmed and the system put in place. After waiting double the incubation period from the last confirmed case, that is 42 days, after 42 days, fortunately, no new cases were detected, but the field activity continued, and the district was declared Nipah free by the Honorable Health Minister in July 2018. But we have continued our AES surveillance and ARDS surveillance. The second outbreak after 3 years, only one case that was died on 5th September, and the experience and knowledge from the previous outbreak helped to re-establish the system within 48 hours. And the control activities, the same activities continued in the second outbreak also. 240 contacts were traced and quarantined for 21 days, and their symptoms were monitored. And these 240 contacts, out of these 240 contacts, 56 were from other districts, and 43 LSJs involved in this case, and 92 high-risk contacts were there. Here also, we tested the symptomatics, but fortunately, none were positive. Then AES and ARDS surveillance continued. A containment zone was set up 3 kilometers radius from the index case, and people in that containment area were also under surveillance for 21 days. Another important activity in the second outbreak is community surveillance for active case detection. House-to-house survey was held. We have trained field staff and ASHA workers for conducting this survey. A performer was prepared and training was given. And total we have 76,074 persons surveyed. 13 were found to have linked to the positive case. A mobile swab collection team was constituted, and then they went to the field and took samples. And 19 COVID positive cases were detected. Ongoing COVID-19 pandemic mean the health system was equipped with isolation facilities, trained health staff for infection control, and we have a good transportation system in place, and logistics and medicines are also in place. With this, it was easier to handle the second outbreak, and number of deaths was only 1. Anyway, we have continued our surveillance, and no new cases were detected during that period. And after that, the district was declared Nipah free in October 2021. Our ARDS surveillance and AES surveillance continued. And also, we continue our vigilance and follow-up. Thank you.
Thank you, Jayashree ma'am. And that concludes our session. But as ma'am rightly pointed out, it was a huge work and a committed work. And we always say time is life. But outbreaks like Nipah, where human life is lost, but it's also a loss for social, emotional, and economic loss for the society. And we like a lot to recover from that. So we need to continue our preparedness, that our surveillance for AES and ARDS. And as a clinician, we want early diagnosis so that we can act immediately. So this is a teamwork, and it's represented by all those who are with us. And we should be continuing this for future outbreak detection. And it's an experience sharing session, and we are going to conclude. But if there are any questions, 1 or 2, we can definitely take. Otherwise, we will conclude the session and over to the organizers. Thank you. Thank you, everyone.
Thank you, speakers, for the really informative session. I kindly request you to accept this small gift as a token of our appreciation.
Now, we'll be moving on to our fourth session of the day. The fourth session will be on source identification and a One Health approach. For this session, the moderator will be Dr. E. Srikumar, the director of the Institute of Advanced Virology in Thiruvananthapuram. The presenters will be Dr. S. Nandakumar, the disease investigation officer in Palur, Thiruvananthapuram, who will be speaking on Nipah, animal surveillance and source tracing. The second speaker will be Dr. Prajit, the associate professor and head of the Department of Veterinary and Public Health at Wayanad. And the third speaker will be Dr. Arun Zakaria, the chief forest veterinary officer, who will be speaking on bats as a natural reservoir for the Nipah virus. The whole session will be 45 minutes long, and 10 minutes will be allotted to each presenter. I invite the moderator to take over the session.
Good afternoon. First of all, let me thank the organizers for giving this opportunity, and it's a wonderful meeting that is going on from the morning. We have, it's a very important session, animal surveillance. Actually, I'm in a mood to do some surveillance for some lunch, as like all of you, but I will try to wind up the session in 30 minutes. We have three wonderful speakers. One is Dr. Nandakumar. He has been doing extensive work on animal disease diagnosis. And then we have Dr. Prajit, who is an associate professor and head of the Department of Veterinary Public Health in Wayanad Veterinary College. Then we have Dr. Arun Sakaria. Actually, he's actually very close to me as a classmate during our veterinary days, and also a good friend of me. And so we have three speakers, and I invite Dr. Nandakumar to start off with the presentation.
Thank you, Dr. Shikumar. Should I share the screen? Fine, thanks. Yeah, first slide, please. The title slide. The first slide, please. Previous slide, the first one. Yeah. Good afternoon, all. Good afternoon to you all. I think with tributes to Sister Lini, who was a Nipah martyr, and also to Sabit. The screen has gone off. Hello. Can you share the screen again? Yeah, fine. Sabit, the first Nipah victim, the person who has lost his life from Nipah, and part of the reason behind all these deliberations on Nipah, and even the reason for this particular seminar is probably Sabit was Ladis, and though he had a so animal surveillance and source tracing, probably the animal perspective of what Nipah means. And that is a particular aspect of what I'm trying to talk. In the next few minutes, I'll be out. Next slide, please. The chain of transmission, we know that it's a lot of animal component involved in the transmission of Nipah. We've got a lot of animals involved, like we have reservoir species like bats, and also the primary host you can call bats, and you've got pigs, which are considered as the primary host of the main target species based on the outbreak experiences in the previous Malaysian outbreak. And you have some instances where horses are involved, because we have almost similar values of Hendra happening in horses, which in the economics of Idaho. And you have Hendra coming together as the Hendra viruses, and now I think I will not be talking on Hendra, but Nipah will be my focus. And later on, you have other species also. May I have the next slide, please? Yeah, based on the outbreak, based on the previous experiences of outbreak, the first outbreak in Malaysia, that was from bats, and it got transmitted from bats to pigs and then to human beings. Whereas in India and Bangladesh, it was a slightly different picture, wherein pigs were not involved, but it came directly from bats. So I think you can call that bats as a reservoir species. At the same time, you can transmit as a primary host to human beings. Philippines, you had a slightly unnatural situation. What you would expect in Nipah, you had a pause involved. But again, it's finally it's starting with humans, and again, it transmits from humans to humans. That's a critical thing what we should really consider about. Next slide, please. Yeah, the web of this Nipah virus emergence, I should just tell you about the pig styes, the houses what we have in this in Kerala, because almost all these pigs are really having pig styes, what we call the pig houses are called as styes, and all these will be surrounded by shade trees, because pigs really need shade, they're not thermotolerant, so you need to have proper shade along the pig styes and pig houses. So a lot of fruit trees are there along with along the pig styes, and which makes a favorable habitat for bats to roost or to feed. So that is one that's a threat. In fact, then pigs transmit the disease to human beings and to dogs and cats and finally to humans. Then regarding the species transmission and the level of infection, what happens in other species other than pigs, is still really not understood properly. Because we have dogs and cats carrying the virus, and the experimental inoculation of all these species definitely had infections coming up, but the transmission potential of these species in a human infection chain is not properly understood. But I think I would just point my finger on this particular picture which I given the right top as to about the bats. Bats, the Chiropa species, the flying foxes, the fruit bats, what you call, these are the normal species which normally carry the viruses, and but they don't die of the disease. They're just asymptomatic carriers, what you call the reservoirs. So they just shed the viruses. So probably a question would be asked, why this shed? Because normally it harbors the virus, doesn't shed normally, but later on, when there are some factors like some stressors which come into their life, like they lose their habitat, they lose their supplies of food. There are also natural calamities, some drought or famine or something happens. There is a stress, and even if physiological stressors like birthing or overcrowding, all these causes stress, which causes the bats to release these viruses in huge groups in the environment, causing a huge sort of an epidemic. Next, please. So the disease in pigs, I will just have one slide about the disease, how it manifests in pigs. And basically, this affects the respiratory and nervous systems. That's why I call it a post respiratory and neurological syndrome, or a post respiratory and enterophagic syndrome. The first clinical manifestation would be the respiratory signs, what I call as a walking pig syndrome, or as what BPS. Because why normally pigs don't cough? But when you are having an infection in a pig farm, the first clinical manifestation, what you can hear from at least 1 mile before the farm, that is normally called as a 1 mile cough. So you hear that pigs coughing, and probably the first suspicion would be a case of a Nipah in a farm. So you have other diseases for differential diagnosis in pigs, like you have a Japanese encephalitis. ANXP is a reservoir of the host for testing, which causes nerve signs and nerve syndromes. So you have to differentiate between two based on your diagnostic capabilities or whichever laboratory can help you out. So if you do contact and injection, or your fomite contamination or contamination of the urine and feces of these pigs or these bats directly, it can get transmitted to human beings. So direct contact or by aerosol contact is also possible in this. Next, please. So I think it's a time I have been worried about whether it can really work. It happened in Siliguri in India, but suddenly it came after all these, we just crossed all these states and navigated into Kerala. So you're not sure where this origin is. You're not sure about the origin of the virus. And we have been tracing the source of the virus in bats. But even if I'm telling you, even if you're tracing the source and finally feeding it in bats, but you're not sure whether the bats are there in your colony which are harboring the virus. Because bats normally harbor a lot of viruses which are pathogenic or creating human beings, including the rabies virus. But probably that will be a slightly different type of habit or bats and other bats hunting bats. But definitely this is going to be a problem, and it is a real problem. That is why we are just discussing the whole day on this, what can be done about it. Next, please. So, see, probably what qualifies me as a speaker for this session would be not as my experience as a disease investigation officer in the Institute of the Animal Husbandry Department, probably a person who has done all the 3 rounds of this Nipah outbreak, World War 2018, World War 1, then your Kochi outbreak, and also the World War 2 outbreak. So the first outbreak in 2018 in pigs, we were a lot of health department people were there in the forefront, and we were there to partners control measures. With all the California, we had people, we moved in people from national exports from Nissan Bhopal and also from the southern regional laboratories. And we collected the bat samples, and of course, NIV team was there, the brilliant team of NIV that came up with all these facilities to capture bats. Everything went off well. Though the casualties and the case fatality in the first outbreak when the human casualties were too many, but definitely that we had a lot of results learned from that particular instance. Next, please. And the next Kochi outbreak, this is the epicenter where we are standing, is that the boy's father and the household from the epicenter of the outbreak, and we just visited there. And again, the whole team was there, and of course, it was a real one-health intervention where all departments collaborated, they joined hands, and finally, we will control the disease with just one baby. I think that disease is spread so far. Next. And again, the third. Because when we tell about the host and the sampling strategies and the surveillance mechanism, what should be carried out in animals? Probably the targeted species is not that good. As you see in the picture, we are trying to sample from a boat. Probably people started asking at that point of time, where goats are in reservoirs or in host infection. And right, you can see the Honorable Minister, Madam, and Forest Minister. We had a discussion that we would guest house, and I think all those people who were attending the seminar, many of the people who were there, Dr. Napi was there, Nipah was there, BMO, Madam was there. And all the departments we sat together, and we started collecting samples, and we sent the samples to Bhopal, our high security laboratory of Bhopal, and human samples were sent to NID Pune. Next, please. So the surveillance strategy in animals, bats are both primary hosts and reservoirs. I would have qualified them not as reservoirs, it's primary hosts also. Because bats can directly transmit the infection to humans. At the same time, you can carry the virus and harbor the virus asymptomatically. Probably you can tell those can be, bats can be called stem bombers. They just clandestine movements and the virus happens inside the bats and suddenly just drops the bomb inside in the environment, causing a lot of human illness. So pigs are considered the primary host and probably the target species where should start the surveillance. In any sort of an outbreak, when bats transmit to pigs, definitely the pigs are the connective link for bat to human transmission. And clinical signs will be evident. As I told you before, that the respiratory signs are predominant in pigs. Probably you can have a suspicion of the infection, then you can start collecting samples and going forward to diagnosis. Ongoing clinical surveillance, active surveillance, and based on clinical signs. And if at all you happen to get a carcass on a postmortem scene, then if you have a suspicion, definitely not open into any sort of non-controlled environment. You need to have biosafety containment facilities because it falls in the risk to risk pathogen. So you need to have high containment about the facilities to handle the pathogen. And because passive surveillance, you can go for the servo sampling and the servo surveillance studies. So as to see or assess the antibody levels installed if it is there in the animal species. Probably your target species will be pigs, and definitely you can have surveillance numbers which is also like dogs, cats. Cattle and goats are definitely not a good host for Nipah virus to survive and transmit, but definitely these are called incidental hosts or spillover hosts. So probably you can do some surveillance there. But basically your surveillance should be focused on reservoirs, what we call as bats. And bats are some animals which we cannot be handling, as such, sampling a goat or sampling a cat or any other domestic animal would be very simple. But we're catching a bat and exposing yourself to, without any PPE and all this protection, exposing yourself to bat sampling would be really tough. Okay, next slide. Next.
So,
Yeah.
excuse me, sir, I'm very sorry to interrupt, but I just want to let you know that we're reaching the 10-minute mark.
Yeah, this is the last slide. I'm going to find a right. Yeah, standard ongoing surveillance, standard reservoir species need to have rapid detection systems and can provide something like point of care testing, which can give you quick detection and quick diagnosis that can help you in further practice of disease. Diagnostic facilities we need to have BSL3 or BSL4 facilities at least one in a state to have a quick capture of the pathogen. The restoration of the proximity of the habitats would be a really good point to stress upon, not to disturb the bats and get them, push out a lot of virus loads into the environment, enhance the infection control measures. And the proactive one health action plan is not that crying of the spillway. You should be acting proactively, see to what should be done. And of course, this is a good session and this is a good exercise what you do now. Let's think about what you do better. Next slide, please. And this is one more final slide. You should be handling your own issues for other people and for other states or other agencies that are beaten. Remember the things to be concerned about. So Kerala, as a state, with all these facilities and good manpower and good infrastructure and good stuff, probably you need to handle your own problems. Thank you so much.
Thank you, Nandakumar, for a wonderful overview on the topic. Actually, even though we had 3 outbreaks of Nipah virus infection, still the source of infection is not traced. So this animal surveillance becomes all the more important, and also how this virus is getting transmitted to the actual patient, we should identify at some point by using any of these methods. Otherwise, this control measures in Nipah will become always difficult. So we will be always working on treating patients and also outbreak management. But the prevention aspect will not happen very easily. So we will go to the next presentation by Dr. Prajit. So he's going to talk on the strategies for On Health implementation to tackle Nipah. Even though we have been speaking about On Health for a very long time, mostly with respect to rabies and other zoonotic infections, the outbreak of Nipah and also the recent outbreak of COVID, coronavirus infection, has strengthened it further. So we will listen to Prajit.
Thank you very much, sir. At the outset, I thank the organizers for inviting me for this beautiful event here. So, yes, I'm going to talk about the strategies for One Health implementation to tackle Nipah. But the coverage of topic will be such that to cater the diverse group of audiences here. So before I start with the topic as such, I would like to highlight you to the beautiful logo which the health department has released. For a few people, it may be just like a bird, right? But it actually has an inner sense that it looks like a hand, it has a leaf, there's a bird there, so it involves an animal there, it involves hand of humans, then the leaf of environment, so it's totally a One Health there. That's a beautiful logo. Yeah, anyway, just the first sentence you see here about diseases like Nipah only infect people but also livestock. So that sentence itself caters that there needs a One Health approach. And not only livestock, there's a natural reservoir which is acting. That is a bat acts as a natural reservoir. So whenever we talk about One Health, it basically involves collaboration, coordination, communication among sectors. So just take a One Health system thinking wherein you have organize this event. So whenever we organize this event, it was meticulously planned where we'll be conducting, the group will be conducting, there will be a transportation committee, accommodation committee, or seminar committee, food committee, etc. So that's exactly is what One Health thinking is all about. That is, we can't cater this, address the challenges on one particular sector alone. We need to depend upon various sectors. So to taking that as a whole theory, we have there are certain sectors which needs to be involved, like the forest department has an important role in controlling the transmission from the bat sources, etc. So that's why we have collaboration and coordination currently, but there is a lack of communication between sectors. Even we as a veterinarian, we come to know, okay, there is a Zika virus here, there is a West Nile virus here, only after reading a newspaper. So that should not be the scenario. We should be involved because nearly 70 to 80% or nearly 78% of the viruses, that is emerging viruses, are from animal sources. So that's why in order to avoid such spillovers, such communication should happen, and that communication will happen only if there is a One Health policy in place by the state government, by the central government. So if you see all those diseases which is recently reported, that is the current millennium diseases, are from wildlife sources. So that's why One Health actually basically brings together the different sectors and gets, it's not a new concept or it's not a new thing which is getting involved. We are actually building on the existing capacities, but it is novel in disciplines and sectors together. Why we talk about One Health nowadays? Because, see, basically, you all know there are a couple of reasons where we see novel diseases nowadays. One important reason is because we have the population pressure. We know that the population is on an increasing trend. Not human population is touching 8 billion in the world, but the animal population is also increasing. In fact, the poultry population is nearly 3 times the human population. We are all sharing the same space. Okay, not only, and apart from that, that is one reason there are more chances of spillover which is happening from wildlife to the domestic animals, from domestic animals to the humans, through various transportation sources like vectors, mosquitoes, ticks, whatever be the source. But what I want to highlight is that this population, whenever it is showing an increasing trend, nowadays the trend is that the purchasing power parity of the people are more. So if I have more money, I prefer more protein-rich diet. That is, I prefer to go to market and purchase some chicken or some non-veg diet. That's a trend. I'm not talking about a story in Kerala. I'm talking the scenario global. So when the purchasing power parity is more, people buy food. It becomes a tremendous pressure for the food industry to meet the growing demand of food. In that cases, what will happen that people to manufacture more and more food, there will be certain practices which needs to be compromised. Like people may go for consumption of illegal wildlife trade, that is consumption of bats or something like that. So that and all are the reasons for nowadays of the emerging diseases. And Nipah also is one of the important indicator of this particular emerging disease. Every year, world remembers One Health on November 3rd, that is World One Health Day. Now, Nipah is basically a problem. You can see that not only the bats, you can see the bats which is actually prone to release the virus whenever it is having some intrinsic factors and extrinsic factors acting upon it. Like for example, when there is a severe disaster happening, drought, habitat loss, fire, forest fire, or we ourselves, humans, are intervening in terms of throwing some stones in trees and all, and where the bad roots are there. Or it could be the inherent pregnancy status of the mammal, that's the bat. So they actually transmit the disease to certain intermediate host. So that intermediate host, in case of Nipah, is still under research. We need to find out whether it is a pig which is acting as intermediate host, whether it is a horse, or whether it is directly from the bats, etc. And see, by the way, it moves to the human beings. There are certain practices, certain sectors which are involved. Agriculture practices, socio-economic factors, trade, cultural practices, international travel, ecotourism, whatnot. So all the sectors needs to be sensitized that there is a particular disease called Nipah which is emerging, and then only we can actually work together and bring about control measures. So coming to the intervention, we have we can broadly divide it into technical guidelines, which is provided by the health department, the ministries, the government of India, and the NCDC people, NIV people, AIMS, etc. They provide technical guidance for, like, when avian influenza was first reported in India in 2006, we had this contingency plan from the human health sector as well as an action plan for avian influenza control in the animal husbandry sector in the year 2005, first published in 2005. That means we are prepared to face avian influenza. Likewise, Nipah also, although we had, we are based on the first experience, we are acting against it. Now we have the action plan, we have the standard operating procedure, etc. for dealing with Nipah. Next, outbreak. Here the health department has played a major role in outbreak management. The beautiful film Virus itself shows out how health department has meticulously worked on in controlling the Nipah viruses. So so there we have the sector, people coming from medical colleges, ministries, private hospitals. Everybody is having an important role in outbreak management. Community support. See, we can't forget the local self-government here. The local self-government are the people who believes in. See, if I'm going a tribal colony or I'm going a particular person, if I go directly there, they won't approach them. But if at all I go through a local self-government, they'll be connecting me to a tribal promoter, and then if I approach there, they'll believe my words. So that's community sensitization and support is very much required. And the next one is a source identification. Here the veterinary sector has a major role to play, because we have to identify from whether it is coming from an animal sources or it is coming from an environmental sources. So here we have ICR, NISAD, Animal Husbandry Department, and many other sectors which play a role. I'm not going to go in detail like what interventions done by different department, but you can see level that international organization onwards, state and central ministries role, district administration, beautiful district administrator we had during that Nipah time, who actually took the review of the status of Nipah every fortnight. Then the central authorities, health departments, all these things were elaborately covered by Dr. Naveen in the intersectoral presentation. Then medical colleges, of course, they are the, the backbone of many of the knowledge, important aspects of Nipah treatment and management. Then laboratories, Animal Husbandry Department, and we, Veterinary University and Forest Department, are into the bat surveillance, advisory services, etc. Well, coming to the research component, see basically why we think this Nipah is happening here, because there are certain changes which is happening nowadays. I already talked about population pressure, climate change, deforestation and other things, but there are certain new practices which are newly emerging. Like for example, many farmers are now into exotic flowering and fruiting plants, rambutans and all, you must have heard in 2021. So that's actually happening. People in Wayanad and all, people are actually shifting their habitation, planning how to grow plants into a different mode, like because they are getting more profit out of exotic plants. Likewise, there are certain factors which I'm not going to, this will take 1 hour to deal with, to dive into the disease emergence into the humans. But anyway, it's all based on the scenario currently. So based on this, our university, along with the Forest Department, Eco Health Alliance, and KGMU, which is located in Lucknow, we have planned a project, and that project is to cater the Nipah virus surveillance in animals, especially pigs, bats, and we are also speaking on with the health department, Meenakshi madam, Vidya madam, etc., to involve the human sectors also in the surveillance, because we have a very good sero surveillance, luminous X-ray, which is, I think Dr. Arun also will be taking. He's also a partner in this project. He'll be, that assay actually determines the filoviruses, Nipah viruses. The complete scenario of what type of viruses is seen in Kerala will come to know. It's still under waiting for approval. It's given for HMSC approval and ICR DARE approval. And lastly, I would like to conclude that we need to establish a state-level zoonosis committee. Of course, we have certain committees in place, but I think this type of zoonosis committee, steering committee, and district-level committee need to be there in Kerala. And this committee will sit together and prioritize the at least 5 or 6 zoonotic diseases in the state, and then create an action plan for that particular diseases. That, and apart from that, we people in veterinary university, we have a One Health Center. We actually undertake training for One Health development of One Health workforce. So that type of training should be conducted to this type of individuals who are there in the fighting against the viruses. Next, we have to follow joint investigation and control program. Even Dr. Vidya, whenever madam goes for some investigation, she immediately WhatsApps me, there is a case of this thing. So that type of informal communication is currently existing within sectors, but that should be formalized now, and then we have to work together. And then we should have a state policy. Thank you all for the patience listening in this time. Thank you.
Thank you, Prajit. That was very interesting to see that some action is happening locally, at least as someone is taking initiative to develop assays or systems or screening platforms. So see, what in the morning, what we listened is most of these activities are centralized towards one lab in Pune. So that becomes very difficult when early detection and control is very essential in these kind of very deadly infections. So at least their department is taking some initiative for doing a routine surveillance. And hopefully that will be a pillar for the future outbreak control or control of the outbreaks from the emerging infections. So that was wonderful. Now we have a very important presentation by Arun on bats and how they are acting as the reservoirs for these deadly viruses. So over to Arun.
So thank you. Good afternoon. First of all, I should thank the organizers to give us a wonderful opportunity to present bats. Okay, because people hate bats, but we love them. They are wonderful creatures. They got a lot of properties. So in my presentation, I just want to talk a bit about bat ecology. I just want to introduce a couple of bat species, what around, and its ecosystem capacities. Then finally, why and what the reasons that bats becomes the reservoirs of these viruses. Will you deduce this time for this or? Yeah.
So while we wait for the slides to load, if you have any points to discuss on the previous 2 presentations, maybe we can have that discussion also. Yeah, sir.
Actually, this is just to supplement some of the points presented by the second speaker from the Wayanad. So, probably some of the points might be, will have to be covered by Dr. Arun also, but I'm not sure about that. What I am trying to say is that there is a huge information gap between what is the source of infection and what kind of medical management is happening right now. Because unless we address the basic cause for the Nipah or other emerging animal and zoonotic disease, we won't be able to contain such measures even in future. For example, we have to understand very well about the bat ecology, its reproductive dynamics, its food habits, breeding biology, and population dynamics, etc. But unless we don't, it might have been covered in the first speaker, by the first speaker, but I'm not sure audio was not very audible. What I would suggest is that, apart from that, when it comes to the laboratory or virus isolation, see, whatever we have right now is the virus isolate. You can correct me if I am wrong, Dr. Sriman, you can correct me. The virus isolate, right now we have the one we isolated in Malaysia in the year 1999. The second one, the virus isolate that got to one patient from Malaysia, then second one from the Bangladesh. No other isolates. We are working on still on that two strains isolated. But the mortality, the case fatality for those cases ranged from 40 to 70%. But in our context, our mortality was almost 90 to 100%. Maybe, in both episodes and both outbreaks. But are we dealing with some kind of different strains which we know about that? For example, the closely related virus, Hendra virus, is already there. The new strains has already been reported in Australia with HEVG2. That's a new strain. That was detected in a horse which died in 2015. It was detected recently on the virus sample from its urine sample, the horse urine sample. So likewise, are we dealing with the different kinds of new variant or strain of Nipah virus which emerged in a totally unrelated location in 2018, 2019 in same period, but in 2019, 21 in a different time period, September, usually May to July, May August is a different, like slightly cool period which the shedding of virus can occur mostly.
Yeah,
but this time it happened only September. So this kind of dynamics, we have to learn more about that, then only we can address the real issue. That's
a very, very important point.
Thank you so much.
See, the genome sequencing of the virus has to be done for that, and essentially we don't need a virus isolation for doing the genome sequencing. So we have newer technologies without even isolating the virus. We can do the genome sequencing. I will come back to the discussion a little later. If Arun can go ahead with the presentation, that will be good.
Thank you. So this is my topic, bats as natural reservoirs for Nipah virus. So as I told, bats are amazing animals. So they're the only mammal that can fly. Sorry? Sorry, it's not clear for me. It's not audible?
No, someone is speaking in between. Can they switch off the mic, please? Some of the online participants, they are speaking. So can they switch off the mic, please? Yeah, Arun, please go on.
Okay, so as I told, they're wonderful species, and they are in the order Chiroptera, and there are two genus, suborders, Megachiroptera and Microchiroptera. Megachiroptera, they are fruit bats, big bats, and Microchiroptera, small bats, as indicated. And they're keystone species. Many species are keystone species. Keystone species are the concept actually given by the IUCN, that is that the species got a major role in maintaining the ecology. So there are so many types of keystone species, and some of the bats are really keystone species. So these Microchiroptera, especially this uses this sonar. They use sound, and it's a bat sonar. So they're using this highly sophisticated mechanism. It's evolved in a span of 34 million years. So that's the beauty of the bats. So for around us, actually, we have in the world, there will be around 1,420 species of bats. In India, we have 132 species. In Kerala, we have 55 species, and I just want to introduce a couple of them. So this is the Pteropus medius, Indian flying fox, where we identified the virus, and which is a short-nosed fruit bat, which is a bit of solitary bat. And beautiful bat, you can see they come and drink nectar during the evening time. These are these species. And we have fulvous fruit bat, which is also a medium-sized bat, but with a huge roost. You can find thousands of bats together. And these are small bats like Microchiroptera. So this is a lesser false vampire bat. You can see near the houses, inside the houses, and there's a beautiful bat, painted bat. And there is a dusky leaf-nosed bat. It's called Hipposidrosis. So then we have rhinolophus, which are attributed to the main reservoir for coronavirus. Then we have least pipistrelles, and which are very small bats, got a huge ecological role. So they form huge colonies, we call it roost. So that is an ecology, that roost is an ecology. So they roost mainly in trees, like in larger bats, like flying foxes, maybe caves, as in the case of fulvous fruit bats. And there are some under the foliages, some may be in the caves, some may be in the tree pits, so that their ecology is different, entirely different. And the life history is quite interesting for the bats. They can, like the flying fox, which can live up to 30 years. Imagine there is a concept, as body size increases in the species, the lifespan increases. But look into the small mammal, and which is a huge lifespan, got a huge evolutionary role in viral reservoir system. So, and the slow population growth. Fecundity is very less, only one birth at a time. And lasts for almost 6 months. There's a huge dependency of the infant on the mother. So the significance, so what are the natural ecosystem services they are doing? One is they are pollinators, important pollinators. For example, this is the agave plant from the Tequila is produced, Tequila, what it is. So this bat is the main pollinator, and without that bat, there won't be any Tequila, right? Like there's a seed dispersal. They speed seeds in long distances because they move long distances. So dispersion is most important. Control of insect population, which is very, very important. For example, a pipistrelle can consume, they estimate around 10,000 mosquitoes like insects per hour. So they got a huge insect control mechanism. And which are the droppings of the bats as a fertilizer in many countries. And there are so many threats for the bat. The main thing is the deforestation, the cutting of the forest. And again, because of the taboo, people used to chase the bats away. Sometimes they are killed for food. So, and plus pesticide. Pesticide is a huge problem. There are so many theories coming out. Then again, like, so these are the major threats. So coming to our subject, so bats can harbor virus, and these are some of them. For example, they can mainly RNA virus. That's quite interesting. So the top species is the rodents in the world because they're the large species number, but they can harbor both RNA and DNA viruses. But bats harbors mainly RNA viruses. That is quite, for example, Nipah virus, and you have filovirus like Ebola, Marburg, and you got coronavirus, and you got these all kind of outbreaks through intermediate hosts, like in the Nipah, in the case in 1998, pig was that in Malaysia, and Hendra in the case of horse was, and Ebola, monkey was attributed in question mark again, and the SARS in civet, and camels in MERS, and it's still confusing with the condition of COVID-19. So whatever, so what's it, there is a, oops. It's not working. Oh, yeah. So in the Nipah situation, you know, the Nipah, the Hendra, the horse is intermediate horse, where in the Nipah Malaysia case, pig was an intermediate horse, where pig-to-pig transmission is possible. And in the case of India and Bangladesh, were man-to-man transmission. So it's not a dead-end, human is not a dead-end host. So this is a question. So why they are reservoirs? Why bats are reservoirs? Because viruses is a parasite, so there is an expense to maintain a parasite in the body. There's an energy dependency. So the question is why they are becoming a reservoir. It's an evolutionary question. There are two hypotheses put forward. One is called, it's a pathogen toxin. Okay, so they use these viruses as a protection against predation. So we have witnessed so many cases because in flying fox ruse, monkeys would not go further. So we have seen in so many cases, we have an experience like that. And second one is called fever hypothesis. It's said, it's a bit of ridiculous, it seems to be, when there is a mild virus infection, there will be an immunological response, there is an increase in body temperature. So bats need huge body metabolism, so that's created by the heat created by this virus infection. So these are the hypotheses put forward why bats are becoming reservoirs of the viruses. Then the question, what are the reasons, factors? So what make a host taxon special as a viral reservoir? So here I'm comparison rodents and bats, because rodents are the major species, biggest species in the world, and second comes the bats. So one first criteria is a greater number of pathogens than other taxonomic group when you compare with another group, another order. So how many pathogens they can, the number of pathogens, species of pathogens. For example, in the case of bats, it's 2.71 total virus per species. And whereas in the rodents, it's only 2.48, right? Okay, then criteria, higher proportion of zoonotic diseases than other taxonomic. Comparison again, it's 1.79 mean zoonotic viruses in bats than in rodents, which is 1.48. And third, unique set of pathogens as comparable to other taxonomic group. For example, Nipah virus is mainly seen in bats, likewise, or Hendra group, or maybe other level. For example, bat harbors the RNA virus richer than the other taxonomic group, where rodents, which is a richer, I told, species were richer, having more DNA viruses than the RNA viruses. Then the fourth, ecological, behavioral, or life history traits that differently favor pathogen diversity. Why? What are these factors affecting the more number of pathogens, species of viruses harboring in it? One of the main reason is the species richness. As I told, more than 1,400 species of bats make up approximately 25% of all the mammal species. So it's a large group. So there is a large chance of viral evolution. Then second point regarding that is the evolutionary history. So bats have got a 64 million years of evolution, adaptive evolution, and which indicates that they are undergoing all the evolutionary process of many mammals, so that they have many characters of the many mammals. For example, when you look into the receptor, viral receptor of the bat cell surface, and you can find major receptors, major viral receptors are present in the bats. That's why bats can harbor the virus. Okay, so that's receptor richness. Actually, it's an evolutionary trend. Then large roots support viral adaptiveness. This is a simple logic. Every pathogen, the role of every pathogen is that to reproduce. Okay, so if a pathogen is really a killing machine, there won't be any host to survive. So as time goes on, they become adapted. First, they will be virulent. Slowly, they become adapted. A balance. It is called coevolution. So which is exactly happening in the case of bats. And unique physiology. As I told, bats has a higher metabolic rate, which favors these virus infections may be favoring. So that's a concept.
Two more minutes. 2 more minutes.
2 more minutes, okay. So yeah, I'm finishing. What factors make a host taxon, especially as a viral reservoir? So here, what is the capability of interspecies transfer? So bats have a more ability. For example, the classical example is the Bangladesh case. What they do, the transmission is through toddy, so they drink toddy, they urinate into the toddy, and the transmission goes through the toddy. So such kind of adaptiveness is there. And most importantly, immunology. Bat has a unique immunology where the balance between host defense and immune balance is there. Okay, there is a host defense, at the same time immune balance is there. The innate immunity and adaptive immunity system. Immunity itself is very unique in the bats, like TLR receptors. There are new receptors in them. Anyway, this is a question I really want to. What happening in? See, previously fruit bats, flying foxes mainly depend upon cashew plantations. We had huge cashew plantations across the Western Ghats, borders of the Western Ghats. You know what happened? Because of the agriculture, price low, the cashew plantation is no more. Nobody's growing cashew plantation. Previously, we remember, people prefer to have the roofs in the house because they will get tons of cashews underneath. So that is not there now, but we are shifting to orchard culture. So everywhere, every houses, you can find new fruit plants are coming up. So the bats are moving towards this one. This is a reason for the emergence of virus disease in our situations. So again, the killing of the bats, that is prevalent in part of the country. And okay, thank you very much.
Thank you, Arun, for that wonderful presentation. Due to a lack of time, we will not have space for questions. So we can have discussions personally with the speaker later on. So it was a wonderful session where all the 3 speakers touched upon the importance of the surveillance and also the on-health approach. So if there are any more questions, we can have the discussion later on because of the lack of time. So let us wind up the session. Thank you once again for all the 3 wonderful speakers.
Thank you.
Thank you very much to all the faculties for giving us insight into the zoological aspect of the disease. I'd request you to take this small gift as a token of our appreciation.
Respected delegates, we shall now disperse for the lunch break, which is arranged in the basement. We shall assemble back at 2:30 p.m. Another note, the sand art session will be at 4:30 p.m. All delegates can collect their certificates from the registration office after the program is over. I repeat, lunch is arranged in the basement and we shall assemble back after the lunch break at 2:30 p.m.
and there is agglomeration, brucellosis.
Moving on to the fifth session for today's workshop on outbreak preparedness. The moderator for this session will be Dr. Asma Rahim, Medicine, and the speakers for this session would be Dr. Chandni R., Head of Department of Emergency Medicine, Government Medical College, Kozhikode, who would be presenting on the topic Emerging and Re-Emerging Diseases Scenario in Kerala, Laboratory Biosafety for Handling Emerging and Re-Emerging Viruses by Dr. B. Anukumar, Scientist and Officer in Charge in National Institute of Virology, Alappuzha, Surveillance Before and After Identifying an Outbreak by Dr. Priya Chandran, Additional Professor of Community Medicine, Government Medical College, Kozhikode, Psychosocial Problems and Interventions by Dr. Isuddin, District Nodal Officer, Mental Health Program, Kozhikode, Communicable Disease Management System Portal by Mr. Vinod, Technical Manager, E-Health, Response to an Outbreak Charting and Action Plan by Dr. Vidya K.R., Deputy DHS. I invite the moderator and the speakers onto the dais. Over to you, ma'am.
Good day, all. Esteemed speakers and the organizers of this workshop. It's been a fruitful day of discussions. So we are moving on to the last panel discussion. It's about outbreak preparedness. You might think that it's a bit repetitive, but it's not, because we'll be conducting it in a little bit different way as how a panel discussion should be done. And it's an interaction of lived-in experience of the speakers. So we'll be moving a little bit, especially with concern of your valuable time. And welcome to all the panelists. All of them are experts in their own field. Dr. Anukumar, welcome sir, Scientist E, in the esteemed ICMR Institute, NIV Alappuzha. And we have our own Chandni madam, who has coordinated and spearheaded and supported us in both the Nipah outbreaks, 18 and 21. Myself, Dr. Asma, Community Medicine Professor in Government College, Kozhikode, and my colleague and a pillar of support in the Regional Ped Cell and Outbreak Response, Dr. Priya Chandran, Additional Professor in Community Medicine, GMC Kozhikode. And there is no need to introduce Dr. Vidya K.R. She is the, I think, the and organizer of this program, doing all the background work. And we have Dr. Isuddin. He's my student, District Nodal Officer for Mental Health, DMHP, right? Thank you, Isuddin. We have one more person who will join online, and that is Mr. Mahesh. Mr. Vinod will not be joining us to present on the Communicable Diseases Management System Portal and how we used e-technology for entry of Nipah data. So shall we start, ma'am? My first query is to my colleague, Priya. Priya, can you just brief us from a public health perspective, what are the emerging and re-emerging outbreaks currently posing a threat to Kerala?
Good afternoon, all.
Slides. Slide 2.
That is Chandni Madam's slide.
No. We have sent a session 4 slide. Session 4.
Yeah, I'll just start briefly since Asma has asked regarding the emerging and re-emerging diseases which we have seen in Kerala, more specifically in North Kerala. For the past a decade or two, we have been witnessing many outbreaks of emerging and re-emerging diseases. And probably more frequently than the rest of the country, Kerala has been witnessing these outbreaks. And some of these outbreaks, most of these outbreaks are in fact zoonosis or vector-borne diseases. And to start with, so many emerging outbreaks have occurred. We had chikungunya outbreak in 2006, which continued in 2007. A localized outbreak of Lyme's disease was reported in Wayanad district in 2013. Diphtheria also I would classify as one of the re-emerging diseases because the outbreak occurred due to a change in the immune status of the population, and which forced us to have a relook into our vaccination program. And so as a result of that, we had to introduce the TD vaccine in our vaccination program. Then we had the H1N1 pandemic, which had its course, ran its course in Kerala also. Japanese encephalitis, a few isolated cases were reported in 2018 and 2019. And West Nile fever in 2018, that was right in the middle of the Nipah outbreak. Due to the AES surveillance, a few cases of West Nile fever could be picked up in 2018. Shigella outbreak in 2021, again pointing to the importance of food safety and water surveillance. And then we have the COVID-19 outbreak, which is continuing. Some outbreaks like the KFD outbreak, which occurred in Wayanad in 2014, which was specifically dealt with by our department. And I remember at that time, Dr. Vidya was the DSO at Wayanad, and the district administration handled the outbreak very, very efficiently at that time. Around 184 cases of KFD were detected, and it was managed by a successful vaccination program at that time. Visceral leishmaniasis, again a disease which we usually don't see in Kerala, even though the cutaneous form of the disease is seen in some pockets. In Malappuram, 2 cases were reported in 2015. Nipah outbreak 2018, a lot has been said about the Nipah outbreak by previous speakers, and the Nipah outbreak in 2021.
Okay, Priya, so it seems that we are a breeding ground for all these viruses, isn't it?
Yes.
And I think that the year 2003 has been a turning point from the perspective of global health, because the world started witnessing emerging new viruses. And I think in Calicut, I remember when we were working in 2006, we had the first chikungunya outbreak at Olavanna, and I think then an array of outbreaks have been there.
Yes.
So definitely there is a possible of zoonotic outbreaks, and so we need to be prepared to handle this outbreak. So with this, in this context, Madam, Chandini Madam, can you tell me what is your general approach to a patient presenting with an acute encephalitis-like syndrome, like, you know, we are mostly concentrating on Nipah and AE in our busy casualty or ED?
Thank you, Asma ma'am. It is not an easy task to identify an outbreak in a busy casualty or emergency department. And we have learned or listened to many of the outbreaks, but it was not easy in a busy emergency department for one reason, that patients, when they come, they want an immediate answer, an immediate result. But most of the time it is difficult. And the resources, human resources, always a challenge. It's not usually to the number of patient load. But 2 areas we have found it very difficult to approach. First one is actually in the busy emergency department, when the patient comes with this sort of presentation. Second, always where the patient first contact, it could be a primary care center or a secondary care center. Most of them will be reaching a center with fever, because fever is the initial presentation in all outbreak. But we have listened to in the morning sessions that how we can do it. We have an active surveillance program, but more than that, in the clinician perspective, we should be looking at with a syndromic approach, like as an acute encephalitis syndrome. And with the Nipah outbreak, we know that patient can come with either acute encephalitis syndrome like presentation, or it could be a combination of ARDS with encephalitis or ARDS myocarditis and encephalitis. Earlier presentations have actually not reported myocarditis, maybe because we have more investigation facilities and ultrasound.
Okay. Madam, what you are saying is that which are the differential diagnoses which a clinician should keep in mind when confronted with this kind of
differential diagnosis actually depend upon the place where we are working. And in acute encephalitis syndrome, before Nipah, we were seeing more of a Japanese encephalitis and we were tuned to that sort of presentation. Maybe that is the same that has happened in Malaysian outbreak also, because we are tuned to, but a new infection always we have to be on the look. But now we know that there are common like West Nile, JE, but more than that, we have to be aware of things that we can treat.
I think you have a slide on differential diagnosis, madam?
Yeah.
Yeah, so...
one more point I would like to emphasize is about the triaging. Triaging, we need to have a system well in place, because after COVID and Nipah, the entire system should be, or entire emergency department should be doing a proper fever triaging in future, so that we will be able to identify this sort of syndromic approach. And always with regard to differential diagnosis, I thought these are the differential diagnoses I will be considering. Japanese encephalitis, dengue, West Nile, herpes, FD in our scenario. And also when there is ARDS with myocarditis and encephalitis, we will be considering leptospirosis as the first possibility, because that is, we have to identify and we have to start treatment early. But definitely similar presentation, always we should suspect hantavirus. Now we have more serious cases coming and dying within 5 days, and most of the time, in fact, Dr. Annukuma has helped us in establishing that it is lepto. Because establishment is always important, because when an outbreak is declared, we will be reviewing all the case sheets, and all those who have come with ARDS and encephalitis will be put into the basket of Nipah. So diagnosis, and a faster diagnosis, that is more important in these situations.
We have a problem with isolating these cases, isn't it, madam? What are the challenges faced by you?
And that's another situation. When we look at the data, we know that similar presentation, at least 1 or 2 cases must be reaching a tertiary care center. But if we have the classical presentations, as we listened in the morning, like segmental myoclonus, segmental sweating, autonomic instability, refractory seizures in a patient with acute encephalitis syndrome, it is no doubt that I don't think any clinician will defer from doing Nipah, because we know that this is a presentation. But in a standard AES presentation, I think we should be prepared to do a faster diagnostic test in our own institution, and we should be getting very fast. Then only the question of or establishment of an isolation facility and running the facility will be feasible and viable, considering the infrastructure and investment involved in that part.
So, ma'am, how useful would be a point-of-care diagnostic lab next to the...
Point of care diagnostic. 2 things that we can do in management is primarily we need to have more of primary adjuncts for early diagnosis, like point of care ultrasound, point of care x-rays, and other routine investigations available, which we can do with the safety precautions without spreading the infection. Second thing is a point of care lab. Well, first and important one is we need to rule out Nipah if it's a classical AES presentation. And I think it is feasible, considering the previous experience, and our microbiology lab is also started doing it, and we should be able to do it. But it should be available to every tertiary care center in Kerala. That is the prime importance. But at least in Kozhikode, Wayanad, and Malappuram, and Kochi, where we have already had this outbreak. So early diagnosis, early implementation strategies, because what is treatment? Treatment is also intensive supportive care. So we have to initiate appropriate treatment, and we should have a facility for research. Especially no treatment is there in most of the illness. So we should have facility for our RCTs, so that we can know, because these are the problems we need to find an answer.
Stockpiling of drugs, do you find it difficult when these, of course we find difficult, isn't it? for getting the drugs required, whatever.
That was there, but we know that the challenges are many with regard to treatment. But one thing is very clear, that in these cases, the treatment is primarily intense supportive care.
Thank you, ma'am. That was a wonderful, you gave us insight on how a clinician approaches an AES like in LESS. And sir, Dr. Anukumar, sir, over to sir. The slides are from slide 8. So, sir, let them put on the slide, but we'll continue our conversation. Why do you think biosafety of labs are so important while handling these emerging and re-emerging viral specimens, samples?
We all know that the laboratory is the only place the infectious agents or infectious samples are deliberately sent. So this is greater risk to the laboratory person. If laboratory person get infected, that will leak automatically into the community. So this laboratory safety is very important for both laboratory person as an individual and for the community. So we have to take all measures to contain the infection as an individual level and also the facility level. That's why we can contain the spread of the virus from the outside.
I remember there was a theory like, for COVID-19 that it spread from the Wuhan labs. So I do not know how true it is, but that possibility exists, right?
If it is true, then there is a two-way that may be leaked. That may be leaked through the infected person. The person who may handle the virus there, she may got infection during handling because of their poor practice or maybe poor equipments. That means the primary barriers, their PPE and biosafety cabinet, something happened to the background. Secondary thing is a secondary barrier, means there is some fault in the facility. Means that is a BSL-3 facility that may have the HEPA exhaust and the effluent treatment plant. There may be some problem in the HEPA. It is a respiratory infection, aerosol infection. There is a chances of leaking into the community. Or your effluent treatment, means the effluent generated during the work, everything is treated, then it will be leave into the STP. So if something happened there also,
there is, okay.
You will get, because COVID also always there in the sewage also. Yeah. So there may be chances. But I'm not sure. I don't know.
I know. We are speculating.
It's a hypothesis.
Anyway, is there a way to classify the biosafety risk in your setting?
Yeah, in India, Department of Biotechnology is an apex body who classified the infectious agent into different classes based on the individual risk and the community risk.
Yeah, it's not working, so I think you have to help us.
Okay, based on the individual and risk, we have classified the infectious agent into 4 risk groups, group 1, 3, 4. And our Nipah virus is coming under the risk group 4. Means it's a high risk to the individual, also high risk to the community. And based on the availability of vaccine and prophylaxis, this virus move into the lower one. Like if vaccines are available and prophylactic available, then we can classify the virus into the risk group 2. Even in Kerala, KFD is risk group 3. Even though vaccines are available, but the agent is highly individual risk. Okay, these are.
Yeah. So, what are the elements, essential elements in risk assessment, sir? Can you just give a briefing on the? Yeah, please continue, sir, please.
Before we think about to start some laboratory, first we should know that what risk group our virus or our agents belongs to. Suppose, for example, Nipah virus, that belongs to the risk group 4. So second is scope of the laboratory, means what you are going to do in the laboratory for diagnosis, for antigen production, or large-scale vaccine production. That also determines the risk. Because, for example, if Japanese encephalitis virus is risk group 2, So if you are going to bulk production in the laboratory, then automatically the risk increase, then it will automatically goes to the risk group 3. Those scope also determine the risk. Then other than that, these are the elements which we need to consider before the assessment. The pathogenicity, infectious dose, route of transmission, host range, these are the characteristics of your infectious agent. Then persistence of virus in the patient and stability in the environment, and whether the effective prophylaxis is available or not, and therapy is available or not. Everything is important. And the foremost important is the procedures and the process you are going to do in the laboratory. It doesn't mean that you have BSL-3 laboratory, you can do anything. Any virus or anything, if you have to do the risk assessment, then go for the laboratory, this thing. Then the next question comes, who determines the acceptable risk? Every institute has their own institutional biosafety committee that has one nominee from the Department of Biotechnology. Based on the input from the principal investigator, who is the laboratory in charge, or who is the project manager of the project, he should provide some input to the committee, then committee determines whether it's acceptable risk or not.
So NIV LP, which level are you working at? Which level of biosafety level?
Madam, these are 4 biosafety levels are here. The biosafety level 1, there is nothing, there is no primary barrier, bench and your PPE, other things. When you go to the BSL level 2, then you need physical barriers like biosafety cabinet, and you have the proper PPE. Then you move to the BSL 3 level, then your laboratory should be negative pressurized. You may ask why that will be. Because if you spill something, that will be sucked and it should be exhausted through the HEPA filter. So the community will not get any infection. And you or the person working there should use PAPR, means powered air respiratory purifier. Then he will be also protected, and you should use all primary barriers like biosafety class 2 cabinets. And your exit should be showered. And all the labs should be double door. Then you move to the BSL-4 level, then, and one more thing is, your exhaust air should be HEPA filtered and your effluent should be treated. Then we move to the BSL-4, the laboratory is airtight, but the person who is working there is positive pressurized, should wear the positive pressurized shoe. And all remaining thing is same. And here one more thing is, the person go out from the lab should take chemical shower along with your suit, and then personal shower. And remaining thing is, here one more thing is, the in and exhaust air should be HEPA filtered and the effluent should be treated.
And so how do we ensure this kind of biosecurity? And what is your comment on that? Biosecurity in the labs. I think in your next slide, is there something on biosecurity? Biosecurity,
Okay.
yes.
So when we are handling virus and agents, we should have accountability on what we are having in our laboratory. That may be, you may be detected some too, but that samples containing many other things. So you should have accountability of that things, and you have to control it, you have to protect the samples. You should not go to the unsafe hands. If it goes, then it will be a problem. That's why the BSL-4 levels are highly secured, means it is electric fenced with gunmans will be there. But BSL-3 lab, it's not like that. But here the one more question is there. It is regarding Nipah virus. Here 1 or 2 laboratory we are going to start BSL-3 laboratory, like in microbiology department in Kozhikode Medical College and in NIV, and also IAV also they are going to start. Now you ask, because Nipah is a BSL-4 organism, how you can handle that in your BSL-3 organism? Here the risk assessments come. Your risk is acceptable, then you can handle. How? If you collect the sample, you inactivate it, then you can handle the BSL-4 organism into BSL-3.
Yeah, that's a wonderful.
It doesn't mean that because it is inactivated, so you can handle in the BSL-2. No, because it is very difficult to ensure that it is completely inactivated or not. So always remember that, because when you are, for Nipah virus, you can inactivate in 56 degree for 30 minutes. That is okay. That inactivated virus you can handle in the BSL, but we don't know whether the water bath is keeping temperature or your timer is keeping correct temperature or the virus is completely inactivated or not. So for Nipah virus, whether you inactivate or not, better to use in BSL 3, because in any spill or any drop from inside the lab, it will be cleared by the negative pressure and it will be filtered, so there is no community risk.
Thank you, sir, for giving us insights on how to prevent community transmission of the virus by ensuring biosafety, as well as handling specimens and how the scientific way of managing a biosafety lab. But when you talk about biosecurity, it also brought a thought like bioterrorist potential for me, which can happen.
That means
right?
that, ma'am.
Yeah. Okay. Thank you, sir,
Thank you,
for
ma'am.
that.
Thank you.
For that input. Over to Priya, madam. Can you just show her slides, please? Slide number would be 26, starting. Anyway, Priya, shall I start? Yeah. What is the role of pre-outbreak surveillance in the current perspective, in terms of emerging and re-emerging viruses?
Yes, so pre-outbreak surveillance as far as Kerala would be something like the period between two outbreaks, because almost every year we are facing some outbreak or the other. So during this pre-outbreak phase, the surveillance mainly is passive. We already have a surveillance system in place. We have got the regional peat cells and also the IDSP which is conducting field-based surveillance. So during the pre-outbreak phase, these surveillance system working passively. The passive surveillance will be taking place during this time. And so the data will be communicated to the district and the state. But most important during this phase is the periodic analysis of data which should be carried out to identify whether there are any clusters or any unusual presentations or deaths due to any unusual causes or some undiagnosed deaths like AES-related deaths which presented with unusual symptoms and the case progressed very rapidly and the death occurred without actually diagnosing the case. So we have to identify such things, and it can be identified only by periodic analysis of the data, which occurs during the pre-outbreak phase.
Okay, so you are talking about passive surveillance.
Passive surveillance.
Pre-outbreak. Yes. Are there any other types of surveillance which we can do?
During the pre-outbreak phase itself, we can have an enhanced surveillance during the seasonal pattern of the disease. That is, we already know that Nipah can occur during the breeding season of the bats. So the outbreak the case surveillance can be strengthened to a more active or a more enhanced mode during these bat breeding season.
Yeah.
Similarly, KFD also has a seasonal pattern. And in those KFD pockets in Wayanad, in the areas bordering the forest, surveillance can be tightened during those phases. So once you know the seasonal trend of diseases, it becomes easier to enhance surveillance during that phase.
So I think we know that, Chandni madam, in our hospital, we are doing now intensified surveillance for Nipah, right? AES cases, we are on the lookout at the triage, red area and all. So we've started, making our house surgeons aware and to report immediately. As part, probably this is a part of augmented surveillance mechanism. Okay, so can you just give us an insight into how the surveillance is carried out by regional peat cells within the hospital?
Yes, so the regional peat cell is functioning under the Department of Community Medicine in GMC Kozhikode. And we have peat cells in almost all medical colleges, government medical colleges and some private medical colleges also. So under the peat cell, reports of all communicable diseases are sent to the peat cell from the various medical, pediatric, infectious disease wards, etc. And this data is line listed under the peat cell and Periodic analysis is carried out for this data to identify any clusters. Spot maps are made to identify the clusters. And basically, analysis takes place to identify any pattern which is out of the ordinary.
So we are also working hand in hand with the IDSP.
With the
right?
IDSP.
Oh, so there is a bit of collaboration going on,
Yes.
and it also aids in outbreak investigations very fast.
Yes.
Okay, so finally, which disease outbreak should we be vigilant in the near future?
As we know that most of these outbreaks which we are seeing are either zoonosis or vector-borne diseases, and almost all these outbreaks have got an acute encephalitis picture or ARDS picture. So most of the time we will be looking for a AES type of syndromic surveillance or ARDS surveillance.
Finally, any suggestions to physicians or clinicians, primary care physicians on reporting and surveillance?
I think before that I would like to add regarding the post-outbreak surveillance also.
Okay, yes.
Yeah, during the post-outbreak, once the outbreak has been identified due to the particular cause, say Nipah or due to KFD or some other diseases, once the outbreak is identified, then the surveillance is more active. You need to have a house-to-house or door-to-door active surveillance for cases, and this mainly takes place in the community, the field-based surveillance. In addition to that, hospital-based surveillance should be stepped up. All hospitals in the primary level, secondary level and tertiary level should be reporting AES cases depending on which disease the outbreak has been identified. And this should be reported to the district and then communicated to the state so that finally final line list can be done and analysis can be done.
Thank you, Priya, for those pearls of knowledge which you've given us on the various surveillance strategies. Over to Isuddin. I've had the fortune of listening to your presentations on the psychosocial problems in the last Nipah outbreak. On the daily debriefing, isn't it? So,
yeah, I didn't get my.
No, in the last Nipah outbreak, we had a daily debriefing sessions, and
of course, yeah.
I had listened to your presentation. So, kindly enlighten us on the psychosocial problems that you have faced in the last 2 Nipah outbreaks.
Yeah. Thank you, ma'am. Before beginning, I would like to thank the organizers for giving me this opportunity and to incorporating mental health into One Health, which is usually ignored otherwise. Probably we tend to consider mental health as least of all concerns. But in reality, the thing is that in any disaster situation, Nipah, any epidemic or pandemic or whatever the disaster situation, the psychological impact is much, much higher than medical issues. The individual who recovered from physical illness may take much longer time to recover from psychological trauma. Coming to the question that ma'am asked, we faced a lot of issues, and why I think in Kerala this is the first time I think in 2018 Nipah time, the first time this psychosocial support is incorporating into the treatment team. The reason was our own colleagues working at Perambra Taluk Hospital and Balusheri Taluk Hospital. They were very afraid of having this Nipah. At that time we are very uncertain about the situation, about the illness and about the severity. And early phases, the mortality was 100%. And those who are primary contacts all got the illness, and they are all died. So you can imagine how dire the situation is. So many of our colleagues couldn't go to home. They were staying at rented rooms, and they are they are waiting for death. The situation is like they got the death warrant. So it's a very, very tiring situation. And many of them told that they are not afraid to die, but their problem is they cannot, their problem is they are pondering about their children's future. And some of our colleagues in Balusheri even wrote will. And apart from this, we also faced, some of our colleagues faced stigma, and many of our staff nurses kicked out from auto rickshaw and bus, fearing that because of the ignorance of the people regarding the transmission. So all this caused us to think about providing psychosocial support. So what we did was we went to these two institutions and we assessed and we made a plan. And according to this, we gave, according to that, we gave stress management classes, then individual sessions, debriefing sessions. And without that, we could help them, we could help all of them. Then at that time, there were a lot of false messages were spreading, especially through social media. And DMO asked us to have a phonic helpline to alleviate stresses of the common man, common people. So we started, and many of the anxiety and stress were related to Nipah transmission because of these false messages. And even I remember some people asked whether they get Nipah after having mango, because there were a lot of social media messages saying the same. If you eat fruits, you will get Nipah, like that. That was a thing. So coming to the...
So it was basically a team-based approach, right?
Yes.
Yes, I think you have formed a team and it's a district, isn't it? The district constituted a mental health team. So apart from mental health counseling, any other specific interventions you could help them with?
What we did was we appointed one psychiatrist, because at that time people were differing opinion. If you are giving to psychologists, because most of the questions will be related to illness processes, a medical person will be a better to deal with that. So we finally we don't have much human resources to deal with that. So we also later included them. So what we did that if their anxiety and stresses are not relieved with the primary psychological first aid, known as psychological first aid, in that we are giving all this informations and we are reassuring them. But some people who are very prone for anxiety and depression will be, those people may not be relieved their tension. So in that case, we need specific interventions, such as psychotherapy, supportive psychotherapy. The thing is that they are very prone for anxiety. Primordially, they are having anxious traits. So these kinds of nuisance and situation will provoke this anxiety, and they require all this sort of help from the mental health professional. So what we do is we psychoeducate. Your problem is due to, because of this, you are at risk. So at risk of having this kind of anxiety. So you can reduce anxiety by doing some relaxation techniques. We sent some relaxation videos to them through WhatsApp, and we also give many sessions to reduce their stresses. I think, and only very few people required medications. With the psychological intervention alone, we could help them to come out from the psychological traumas.
So I think you've done a wonderful job in providing them with mental support, because we we have, as a contact tracing team, we too were, bombarded with a lot of anxiety, and when we call them up for surveillance, they used to open up a lot, and many of them have even told us that they are watching the relaxation videos you've sent, and it's been a wonderful job. Anything we want to add on suggestions to handle future outbreaks?
The thing is that most of the people is normally get anxiety because it is something related to our survival. So it is normal to have it. So better to listen to them and better to reassure them. And when we are emotionally taxed, our intelligent brain, the prefrontal cortex, may not working. Instead, our all decision and thinking will be taken over by our emotional brain, such as limbic system and amygdala. So we cannot think rationally at that time. So we mental health professional help them to think rationally and help them to come out. For example, one doctor at the early phase of Nipah, I remember, he was not afraid of death, but he was very worried about his body is being burnt after the death. At that time, the burial protocol was not there. We were following that Ebola protocol. So he was very worried about that. It will, though he is not actually having problem, but he is thinking about his parents. They will be very, because in their religion it is not acceptable. So the parents will be very disappointed, and their future will be very dreadful. So in that case, because that is such a case, so that case is transferred to me. So we discussed this, and finally what I told is that, doctor, have you traveled in flight, in plane? So so he told, yeah, many times. Have you ever thought of this, crashing the plane and your body is being burnt and there is no remnants for burial? Then this is, I'm just saying, this is how we are helping them to think rationally. So that is I didn't think about that. So I told them the situation is very similar. You are only in quarantine, and there is no surety that you will get the illness. So we will better to think hopefully, and so that is how people can overcome. And I would like to add we should always give importance to psychological aspect, because that is the main concern of an individual.
Thank you, Dr. Sudhin, for that. So let's move on to Dr. Vidya, who is, in charge of drafting action plan and putting everything in place once an outbreak is reported. And in the last outbreak, we had worked together as a team, and I could see how efficiently Vidya had, handled and planned and sought to it that the team worked. So Vidya, once an outbreak is reported and is what is the process of and the key steps of drafting an action plan?
Thank you, ma'am. Actually, there are 10 steps, and today is the most important session of this whole workshop, because today we want to equip all the districts to prepare an action plan when in case any Nipah outbreak happens in their district. So, actually we are planning to divide the whole delegates of workshop into 6 groups, and each one will be given a topic, and they will be taken to the rooms that is downstairs next to our next to the place where we had our lunch. And the teams will be divided based on the districts, and they will be assisted by a facilitator. And now it is, the teams will have to assemble back to this hall at 4 o'clock, and each of the team leader will have to do a presentation based on these topics. So these are the topics that we want all of you to prepare an action plan on. First one is the identification of an outbreak, and the districts will be Pathanamthitta, Idukki and Kottayam, and they will be assembling in room 1. And next topic is the surveillance, and districts are Trivandrum and Kollam, and they will also be assembling in room number 1. And the third topic is infrastructure, that is that has to be done by Alappuzha and Ernakulam, and they will have to assemble in room 2. Then fourth topic is setting up of laboratory, Thrissur, Malappuram, Palakkad, and same also be in room number 2. Then the one is sample collection from humans and animals. That will have to be prepared by Kozhikode and Kannur, and they will have to assemble in room 3. And the last one is IECN training. That will have to be done by Wayanad and Kasaragod, and they also will have to assemble in room 3. And the facilitator for room 1 is Laila Madam. Laila Madam, and Madam will be assisted by a team from Manjeri. And the facilitator for room 2 is Thrissur. That is Dr. Binu Arikal, and he will be supported by Dr. Sudhraj. And the last one, that is sample collection from human animals and IECN training. They will be in room 3, and they will be facilitated by Dr. Anuja Madam and a team from Trivandrum Medical College. So I think from the topics itself, I think you all will know that what are the components of an outbreak, response to an outbreak. I have not added all the rest of the 4 steps, because these are the most important steps that we will have to be done in a district when an outbreak happens.
Thank you, Vidya. So Vidya has actually, throw the ball to your court and tried to engage you as healthcare professionals and healthcare workers in drafting an action plan. All the best. And I think
all of you will have to assemble here at 4 o'clock, and we will have a panel discussion after that, and the panel discussion will be led by Dr. Meenakshi Madam, then Dr. Anish, then we will have Dr. Prajit and Dr. Arun Zakaria, and also Chandni Madam and Priya Madam also. All of you can sit and discuss on any issues that is being present in the presentation.
So CDMS portal, I think due to lack of time, I think we can, isn't it? We can keep it. Now it is there? Okay. So just 5 minutes on, I think Mr. Mahesh from eHealth will be presenting on the new management, information system eHealth, that is communicable disease management portal, which has helped us a lot in the report, validation of reports, in the last Nipah 2021. So over to Mahesh. Online.
The facility to share.
Thank you. Thank you, Dr. Anukumar sir, for, I think he's just to leave early. Thanks a lot for your inputs. Give a hand to him.
Okay, so welcome all. I am Mahesh, software architect of eHealth, and I am bringing you to the CDMS platform for the next 3 to 4 minutes. So I will just briefly tell you what are the features available with the CDMS and what is a CDMS. So can you move to slide 1? Hello. Can you hear me?
Yes, we can hear you.
Yeah. Okay. Could you please move to slide, or shall I share this screen? Share my screen?
Yeah, I think that will be better. You can share your screen and just go on. Yeah,
But my
the
you have to give me permission to share. Yeah.
Is that possible? Permission to share? It will take time.
No. Yeah. Yeah. Yes. Now I can share. So is my screen visible now?
It is, Mr. Mahesh, it is visible.
Yeah. Okay, so CDMS is a comprehensive ecosystem built for contact tracing that we have built that platform in an open source CRM named ESPO, and it has been developed in a war room mode for Department of Health, and we are the IT nodal agency of Department of Health and Family Welfare, and it has been security audited and hosted in State Data Center Trivandrum. So CDMS is primarily meant for Nipah outbreak management for contact tracing, and primarily built for that purpose, and we have built in an architecture like it can be extended to communicable diseases outbreak in the future. So what is our role in building the CDMS? Because we are the IT nodal agency of Health and Family Welfare, we are supposed to have the platform to be built for Health Department, and we have made that platform in a round clock basis, and with the experience of the people from Nipah outbreak in 2019, the domain experts who have helped us a lot in building the application in a few hours of time. So what does CDMS has a lot of infographical dashboards, and all that can be controlled over multi-level user management, and all these are equipped in our CDMS platform. So basically CDMS has a patient list and a surveillance list, so that each patient has to go, whatever the contact list are, contact persons are in the associated with that patient, that will be categorized as primary, secondary contacts, and that can be enlisted, and it will provide an ecosystem to maintain and follow whatever the contacts we have with that patient, and once the incubation period is over, then the contact list can be reduced, and it can be removed from surveillance list also. So positive cases management, for positive cases management, we have a patient list, and for that outbreak in 2021 September, we have one patient that who was dead, and associated with that patient, there are 251 surveillance contact list of the associated with that patient, and but fortunately none of them has been positive so far. So the features, like it can be used, it is associated with the public caller management, so that the call center, we have a call center at that time, and the call center people are managing the follow-up calls of these surveillance people in the surveillances, so that their health status is being updated in a regular basis, and there is a facility for doctor calls, so that for that doctor can be communicated if anyone have the symptomatic, anyone is feeling some symptoms regarding this, and if somebody feels many mental issues regarding this, so that DMHP officials, DMHP doctors has been engaged in for the purpose, and our call center agents will notify that that person requires a mental counseling. So where the application itself has a comprehensive master data management, all the hospital districts and local bodies, and all these master data are available with our application, and we can customize and give permissions for the easy user management, and better access control can also be given in a secure manner. So we have a team management for each class of users can be categorized and grouped into teams, so that we can give wholesome permission to a group, and so that we can call that user groups as a team. So we have categorized that team as Kozhikode team, and that can give a privilege to for having that can be given a specified privilege for all the users. So we can build the configure reports and dashboards that are configurable in a minute of time, because that's what this application has, the configurable and scalable architecture, and so that we can have built a report in few seconds. That is also an advantage, so that whatever reports are needed by the health team, that we can provide with ease. So alerts and communications are also incorporated in this. So we have the open source technologies like PHP, MySQL, and Espo CRM with workflow, and hosted in Apache Web Server. So training has been given by the training for the application has been given to all stakeholders and health officials who are handling the application. It's a product of one kind of its among in the country, and it is security audited and safety hosted in state data center, and it is highly flexible, scalable, and configurable with the workflows and business process management. And this is the URL to the CDMS, and I will just go through the application in 1 minute. If you have any, if your time persists, I will show you the live application demo. Shall I? Madam?
Should we? I think we are running out of time, Mahesh. I think probably while presenting the action plan, will there be time, Vidya?
Oh, no issue.
Yeah, the next session, if possible, isn't it?
Yeah.
Anyway, Mahesh, we had we used this contact tracing. I mean, during our contact tracing for entry of the details last time, we had used this very simple and user-friendly interface for entering the details, and it's been really useful. Thanks a lot for developing this. It's quite user-friendly, and I think our contact tracing team knows how it really worked. Midway into the surveillance, we had started using it. Thanks a lot, Mahesh, for the inputs.
Thank you. Thank you, ma'am.
Shall we go? So with that, we are coming to the end of the session on outbreak preparedness. As we all know, with continuing threats like the global warming, melting of ice caps, environmental degradation, increase in wildlife trade, every day we are being, the emerging and new threats are being thrown at us. And therefore, this is the most important topic which we need to focus on, that is outbreak preparedness. Because if we are prepared, then we can, our response is, that will trigger the response and also make us think, okay, and we are always, that puts us on alert. So I thank all my panelists for giving valuable information and how to be prepared to face an outbreak, because it's actually hanging as a Damocles sword above us each and every day. Thank you. Thank you for the kind listening. And probably 1 minute, if the audience have any doubts or queries to our panelists, you can raise this. Thank you.
If there are no questions from the audience, I'd like to thank all the panelists for the wise insight into the topic of outbreak preparedness. And I'd like to thank Dr. Asma for moderating the session. As a token of our appreciation, we'd like for you to accept this small gift from us.
All delegates are now requested to proceed to the allotted rooms for the session on the District Action Plan preparation. All delegates are requested to come back to this hall at 4 p.m. for the sand art session. 4:15 p.m. for the sand art session. I repeat, all delegates are now requested to approach the allotted rooms for the District Action Plan preparation session and should come back to this hall at 4:15 p.m. for the sand art session.
Welcome back, everyone. We now have a session called Talk with the Experts. We have with us, joining over Zoom, Dr. Pragya Dhruvyadav, a scientist and group leader at ICMR NIV, Pune. Welcome to the workshop, Dr. Pragya.
We might present chemistry option.
Dr. Pragya, we would like to inform you that we have accepted your request and made you co-host in this meeting.
Good afternoon, everyone. Can you please hear me?
Yes, we can see the presentation.
Ma'am, your voice is audible.
Yes, ma'am, you're audible.
I am traveling, so I am not able to present. I request Dr. Reema Sahar to present on my behalf. Dr. Reema, please present. Okay, ma'am. Thank you. Good afternoon, everyone. So on behalf of Dr. Pragya Yadav, who is the group leader and scientist staff of Maximum Containment Facility of ICMR NIV Pune, will be delivering this talk. So from morning it has been discussed that Nipah virus, about all the Nipah virus related transmission, its source of infection. So just to brief, that in India, the source of infection is mostly the bats, as we see in this figure. Similar to the Bangladesh, unlike the Malaysian outbreaks, in which we also have the intermittent host, which are the pigs. In India and Bangladesh outbreaks, we have seen many human-to-human transmission. And every year after 2001, Bangladesh has reported annual outbreaks, and India has reported 5 major outbreaks, which we can see in this image. The first outbreak, which happened in 2001 in Siliguri, West Bengal, in which the case fatality of 68% was there, followed by the outbreak in 2007 in the Nadia district of West Bengal, in which 5 cases with 5 deaths were reported. Almost 100% of case fatality was reported. After that, almost after a decade, we have seen the outbreak in South India in 2018, which has been discussed throughout the day. How the first outbreak happened in Kerala in 2018, in which the CFR was around 89%, which was followed in June 2019, the Ernakulam outbreak with the survival of the case, followed by the another outbreak in 2021, which happened in Kozhikode, when this case succumbed to infection. In all the 3 outbreaks of the Kerala, the bat has been detected to have the source of source of transmission with the positivity. So this is not the first time in 2018 when NIV was able to find the source of infection, but NIV was dedicatedly hunting the Nipah virus source of infection since first outbreak in 2001, which happened in West Bengal. Bat survey was conducted in northeast region of India, and successfully we could prove the positivity in Dhubri district and Kuch Bihar districts. Then after the survey which was conducted. If we can see the images which were shown, these are all ICMR and NIV trained staff, field staff, going to the difficult terrains to capture the bats and to prove the source of infection and to find the Nipah virus. We have captured many species of the bats and investigated in a good number to see the positivity. If we can see, we have different species of the bat captured, including Rausetus, Pteropus, Cynopterus, and Pipistrellus. Till 2010 to 2017, why we are highlighting this slide is, we have worked even prior to these outbreaks of 2018, what NIV has done to find out the source of infection and transmission as well as Nipah amongst the bat. So 636 total number of bats were tested, out of which IgG antibodies were positive in 6 bats and RT-PCR positivity is among 24 bats. Before 2018 outbreak of Kerala, even pig serum, if we can see a figure of around 1,000 pig serum were tested from the Mizoram state and were found to be negative for Nipah IgG antibodies that rules out the pig as a source of transmission in India. This paper on detection of first Nipah virus in RNA in fruit bat has been published in 2012. If we can understand that there is always a chance of positivity and the zoonotic transmission to humans. Apart from the positivity of Nipah virus in bats, new virus discovery were also made from bats, including the Mulsur virus from the Rausetus species and the Tumen virus from the Pteropus bats. Now, what experiences did NIV shared and had when Nipah virus first hit Kerala in May 2018 in Kozhikode? So, NIV first confirmed the Nipah outbreak, being the apex lab, isolated the Nipah virus from the throat swab of human specimen. Complete genome sequencing was done using NGS. NIV scientists participated actively in the containment of NIV with a central team in Kerala. Enhanced capacity building was done at ICMR Kerala unit. And yes, the source of outbreak was confirmed in Kerala with the positivity in Pteropus bats. From isolation to detection of source of infection, the scientists and the technical staff of NIV Pune worked tirelessly. In the morning, Dr. Gop Kumar has explained how the dignified burial of human remains was conducted. This has been, the scientists from NIV have given training for this burial. Not only this, the sample collection training, the packaging training, and helping the central team under the aegis of then EMR head Dr. Ravindran. The isolation facility was set up. All the guidelines were prepared, including the treatment and management of Nipah virus disease, hospital infection control guidelines, handling of human remains, and roles and responsibilities of VRDLs during the outbreaks, as well as sample collection and packaging transport. Then it was a huge chaos. It was pre-COVID-19 pandemic era, when we know that there were no availability of PPE. People were not trained about the collection of samples. If the team from Kozhikode could remember, whole of the wards and suspected cases were lying and people were afraid even to collect the samples. So that time, the major challenging was to early diagnose these suspected cases and to isolate the cases, those who are confirmed. So under the leadership of Dr. Ravindran, a standalone Nipah treatment facility was established, and within a week, a dedicated facility was ready for the isolation of the Nipah positive cases. Similarly, because of the there should not be any delay in the diagnosis, a quick training and capacity enhancement of laboratory was done on the biosafety and Nipah virus diagnosis at ICMR NIV Kerala LFP unit, in which the team from NIV Pune went and trained the team to the NIV Kerala unit. The complete genome of the human cases as well as the bat specimens from 2018, the phylogenetic analysis, it matched with the Bangladesh sequence. If we can see here, the B genotype, and they have the human as well as bat, they have a similarity of 99.7 to 100%, giving a probable cause that bat could be the source of infection to human. The sweat and the hard work from the field team, which captured the Pteropus bats in the difficult terrains in 2018, amidst the rain which were happening there, could help to trace the source of infection. So the Nipah virus viral RNA positivity was 25%, and it was near the house of index case, proving as a source of transmission. So what lesson we learned in 2018 outbreak? The need for effective public health communication, because we have faced a lot of problems starting from the burial of the human remains, starting from communicating the risk to the people, isolation, triaging, everything, the problem which we have faced in public, social mobilization to reduce the rumors, community engagement, involvement of different stakeholders. Though there was a high political commitment, but strengthening of the health system is the need which we felt in this outbreak. What are the challenges which we faced in 2018? We tried our best to incorporate and which helped in our further outbreaks in 2019 and 2021. For early diagnosis, surveillance system was strengthened in Kerala. On-site diagnosis point of care assay were developed. For isolation facility, standalone isolation facility was created at GMC Kozhikode. Huge number of healthcare workers were trained for donning and doffing as well as for biosafety. As there was need of therapeutics, monoclonal antibodies were imported quickly and the clinical trial protocols were developed. As there was no understanding about the antibody kinetics or the subclinical infections of Nipah, seroprevalence studies were conducted and countrywide sero survey on bats were continued and still ongoing to map the high-risk areas in the country. If we see the seroprevalence of Nipah-specific antibodies, which was done among the close contacts of Kerala after 2018 outbreak, this was done after 49th day of post-exposure. So we could see IgG positivity amongst 2 close contacts and IgM positivity among 3 close contacts, which suggests a very low prevalence of subclinical infection in Nipah virus. Hence, in 2019 and 2021, a huge lot of asymptomatic as well as symptomatic contacts were screened, because we have learned that there is chances of subclinical infections in Nipah virus after 2018 outbreak. Similarly, till date, like now it has been 3 years after 2018 outbreak, and we could we have studied the antibody kinetics to understand how long this IgM as well as this IgG antibody stays in the survival cases of 2018 and 19 and the asymptomatic contacts which were screened in 2018. If we see a figure here and the lines which are mentioned, the follow-up of Nipah survivors almost till 40 months, that is more than 3 years, the antibodies were present, like IgG is detectable. It starts from 5th post date of infection. Similarly, IgM, it started from 5th day of infection and we could see till 49th day of infection. So in this case, the IgM goes very early and till date, we could see the IgG positivity. As per the need of the hour, the work was done for development and validation of Nipah point of care assay, which was used in 2019 as well as 2021 outbreak, which helped in early diagnosis, isolation of the cases, as well as reducing the chaos and the misinformation and early triaging of the suspected cases. This is portable, battery operated, automatic, and with the minimal biosafety label, it could be handled. Our team meticulously worked not only in India, but they also did external validation of this POC in IEDCR Dhaka, Bangladesh for further approvals. For the implementation of the clinical trials, as we all know that there is no treatment for this Nipah virus at present, and there is no prophylaxis, no vaccine, a monoclonal antibody, a complete implementation, and the SOP for the clinical trial was developed with all the experts so that in next outbreak, this monoclonal can be used for the treatment of the infected cases. So the ICMR commitment to Nipah virus infection included the multidisciplinary trial team developing of the trial protocols, all the SOPs, and the testing by indigenous POC assay. And recently, the CDC or DCG has approved the POC for Nipah virus detection in collaboration with MolBio. As per the need, countrywide Nipah virus survey on the bats were conducted. Nipah survey in the bats could be done only till early 2020. After that, COVID-19 pandemic has hit, and it was very difficult to travel and to engage the frontline workers. And all frontline workers were mostly, including NIV staff, were doing the COVID-19 work. So till 2020, if you can see, we have covered almost around 13 to 14 states, and RNA positivity, if you can see in purple color, which is marked in this map, it is observed in 4 states, RNA as well as the IgG antibody positivity. And only IgG positivity were observed in 2 states and 1 union territories, including Karnataka, Pondicherry, and Tamil Nadu. So if we can see, the hotspots are present throughout the country, and still until we are ahead ready for doing survey in other states to map the high risk areas and to map the hotspots. So what experiences from 2018 helped us in 2019 outbreaks? As when the outbreak was declared, immediately ICMR made a containment team in 5 different fields. First, a clinical team was made, and the clinician from GMC and Alappuzha and Kozhikode, they went for the clinical assessment of Nipah cases. Laboratory team from NIV Pune, they helped in field setup, which was the first field setup of point of care assay at the GMC Ernakulam. Bat survey team went immediately to find the source of infection. The epidemiology team from ICMR NI Chennai did intensive contact tracing and surveillance with the IDSP of Kerala. And the pharmacological team from the Nari Institute which is present in Pune, they helped in establishment of facility which will help in administrating the monoclonal antibody to the Nipah confirmed cases. Quickly, the Nipah virus sequence from Ernakulam was, the sequence was, the NGS was performed, and this sequences, it matched with the sequences of 2018 Nipah outbreak. In the image, if we can see, this is the team from NIV quickly within 24 hours of the outbreak declaration could set up the first ever laboratory setup with the POC, the real-time PCR facility, and the IgM and IgG testing facility of ELISA and at GMC Ernakulam. This was, the images look very clear and clean, but the lab was not in that good condition. Everything had to be taken care, and with the full support from the team from GMC Ernakulam and the Kerala state government, it is possible to implement and to set up this field laboratory. These are the few glimpses of training of the staff, not at GMC Ernakulam. With the help of Dr. Vidya Madam and her team, and making the trainer of trainers, almost 30,000 healthcare workers were trained within 15 days, and that was a huge work which was done during 2019 outbreak. 8 government medical colleges from the Kerala were also trained for Nipah virus diagnosis using POC. The capacity building of the GMC Ernakulam was done, and the biosafety training were given so that the sustainability of training of the testing will be done even after when ICM and NIV team will leave the outbreak epicenter. With that, again, the tracing of the source of infection was done, and here in 2019 we could not found any RNA positivity in bats, but IgG positivity in bats were observed, almost 21%, which could give a probable source of infection to the index case in Ernakulam. So what lesson we learned from the outbreak in 2019? That preparedness is a key element in response to the containment of these high-risk viral pathogens. The previous experience in 2018 and the teamwork which applied in 2019 helped in early containment with only single case in 2019 with better contact tracing, proper risk communication, quick establishment of on-site lab, establishment of monoclonal antibody facility, and identification of the source of infection in Pteropus bats. Last year in 2021, during the second wave of COVID-19 pandemic, which hit the Kerala state at a later stage than the country, the Nipah outbreak happened. Again, with the similar way, the NIV team helped for the setup of the establishment of on-site field diagnostic facility, helped in capacity building of the lab, and augmented the laboratory testing. The team were dedicatedly deputed, and the biosafety and handling of Nipah virus specimens were done. This has been discussed by Dr. Kalpana Madam in the morning. Screening of the close contacts were done. 64 close contacts were screened, out of which the primary contacts were 19 and the secondary contacts were 5. If we see the presentation of the COVID-19 and the presentation of the Nipah, more or less both presents in the similar way. Apart from the AES presentation, Nipah also presents as one of the symptoms of ARDS, that is respiratory presentation. So it was very difficult then during COVID-19 pandemic for the isolation of these cases. Or if any of the primary contacts, they had any symptoms of cough, cold, sore throat or fever, then if they are a close contact of Nipah case, they would be suspected Nipah. But when we have screened these cases, 12 of the close contacts were positive for SARS-CoV-2 and all were infected mainly by Delta variant. Again, 102 bats were sampled from the 4 sites of epicenter of this outbreak, and IgG positivity were reported in 21% in the Pteropus bats. And this time, for the first time, we could see the positivity in Rausetus bats, which is almost around 38.4%. The phylogenetic analysis of this outbreak strain, it resembles similar to the 2018 and 19 outbreaks, and it matched with the previous Kerala outbreak. If we see this figure here, there is something mentioned as a Bangladesh strain, Malaysian strain, and slightly different is all our 2019 and 2021 outbreak strain, which is now labeled as an I strain, that is Indian strain, because it is clustering. Even if it clustered with Bangladesh, it has slightly different sequences, and hence a separate nomenclature has been given as I genotype to the outbreaks, to the sequences in 2019 and 21. Enhanced capacity building was done by the team from NIV Pune, and the bat sampling which were discussed previously. First time NIV could do the Nipah PRNT test, and amongst the Pteropus medius bats, positivity 3 by 3 bats shows the PRNT positivity. A high-level expert committee under the guidance of Dr. V. Ravi, Dr. Morekar, and Director Dr. Priya Abraham Madam. It was set up, and these AES algorithm previously didn't included Nipah virus screening. This AES algorithm were modified, and now Nipah IgM at district level and at regional referral level, referral lab level, Nipah TrueNat and Nipah IgM both were now included under the AES algorithm, so that none of the Nipah cases will be missed in future during the screening process. Similarly, the DCGI has approved TrueNat as for the emergency use approval for Nipah virus diagnosis in 2021 outbreak. So, till today in 2018, 2019 or 2021 outbreak, the credit goes to the huge teamwork from not only from the ICMR NIV Pune, but from the Kerala state government, the IDSP, the public health officials, the central team, the experts from the AIMS, and from all the hospitals, the private or the government which were involved in the Nipah virus outbreak. So, few challenges which were faced during Nipah outbreak in 2021 because of the ongoing COVID-19 second wave. As discussed earlier, there was similar presentation of Nipah and the COVID, which made the diagnosis difficult and challenging. The isolation of Nipah case versus COVID-19 become a very critical scene because we need to have a different isolation facility for Nipah as well as for COVID-19, which has added the burden to the health system in GMC Kozhikode. Most of the close contacts were COVID-19 positive. Shipment of samples were challenging to the Apex lab considering the ongoing pandemic and the lockdowns which were there. Most of the laboratory workers were COVID-19 infected. They were in isolation, some were in quarantine. So with less staff, most of the work were undertaken. The algorithm of AES were changed in this outbreak in 2021. The healthcare workers, the reduced availability of beds, ventilators in the hospital considering the ongoing second wave of COVID-19, then and during 2021 outbreak, made it is more difficult for all the physicians to deal the Nipah virus cases. And of course, the devastating second wave added with the Nipah outbreak created huge outrage, fear and chaos amongst the community. Even with all these challenges, we could really work out very well. And I congratulate all the team from Kerala for doing the excellent work. And with just one case, the 2021 outbreak was over. The NIV being the Apex lab, the BSL4 being the Apex lab for handling all the high-risk viral pathogen. The major role was to do all these studies and to understand the source of infection, to understand the strain which is getting which is circulating right now. All these studies been done at NIV. And just to brief everyone, now ICMR is ready with the mobile BSL-3 facility, which can be now be utilized for such kind of outbreak scenarios in which when we face the challenges of shipment of samples and the facility for establishment of the labs, this kind of mobile laboratories will be really helpful and can be taken up till the field level. So we acknowledge the efforts and the support from the ICMR headquarters, from our Secretary DHR and DG ICMR, our ECD chief. We acknowledge the support from the Kerala Public Health and all the hospitals, the dedicated team from ICMR NIV Pune and ICMR Kerala unit, collaboration from the Mole Biodiagnostics and the grants which we receive for this training. I request Madam to add if I have missed some points. Thank you.
Thank you, Dr. Rima. And I'm sorry I could not present because I am traveling and there was a network. Dr. Rima has covered all of the aspects, except I would like to add that the recent in 2021, we found positivity in Rousetter species which was not reported earlier from Kerala. In 2020 also, we found positivity in Raucetus species and Pepis species from Maharashtra state. And in the same site, we are doing survey for bat from 2009, and which really make us think that ecology of bats and susceptibility to Nipah is changing, and that may we need to also look at other species and birds in Kerala in future for the surveillance to understand if there is a more reservoir. The next point I also like to emphasize that we should have a containment facility as early as possible in Kerala so we can handle such pathogenic viruses and the response can be given faster. The third and most important, after the virus isolation from the 2018, we could develop indigenous ELISA and testing system, but we are still struggling with the therapy and we don't have any right antivirals or vaccine, and vaccine should be our priority where we can use for high risk population and that can protect lives in future. These are the few of the points, and I would also request the state, forest, and also rest of the people to come forward and work with us so that we can establish the seasonality of bat in Kerala state and we fast track. I understand very well because of COVID, we everybody got busy in the response, but we can restart, reinitiate this work, and we can understand how the seasonality is going to challenge. And if we can establish that, maybe we can have the more proactive surveillance in hospital where we have AES or ARDS cases in that particular time period. Not only the Kerala, but in other states where we are seeing the hotspot in bats. And I'm very sure the kind of leadership and the proactive approach state government, Dr. Rajan Khobragade, Honorable Health Minister, and everyone from the state has shown that will be a very good learning from rest of the state in country where there will be problem in coming time in future in India. Thank you so much for giving opportunity to us. If there is any question, we will be happy to answer.
Thank you, Dr. Rima and Dr. Pragya, for that really valuable session. Next, we have with us the very talented Mr. Udayan Edapal, who's going to mesmerize us with his beautiful sand art. He's going to dedicate this piece of work to all those who work day in and day out to protect us from this deadly disease.
Book. Close it. Mr. Udayan Adapal is about to start his piece dedicated to the Nipah disease in Kerala. Let's watch and observe his painting.
Thank you, Mr. Udain Edapal, for mesmerizing and taking our breaths away with your beautiful artwork. Moving on to session 6 for today's workshop, that is the District Action Plan Preparation. This session will be moderated by Dr. V.R. Rajendran, former Principal, Government Medical College, Kozhikode, Dr. Anish T.S., Government Medical College, Manjeri, and by Dr. V. Meenakshi, ADHS Public Health. Speakers, please note 3 minutes is allotted to each group for their presentation. I repeat, 3 minutes is allotted for each presenter from each group. I invite the moderators onto the dais. All teams, please note, do send your action plan as a report. The presenter for team 1, please do come onto the dais for your presentation. The topic for team 1 was identification of the outbreak. All teams are requested to send their report to the email ID nipahworkshopkkd@gmail.com as a report within 1 week.
Good evening all. The topic presented to us was identification of an outbreak. We represent 3 districts, Idukki, Pathanamthitta and Kottayam. Identification of outbreak, we usually get the data from our IDSP and also the PEDCEL data. We look into the data and see whether there is an increased number of cases, whether there is an age shift of cases, increased number of cases with respect to the previous year data and also the previous month data and also previous week data. And in case of Nipah, whether there is any AES cases with clinical features of fever and fever with altered sensorium. Then coming to the casualty or in the OPD, then there is, if there is any clustering of cases or whether any epidemiological linkage of cases from a particular area, whether there is any unusual deaths, whether there is any reports from the social media or from the rumor register or any unusual events. In case of KFD, whether there is any monkey deaths happening in the area, whether in case of Zika, whether there is an increased number of microcephaly cases reported, and also from social media, also sometimes we get the indicators of an outbreak. As soon as the outbreak is reported, outbreak is identified, we report first to our district IDSP cell, then from there to the state IDSP cell, and appropriate action is taken at the level of the institution and also at the district level and also at the state level.
Hello. So I think first in this regard is the suspect the case. Identification of case means you have to suspect the presentation usually was in the encephalitiform or the RDS pattern. So any patient coming to the casualty, you have to suspect. That is the importance of what we studied during the Nipah period.
Actually, the diseases like Nipah and also the previously it was said that the avian influenza, human avian influenza, then Ebola, these diseases are yet to come to our state, no? But it can happen at any time. So the surveillance is the backbone of every disease for early detection and also prompt action. So in that point of view, in the current context of the COVID pandemic, we have a lot of labs which were equipped with all these testing facilities, especially the PCR facilities, and also the only thing we need is the early index of suspicion among the doctors and also the public health point of view. If there is any, as you are telling, any clustering of cases from an area or that kind of. The most important thing is AS surveillance, acute encephalitis surveillance, which is happen to be there in all major hospitals, because all these cases will land up in major hospitals only. So that is the thing.
I invite Dr. Arun Zakria, Chief Forest Veterinary Officer, to join the moderators on the dais. Thank you, presenter of Team 1. I now invite the presenter of Team 2 to present their report. The topic given to them was Nipah surveillance.
We were given the topic surveillance. So during the pre-outbreak period, we have a inbuilt routine surveillance system. So through that routine surveillance system, hospital-based AES or ARDS reports are daily taken from both the government and private hospitals. Daily reporting of hospital-based AES or ARDS surveillance is done, and the collected data is checked for completeness, and also the reporting, the AES surveillance reporting should be regular and timely. Then also, if there are any hotspots identified in previous outbreaks, in those hotspots, surveillance activities are augmented. And if there is any increase, and we will check for any increase in the number of any suspected or cases. If there is any suspected or confirmed cases, we will isolate the patient, and the control activities are initiated, like formulating an appropriate case definitions for probable confirmed suspected cases, and active case search is done, and for index cases and contacts. And contact surveillance in the context of family, hospitals, and community is undertaken. Then the primary contacts and secondary contacts are kept in quarantine. Primary contacts are kept for 21 days, and when they are symptomatic, they are tested. Then in fever surveillance is also intensified in the field. Then as part of intersectoral coordination, with the help of Animal Husbandry Department, the measures are taken to identify the source of infection. If there is any clustering of cases, containment zone surveillance activities are taken.
Thank you, madam. Surveillance, basically we are speaking about surveillance of human cases. Definitely that is very, very important. But I think we have to concentrate on the animal surveillance also. Domestic animals as well as bats. Because if you look at the scenario of Nipah in Kerala, we can notice that there is only 3 instances of spillover. Even if there is 25 cases or 26 cases are there, the spillover is only 3 instances that we documented. 2 of them were in Kozhikode and 1 is in Ernakulam. And from both these districts, NIV people were able to identify positive bats. According to Pragya Madam's presentation, in Ernakulam, IgG positivity was demonstrated, but in Kozhikode, even live viruses, viral RNA was also demonstrated. That means maybe almost entire Kerala, the positive bats may be there. In Calicut, the second episode may be because it is Calicut, and Calicut faced the first episode, and we were, in Calicut, people were maybe more vigilant. That may be the reason that Calicut was actually identified the second instance also. So it is actually a threat for entire Kerala, and we have to go for a geospatial mapping of positive bats where it is concentrated in some localities. In some localities, it may not be there. What kind of behaviors of people are lead to this kind of spillover? These things are very, very important. I think we have to go for an on-health approach also. These things are very, very important. We have to concentrate on human beings. That is utmost important. But definitely we have to go for other distal determinants of Nipah outbreak in Kerala also. Because these things will help us to contain outbreaks, but our basic surveillance activities will not prevent outbreaks. To prevent outbreak, definitely we have to concentrate on the natural reservoirs of viruses. That is very important. I think I'm happy that Sir is there, and I am happy to hear from him.
Thank you, sir. The main problem is that viral titer in bats is very, very low. That's the main issue. That's why most of the time we have to euthanize, sacrifice the bat and collect the samples. And in that process, there is NIV is insisting it should be done in NIV. But here, we have to do a longitudinal surveillance program, and using newly developed antigen and IgM simple lateral flow ELISA, so which can, I think it's already been developed, I think. So such kind of a longitudinal survey, because we are all doing the cross-sectional surveys and you get the bad population ruse, the problem that they shift. They frequently shift, they divide sometimes. So that kind of one-time data may not be sufficient. Maintain a baseline data and continuous longitudinal surveillance and see the bat. If any positive there, action should be taken, like containment of that area, and some sort of protocols has to be developed. Especially water, today morning tool, water body has to be monitored, or it should not be used like that, or confinement and the kind of area. Such kind of practice would be sufficient.
Thank you very much to the presenters for that excellent presentation. Now we have Team 3 with the topic infrastructure. I invite the members of Team 3 onto the stage.
Good evening, respected dignitaries. Good evening all. So after getting the data from the district surveillance team, so we got the exact figure of how many cases that we had in our district, and of that, how many cases are the confirmed cases and the next probable cases. And with the help of the surveillance team, we will get an exact number of how many is the actual contact. Primary contact that we have traced from the surveillance stream. So based on that data, in the district itself, we will form an infrastructure committee with the help of the district administration and with the health department and the other supporting department. So with the data, we will identify the infrastructure capacity of the district, and we will identify the exact which hospital that we need to be chosen for the isolation facility arrangement and isolation facility arrangement for these probable cases. And for the confirmed cases, definitely it will be the tertiary care center. So there is the medical college itself in the district. So in the medical college itself, we will ensure the tertiary care facility, including the medical ICU facility, and also the supporting staff, the supporting doctors, the supporting equipments, including the oxygen support, the instruments, the drugs, consumables, and the point of care services, including the portable units of lab, ECG, and X-rays. And regarding the isolation facility arranged in the particular district, we will identify one particular taluk level hospital for setting up of an isolation area. So we will choose the room-based isolation. So we will try to choose a room-based facility available in the taluk level hospital. Maybe it's a pay ward. So we will choose one building of pay ward said to be an isolation building, and we will try to isolate the probable cases in that particular area. Along with that, we will have the exact number of how many are the total contact cases that we have in the corresponding district based on this index cases. So we will try to identify the exact location of this contact, this primary contact, and ensure the isolation, home isolation of this contact. And regarding the contact persons, we will also identify the area of the places and the particular medical officer who is in charge of the area regarding these cases to ensure the quarantine and isolation of the particular case. And also we will try to arrange the ambulance facilities. We will try to consolidate the total data of the ambulance facilities available in the district and the places, which all places that ambulance are located, and we will try to form a nodal person who is in taking care of this transportation and logistics. and with the infrastructure arranged at the medical college facility and also the taluk level hospital facility, we need an infrastructure management committee also, so that along with the help of the district administration regarding the finance for the daily need of the patients, their food, their daily activities, and also for the waste generation, also the biomedical waste and the other general waste formed during the isolation of the hospital. So for all these things, we will form a control unit at the district level to coordinate all these kind of infrastructure activities, including the daily monitoring of patient flow, the IP rate, the consumables, the drugs, and all these things. And we will review on a daily basis regarding the number of cases who are at the quarantine, and those who are in quarantine, how any kind of symptoms may be mobilized to the primary care taluk level hospitals, or from there to the tertiary level. So we will have a regular daily base analysis of the occupancy of the infrastructure occupancy and the vacancy of the corresponding identified places. So once the medical college facility is its occupancy is exhausted to 30% of the load, and also the taluk level hospitals the occupancy exceeds more than 50%, we will try to identify another hospitals also to be engaged as an isolation. So regarding that, first we will consider taluk level hospitals, and we will try to run other general level hospitals or district level hospital to run the daily activities. Initially we will try to mobilize only one hospital of the district. Regarding that, thank you.
Okay. So everyone knows that was a medical emergency period, and the infrastructure as such, the day when the minister contacted us, it was really, we were so pathetic, because we don't know exactly how to manage the patients. But luckily, I think Dr. Devadas, he is a public health from Bangalore. His direction as well as the central team came and they directed us in a proper way. Luckily, we have a payaward, KHRWS payaward, that is converted into various layers according to the suspicious contact like that, and there was ICU also. And likewise, the infrastructure, other infrastructure also managed, because various teams were formed to arrange these things. The logistic, even the central government provided a lot of PPE kit and the mask. So infrastructure, everything was arranged. Luckily, after that, our state government also sanctioned an isolation block to Kozhikode and Trivandrum Medical College with an expense of around 80 plus 20, 100 CR. So that area, we now that was taken, SP was planning to start the work, but this was sanctioned as because of the Nipah. But we will utilize that area for not only to the Nipah, we can use that area for the pandemic, various epidemics. Also, other time, we can use that area, even for the mass, any traffic accidents. We can use that area if there is no pandemic or the infection is as such. That is the plan. And because of the COVID, we got an isolation ward as such. Okay.
Actually, infrastructure and logistics will go hand in hand, and we should learn from our experience. Actually, all the districts should have there should be infrastructure facility for not only for treatment, it is for testing, isolation, quarantine, everything we have to be prepared, and we should have that facilities in each and every districts. Usually in every emergencies we used to get the treatment facility from our medical colleges. But peripheral hospitals also should be equipped so that the right care for the right person. We'll trace the cases according to the severity and other parameters. So the critically ill patient should be there in the well-equipped hospital like medical college, or the other less severe patients who can be managed at secondary care level, or even below that, they have to be there. So that kind of preparedness and planning should be there in all districts.
We often build the infrastructure after the outbreak is set in. But I think we have to look into the infrastructural matters even before the outbreak. Because Nipah usually present as encephalitis, ARDS, and with maybe some other complications. But among these presentation, ARDS is the most important thing in a public health point of view. Because if a person is presenting with ARDS, the chance of contamination, the chance of infection spread to others will be much more. So in Bangladesh type of Nipah that is there in Kerala, the ARDS kind of presentation is very prominent. So whenever a patient is presenting to you with ARDS, you have to be very much concerned about the infrastructure. One thing is we have to communicate the bystander, to take this case very seriously, because in IEC, you have to mention that they have to wear masks, or they have to keep their hands clean and all other things. If that kind of a patient is there in your hospital, better don't send them for investigation. Let the investigation team should come them and collect samples, and all these things are very important. If these people are sent to maybe for CT scan, or these people are sent to some labs, sometimes there will be large kind of contamination and maybe lead to a large outbreak. That may be what happened in Calicut in 2018. That is one thing. Another thing is, if these patients are kept in rooms like ICUs, even if it is not detected as Nipah, we have to have our own separate facilities for patients presenting with ARDS, because there may be, in Calicut also, we have got an experience that in ICU there is a cross-contamination. So these things are syndromic. Even if there is no evidence, or if there is conclusive evidence that it is Nipah, all ARDS cases should be considered as there is a potential case of Nipah, and we have to change the infrastructural arrangement so that there will be no human-to-human transmission. That is a very important thing, I think.
Thank you very much for that presentation. Before moving on to the next presentation, I'd like to invite Dr. Kalpana George, the Associate Professor of Microbiology at Calicut Medical College, to join the moderators on the dais. I'd like to invite team number 4 to present on the topic of setting up of a laboratory.
Good evening. Our action plan was prepared based on to establish a lab surveillance system. So we prepared 2 objectives. The primary objective, or a long-term objective of the action plan, is to establish a continuous lab surveillance system for early identification of new or emerging diseases. And our secondary or short-term objectives are like establishing regional public health labs in all the districts, and upgrading of facilities in existing laboratories in the MCH to VRDL status, and sustainable system for collection and transportation of samples from the periphery to the medical college labs or the regional public health labs. Also, strengthening of the sub-district labs. And existing facilities in the state we have assessed. In the existing system, some centers like Taluk hospitals and some districts have CBNAT facilities, TrueNAT facilities, and PCR. It's not a standardized system, it's not a uniform thing. And as of now, the collection is done at peripheral levels like FHCs and CHCs, and the collection is done by lab technician or doctor, and it is packed by nursing assistants and transported by own system, that peripheral institute system only, and the expense is bared by the peripheral institutes. And there's a portal for, as of now, there's a portal for COVID system that LDMS is there. So the strategies to improve that, we have to identify infrastructures, and adequately trained manpower should be available in all the levels. like in the periphery for sample collection and as well as transportation. And in the hubs, we have to identify qualified people like MD microbiology and other specialty people for handling the sample diagnostic techniques. And also, we have to ensure the waste management system in all the levels. And we need to establish a district nodal person, which may be DLT or junior scientific officer, and other nodal persons may be identified at taluk levels, so that a hub and spoke model of lab surveillance, in which we can collect the samples at the periphery and transport to the taluk level labs or district level labs for identification may be established. And all these system has to be linked with, which is ideally to be linked with LDMS system. LDMS is, as of now, it can handle only COVID cases, but if we include other diseases into the system, and if we are able to push the data into the IHIP portal, the surveillance system can be easily monitored using the computer management HMIS system. So identification of clustering of cases and in temporally or geographical clustering of this cases can be very easily done. And we have to establish a data sharing system with other departments, including veterinary, forestry, fisheries departments, so that they can also take part in the monitoring of diseases through the labs. And we need to establish a monitoring committee for the implementation of the action plan at the district level, which may be constituted including district collector, DMO, and other financial officer, etc., so that we can conduct regular monitoring meetings at 3 months. Concurrent evaluation as well as consecutive evaluation may be done. Thank you.
Thank you. About your topic was lab surveillance system. Surveillance is not during the outbreak.
No.
It has to be a constant thing. We have a good example of surveillance happening with NACO, the National AIDS Control Organization. They carry out regular surveillance of hepatitis B, hepatitis C, HIV, which is happening regularly. So when we talk about, I think that can be extrapolated for other diseases too, like these dangerous pathogens, where we can use the lab facilities wherever is possible for constant or periodic surveillance, for which we need the health authorities to make a definite plan on how frequently the samples has to be collected, from where the samples should reach the laboratory, and it cannot be done all over Kerala. Like it has to be the surveillance has to be carried out only at specific centers. At least that should be very clear. I think that is all I have to add.
Actually, we have for vector-borne disease like dengue, chikungunya, we have the Sentinel Surveillance Lab system. We have 38 labs, including the State Public Health Lab, which is considered as the Apex Referral Lab. So in these 38 labs means every district there will be 2 or 3 labs. In some districts more than 3 labs were there. And in these labs, the NS1, for dengue, NS1 ELISA facility, then IgM ELISA facility is also there. For chikungunya, the MAC ELISA facility is there. So dengue and chikungunya will be confirmed in these labs. These labs are mainly the public health lab, then the microbiology lab of Government Medical College, and also some major hospital lab, district hospital. In Ernakulam, 2 UPHC labs are also selected as the Sentinel labs. So like that, every district there is facilities there, but this iron testing lab should not be there in all institutions. So for that, some region-wise or for 2 or 3 districts, there should be one lab. We have VRDL lab in all major government medical colleges, so that can be utilized for this high-end especially the AES cases and all, their sample can be tested in these labs. And also, actually our Principal Secretary has assured that the 15th Finance Commission grant will be utilized for strengthening the laboratory surveillance. So we are expecting that to happen.
Thank you, Team 4 presenter. A kind reminder for the delegates, I request that no one should leave as there would be the group photo after this session.
Now, I invite members of Team 5 to present on the topic of sample collection from humans and animals.
Good evening all. So we are moving to the action plan for sample collection from humans and animals. So at this moment, I want to emphasize again and again that we are discussing and we are cooperating the One Health policy, which we are included both humans, animals and nature in our sample collection, treatment and follow-up. So the collection of samples from both humans and animals are equally important in this scenario. So we are taking acute encephalitis syndrome as a prototype for our sample collection. So as earlier said, every AES case should be moving to the secondary or tertiary care centers for admission. So there should be a facility to collect sample from an AES case at the first point of contact or case. That is the most important point that is needed. And at the time of sample collection, we are planning to collect samples for detecting an array of diseases or a group of diseases, because we can't approach a patient for multiple times because he is more contagious. There is a chance of more deadly contagious disease. So we are collecting samples together for an array of diseases, and these samples are classified. First, we should test for the most common diseases which are present according to the endemic area. And the further samples will be kept back, and if the most common diseases are tested negative, we can move to the second step of samples for the second group of diseases. And these diseases, the testing of diseases and the samples should be classified as at the institutional levels, at the regional levels, and at the state or national levels, just like our NIVs. For example, at the institutional level, we can check for dengue fever, leptospirosis, where these diseases can present as AES. And at the regional level, we can test for this our Nipah virus, Handa virus, influenza virus, etc. And at the NIV levels, we can check for the Ebola virus, which is the most rare conditions. And moving to the sample collection, we should have a SOP, that is the standard operating procedure. And this standard operating procedure should emphasize whom to collect the sample, when to collect the sample, how to collect the samples, what all precautions should the collector attain, including the personal protection equipments, then which specimens should be collected like blood, CSF, urine and throat swab, then how much quantity of samples to be collected. For example, blood 5 ml sample, for urine 10 to 12 ml of sample, and conditions for transport of the samples, because the transportation is a very important part for sample collection, and transportation system should end in a proper contact person to collect the sample. And after testing, the most important point is to proper waste disposal. It is also part of the sample collection. Along with that, we need the strengthening of labs at the various levels, at the institutional levels, at the regional levels, and at the national or state levels. And proper sample requisition form is also important, because we are using these samples in the later part when we are testing negative for the most common diseases. So the proper requisition form must be filled at the first contact itself. Coming to the present scenario, we have a lot of infrastructure and a lot of machines for our COVID testing. And when this COVID is coming under to control, we can use these machineries for further disease testing and diagnosing. And linking with these local labs with the local government authorities can strengthen the labs for funding, and it can also involve the local community medicine people to follow up the contact persons. For primary contact persons, we can keep them in isolation in our isolation centers and collect the samples by this prospect. And for the secondary contact persons, if they are developing any symptoms, we can shift that patients or that persons to the isolation center and can collect the sample. That is the sample collection part from the humans. When we are diagnosing a zoonotic disease, the second most part is the sample collection from animals to find out the source, and it should be just elaborated by Dr. Annie.
Good evening all. So coming to the sample collection in the case of animals, if a human zoonotic disease is confirmed, we have at the district level animal disease control project. So under which a team will be sent to the particular area, and within the 1 kilometer epicenter radius, we will collect all the possible domestic animal samples. And if a wild animal spillover is suspected, then we will also go for the wild animal sample collection with proper consent from the authorities. And if wild animal darting is needed, that will also be done. Just mentioning the veterinary labs at the district levels, we have regional disease diagnosis laboratory which is located in Kannur. And for avian cases, we have avian disease diagnosis laboratory which is located at Tiruvalla. And we also have state animal disease laboratory which is located at Palot, Trivandrum. And if the results are not, means if we are not confirming the case from the labs that are available at the state level, we have Nihsad which is located at Bhopal. We have confirmed the Nipah and HPI cases at Bhopal and Nihsad. And regarding the sample collection or how the samples that are collected in the case of animals, for birds we will go for the dead birds, and we will also collect the cloacal swabs in the case of birds. And in the case of small animals, that means goats, pet animals, etc., we will go for the throat swab collection. Thank you.
See, regarding the animal sample collection, there are two objectives. One is surveillance. Second is identify the, when there is an outbreak occurs, then how many animals are exposed to, and could they be carriers? So most of the cases in the pigs, they are asymptomatic in most of the cases. So that you have to see. So in bats, for the surveillance, best sample is urine. So you can do it non-invasively. You don't have to capture the animal. Lots of work. The problem is that transportation. The viral load would be very less, and you can just put a sheet and you can collect the urine. Such kind of surveillance can be done, and the mapping can be prepared. A GPS data sheet can be prepared and handed over to health department, and they can use it as, so to identify the location where the virus is prevalent, and also back tracing, which is very difficult because bats travels a lot. So health department can use it. Thank you.
They have included almost all points, very well presented. And there are the sample transportation. We have good examples in front of us. Ernakulam, they have a hub and spoke model for this transportation sample, and also in the context of COVID, in most of the districts, as per the guidelines, they have collected samples and transported it in time without any contamination and all. So that practices we can follow up in the coming years also. As I said, preparedness, planning, that is very important in the case of any emergency. Will be that is the Kerala model, all are saying. So that we have to follow. Thank you.
Thank you, presenters of Team 5. I now invite presenters of Team 6. The topic given to them was IEC training. We have come to the conclusion of this session. I now invite Dr. Naveen to present a small token of appreciation to Mr. Udain Edapal for mesmerizing us with his beautiful sand art. I invite Dr. Naveen and Mr. Udayan onto the dais. Thank you, moderators, for that really insightful and knowledgeable session. I now invite the delegates onto the stage for the group photograph. I repeat, I invite all the delegates onto the dais for the group photograph.
You are right, credential. Ready? Ready? Set ആവണേ എല്ലാരും. ക്യാമറ വരുമ്പോൾ ഓക്കെ ചാമ്പിക്കോ. വേണ്ട ഒരു ആക്ഷൻ
എല്ലാ ഡെലിഗേറ്റ്സിനും കോഴിക്കോട് ഹെൽത്ത് ഡിപ്പാർട്ട്മെൻറ്റിൻ്റെ പേരിലും നാഷണൽ ഹെൽത്ത് മിഷൻ്റെ പേരിലും നന്ദി രേഖപ്പെടുത്തുന്നു. നിപ്പയുടെ ഇതൊരു CME മോഡലാണ്. ഇനിയും വേറെ ജില്ലകളിൽ വെച്ച് മെഡിക്കൽ CMEs നടക്കുന്നതായിരിക്കും. എല്ലാവർക്കും ഒരിക്കൽ കൂടി നന്ദി പറഞ്ഞുകൊണ്ട് ഇന്നത്തെ ഈ ഒരു കോൺഫറൻസ് അവസാനിച്ചതായി അറിയിക്കുന്നു. താങ്ക് യു ഓൾ. റെയിൽവേ സ്റ്റേഷനിലേക്ക് ഇവിടെ നിന്നൊരു വണ്ടി അറേഞ്ച് ചെയ്തിട്ടുണ്ട്. അപ്പോൾ റെയിൽവേ സ്റ്റേഷനിലേക്ക് പോകുന്ന ആൾക്കാർ മുന്നിൽ ഗ്യാദർ ചെയ്യാം.